We will prepare you for the IBSC board exam, but more importantly, we want to make you better clinicians and raise the standard of care, more importantly. Okay. So our course overview, Chief Stewart already kind of went through the expectations in your syllabus. Just read that over. Certainly don't have to read it word for word, but as you go over that tonight, just make sure you have a minute to go over the expectations and stuff.
Does anybody have any questions on the syllabus? The syllabus is the class schedule. That we didn't cover that yet. So has everybody got that? Okay.
And that's pretty self-explanatory.
Huh?
That's pretty self-explanatory.
Yeah. Just want to show some questions. Everything's clearly on there. If something changes to that, we'll obviously let you know, but all the testing dates are on there. Study halls are on there.
The other thing is that course manual that you received, and make sure it says fall 2025 on there. That should be the most updated one. They have this course manual, right, Chief Stewart?
That's the handbook.
That's the handbook.
Yeah,
They've got the handbook. Yep. So you all are adults. We're not going to read the handbook line by line, but there's a lot of information there. You got to know it. So just go through that this evening sometime. Make sure that if you have any questions, bring it back. Okay. We have quite a bit of expectation from you, to be honest with you. But you have a lot that you can expect from us as well. As instructors, you can expect from us that we care, because we really do. We care about meeting your needs. We've heard what you're here for, why you chose to take this class. We know that you want instructors that are knowledgeable, that arrive prepared, and that seek your success. But at the same time, we have a lot of expectations from you as well. We want you to be self-motivated. This is not like any other class where you can maybe show up and follow along in the handouts, and as long as you do that, you're going to be fine. The handouts are only the highlights of stuff that you need to know. There's way too much stuff to go over in class that you have to then make up for in the textbook. So your chances of passing are substantially higher if you actually open your text and go through that as well to kind of fill in any gaps that may be to answer questions of the highlights portion of the notes. Does that make sense? So, but you got to be self-motivated. No one's going to go home with you and make sure that you actually go over the notes again and the textbook and do your homework. Only you can do that, all right? So we want you to be self-motivated. That's why we have 6 days in between classes, because honestly, the other 6 days, you really do have to be preparing for understanding what you just had on the day of the class today, and then what's upcoming for the next week's class. And on that syllabus, it'll tell you what's upcoming. If there happens to be any changes, we'll certainly let you know the week before. But going over that beforehand, this is one of those things that you'll have to prep before class to really succeed in this class. That's part of arriving prepared, because for every hour in class, you'll have to spend at least 2, sometimes 3, depending on the topic, outside of class studying the material. When we looked over this course last year, did a comprehensive assessment of the material and hours, this equates to a semester level college course, science, probably a 300 level science class in college, okay? So it's legit, and you'll have to spend the time concurrently like you would any semester long course in college, a 300 level science course in college, right? We will therefore want you to use multiple strategies to succeed. We will have study halls. You'll have these recordings to watch. You'll get I think it's a private link to these recordings. It's not public. So you'll get to watch the recordings again. You got your notes, of course. You've got your textbook. You've got office time with any of the instructors. Plenty of strategies for you to get through all of this material. So we're going to give you multiple ways to succeed. If you put in the time and choose a pathway to succeed, you're going to be just fine. So all these things, so you've got expectations from us, we've got expectations from you, and I think you follow that, you'll be successful. Is that fair enough? Cool. All right. So some quick highlights for today's morning session. We're going to go over highlights from 4 chapters, 1, 2, 3, and 20. Definitely don't have time to go through all 4 in detail, but we're going to just pull out some of the things that we often see on the IBSC exam. Remember, this course is preparing you to pass the board certification exam, but more importantly, we want you to be better clinicians, raise the standard of care, improve patient outcomes. But for purposes of the exam is kind of where the lecture portion tries to highlight. We also go over material in lecture that tends to be problematic. Like when we go through Krebs cycle and oxidative phosphorylation this afternoon, that benefits from some face time, some one-on-one time that augments your textbook reading. But other things like HIPAA and EMTALA, we'll hit a couple of test question type stuff, but that's all stuff you can read on your own. Okay, and we expect you to read on your own. So we'll go through that in 1, 2, 3, and 20. We will do our patient assessment. The other thing is lab values. That also will need some face time, and so we'll do that in person, a lot of that in person. So we'll save our in-depth stuff for that kind of thing. A lot of test questions on kind of assessment strategies, but also clinically. I think we could be a little bit more detailed in how we do patient assessments, especially in critical care. So we'll spend some time on that and then spend more time on lab values, okay? So I know that's a lot of material. You guys ready to jump in? All right, let's jump in. Chapter 1 overview for intro and overview of CCT. Is a critical transport service line required? Do ambulance services have to have a critical care transport service line? Yes or no? No, it is not required. In fact, having a single resource service line costs us money. It's quite expensive if you look at how much it costs to pay, to train, to credential, to maintain, to have a separate set of protocols, because our critical care personnel have protocols that are different from the road. An advanced formulary skill set, that is expensive, and it takes a lot of time, energy, and money to run a service line. So then, why do so many agencies want a critical care service line? Why do you think they want a service line? Why does Abbott have SCT? Why do we have 9664? Well, it is cool. I mean, chicks dig it, for sure.
They want better medics.
They want better medics. That's a good one. What else? Better patient outcomes. There's my cynic in the room. I always have to wait for who that is, because they just want some dang money, that's all. He's not lying. You definitely can, right? There's BLS 1 and 2 billables, ALS 1 and 2 billables, and then there's SCT. People thought Abbott came up with specialty care transport SCT. No, it's straight out of the CMS manual. That's a level of billing, okay? Interestingly enough, CMS doesn't define SCT billing as done by an SCT or critical care service line. It just has to be done by paramedics who the medical director certifies as having a level of knowledge and training above a usual and customary paramedic. Did you know that? That is all you need to bill CMS at the SCT level. Is ventilator management routinely taught in paramedic school? No, it is not. So every time you go through our vent class here and you get trained up in the Hamilton vent, you now are a paramedic who has training above and beyond the knowledge of a standard, usual, customary paramedic. That makes you eligible. I'm sorry?
Same with the Sapphires too then.
Yeah, Sapphire pump. All the training you get in your new employee orientation, that makes you above and beyond a normal paramedic. So you don't have to be 9664 to bill at the critical care level. In fact, we have ground ambulance crews all the time that are doing critical care transports because we either don't have a 64 resource available or it didn't come out as one, but they still did it anyway. They had a routine vent transfer that didn't need a critical care paramedic. We can still bill at the critical care level. So it isn't just for billing, although you could. It truly is because it provides a more consistent product for our patients, which means better outcomes, better services. And frankly, it also takes a lot of the angst and anxiety off of our ambulance crews, our typical road crews. My experience at Abbott is the same that is here at SCCAD, in that when a usual and customary ALS crew arrives at the hospital for a patient who's on multiple drips and on the vent with lots of chest tubes and all that stuff, that's nerve-wracking. And it's a long distance transfer especially, or one that's gonna take 30 to 45 minutes, that's nerve-wracking. They breathe a sigh of relief when the critical care medic gets there. And SCCAD has been no different. When 9664 shows up, you can tell there's a kind of anxiety kind of drops a little bit with the road crew because they know they've got help, and the 64 medic is accustomed to these kinds of calls, and they can be there as a resource for them. That's how I want all of you to be when you're out there at 64, able to take that anxiety level down. It's all about providing a great service. And here at SCCAD, 906064 is what we call our single resource medic. They don't respond in an ambulance, they respond in their own SUV. They can self-dispatch to certain calls, at least I want them to. We have crews that can ask for them specifically because they bring another level of critical care decision making that they're used to. They also bring other resources. They'll have their ultrasound, their point of care ultrasound with them. Sometimes they'll have other meds and interventions that the usual and customary road crew does not have. But the way we do it here at SCCAD is, as a critical care single resource, they can get dispatched automatically with a crew to a high risk critical care transfer, interfacility transfer, right off the bat. Sometimes they'll get there and they'll be like, this is not a critical care. I'm going to put myself back in service and this crew can handle it. But sometimes they're like, yeah, legit, this is going to be bad. And they will then park their truck and just get in the back of the ambulance with the crew and take them to wherever they're going as a single resource, just to help that crew out and, more importantly, help bridge the gap between one hospital and another for patient care. And that's another way that you can think of yourselves as a critical care medic, is you are trying to make that seamless transition of care, either from the emergency department or maybe the ICU to in the intensive care. Remember, for those IFTs or interfacility transfers, this patient is too sick for that doctor. This patient is too sick for that hospital. So that's a huge burden on you. That's a huge weight on you to give that seamless transition of care from one hospital to another. And that is incredibly important for that patient especially. Now, you may have some test questions that talk about modes of transportation, and really all you need to know is that when it comes to about a 50-mile-ish radius, the typical mode of transportation is going to be a ground ambulance service, and that's fine. These are some examples of ground ambulance critical care trucks. A lot of times, what's really frustrating is that in Missouri especially, there is no law that says when you can or cannot put critical care on the side of your ambulance. You know, I know for a fact that there was a local company in St. Louis that put critical care ambulance on the side of their truck, and when we asked them, so what makes this a critical care ambulance? Do you have different stuff? No. Do you have different meds? No. Are you trained any differently from any other paramedic? No. Really? Yep. And that's not against the law. I think it's unethical. I think it's pretty shady, but it's not against the law, so they did it. Okay. But here at SCCAD, it very much means something when it says critical care. That is someone who has been trained and credentialed at a different level, and they absolutely serve a different purpose than a usual and customary road paramedic. Okay? Same with most of these other places as well. Now, once you start going out to 150 miles, the mode of transportation is going to be a rotor air ambulance. Now, there's two divisions to air ambulances. There's rotor wing, or helicopter, and fixed wing for airplanes. Okay, so for rotor wing air ambulances, typically out to 150 miles or so. And really, if you're just familiar with the different platforms, I think that's really all you need to know. For example, anyone tell me why Bell 412s are typically more common, like in California, Utah? Why don't we have a lot of 412s in St. Louis or Missouri? It's really a practical reason. It's not. What?
Elevation?
That's one. It's power, right? We don't have mountains to go over. The other thing is this is a much bigger platform. You can easily put 2, sometimes up to 4, I think, in a 412, depending on the configuration. Unlike the UH-1s, which it was built on, this one is different in that it's a dual engine. But there's a lot of power here. So in California, there's a lot of 412s in California. They do have mountainous terrain, longer distances. They can have multiple patients. And of course, when it's really hot and humid, is your lift better or worse? Way worse. Your lift is way worse. So having that extra power is helpful. Okay. In the St. Louis area, we have a lot of Bell 206s with air-evac, and that's plenty for our region for the most part, and so that's okay. But just having some baseline knowledge of the different air platforms is all you really need to know. Once you start going over that 150 miles, then air ambulance fixed wing divisions are going to be probably more appropriate. And there's also a bunch of different platforms, both rotor, turboprop, and jet for your fixed wing assets. Sometimes they'll rendezvous with ground services. I was just talking with the accreditation site visitors here who are doing a site visit here at SCCAD, and we were talking about long transport times like from Alaska, and how they often will use a mix of a helicopter to get to a further airport. That airport will use a fixed wing to then cross the Great Tundra to Anchorage, and then a ground ambulance service to the medical center. I mean, it's not unusual for Alaska EMS to have a 2-day transport time in some places, sometimes 3 if the weather's really bad. So you think you've got some long transport times. Here, I don't think you have 3-day transport times, but fixed wing. So for chapter 1, just review for background crew configuration and requirements, certification, licensure versus credentialing, stress management, safety considerations, and a little bit of the history of the air ambulance service for chapter 1. One other thing that is deserving of a little bit more mention probably is this second bullet point. Certification, licensure, credentialing. I have seen test questions on that before. So you have to have 3 things to actually practice as a medic: a certificate, a license, and a credential. What are the differences? So who gives you your certificate to be a paramedic? I'll give you a choice. Is it the school, is it the state, or is it your medical director? Who gives you your certificate? The school. The school gives you your certificate to be a paramedic. But even with your certificate, I graduated from paramedic school. Why can't you just jump on an ambulance and start practicing? You need the second thing, which is what? Who gives you the license? The state gives you a license. So now you've got your certificate and you've got your state license number. You still can't work on an ambulance until you get a credential. Who gives you that? The medical director does. Okay, so, and typically another test question might be the agency, which is kind of true. The agency gives you a credential to practice medicine through its medical director, right? An ambulance service can't just open an ambulance service and have no medical director. They still can't allow you to practice. There has to be a doctor behind you that says, okay, you've gone through the training, you have your minimum competencies, you know your protocols. The hamana of the medical director says you may practice now. Okay, that's your credential. So also know that in some states like California, you don't actually get a license from the state. You get a license from the county. So a Los Angeles County paramedic may not be able to practice in San Diego if they don't have a San Diego County license. Okay, it's very weird in California. Everything is weird in California. But just know that too. Okay, so you get your certificate from your school, you get your license from your governing authority, which almost always is the state. You get your credential from your medical director. And if you work for AccuCare and Abbott and Lincoln County, you might have 3 medical directors that credential you. Okay, if you have 3 different medical directors. So for each agency you work for, you just had 1 certificate and typically 1 license, unless you're in California, and a medical director from each agency. That is a test. That can be a test question. All right, chapter 2, medical legal. They do have questions about medical legal on the IBSC. One thing that you have to know absolutely is what a tort is. That's a favorite test question. What is a tort? It's not a sweet baked good from Panera Bread. That would be a tart. Okay. A tort is a wrongful act or an infringement of a right besides contract disputes. That's different. That's not a tort. Infringement of a right leading to civil liability. Now, if your wrong is against the state, that might be criminal. But when we're talking about medical malpractice, usually it's a civil liability. That's a tort. It's a wrongful act or infringement of a right. Okay? Now, here's the thing that's really, really, really troubling. You've heard of the Elijah McClain case in Colorado, yes? You know who Peter Kucinich is, right? He is the paramedic that got a prison sentence for criminal act of negligent homicide. The crazy thing is that he was not even the medic that had his thumb on the plunger and pushed the ketamine. He was the supervising officer. And because he was the ranking officer and did nothing to stop it or manage the situation, he was the one found criminally negligent and got a prison sentence. Okay? That should make you pause. All right? So lots and lots of national attention on this case because paramedics are increasingly now being found criminally liable in addition to civilly liable. What's the difference? Civil, if you're found guilty, you pay a fine. Criminal, if you're found guilty, you go to prison. Okay? No bueno. So pay attention to medical negligence. Medical negligence is defined as 4 things. And you have to have all 4 things to be found guilty. Not just 2 out of 4 or 3 out of 4, but 4 out of 4 things. You've got to be found guilty of not performing a duty, having a duty, having a breach of duty, having some kind of harm, and causation, that harm was caused by that breach of duty, okay? So like, if this guy says they had a duty to take me out the field, they dropped me, okay, and I now have a hip fracture in addition to my broken ankle, and that was caused by them dropping me, that's 4 out of 4, okay? So now he can sue them for his hip injury, all right? So give me an example of a duty to act. Like, what gives you a duty to act? How would they check that box against you? You're responding on a 911 call. You're on duty in uniform, and you have a duty to act, right? If you're sitting in your living room, putting down a cold one, watching the football game, and you hear a crash right outside your house, and there's people bleeding all over, and it's on fire, and you just watch from the window, can they sue you for failing to? No, you had no duty to act. You're off duty in your own house, minding your own business, right? You're not compelled. Now, same person watching a game in front of your station, hopefully not putting down a cold one, a cold Kool-Aid,
Yeah.
a Diet Coke, and there's an accident, then yes, you probably have a duty to act. Okay? But duty to act, responding, okay, so duty to act. Breach of duty, what does that mean? That's easy, right? Breach, you didn't do your duty. The tones dropped, and you did not respond. You just didn't. You said, I'm tired. This is my 3rd call in an hour. No, someone else can get it. Okay? You did not respond. That's a breach of duty. Okay? Or maybe it wasn't even your fault. Maybe you quite innocently turned left instead of turning right to go down the street. And as a result, you kind of got lost. You had to backtrack. Traffic was horrible. Then you had to find another alley. And you were late to the call by 6 minutes. Okay? It added 6 minutes to your time, they died. Could that be considered a breach of duty? Absolutely. Because what are the lawyers going to say? You should have known your map book. You should have known where the address was. You should have known where to go. Okay, that's a fair statement. Okay, so getting lost on your way to the call could be called a breach of duty. Okay, how about harm? Something bad happened. Okay, that's easy. My client died because it took you 6 extra minutes to get to the call. Or, you know what, you should have done the medication administration cross-check and you didn't, and you instead gave them ketamine instead of Lasix. I don't know, you gave them the wrong med, and they, here's an easy one. You pushed epinephrine instead of morphine, and now my client got a heart attack because of that, because they went to SVT and had an MI. Okay, that's a real case, by the way. So that's harm, right? Suffered harm. And number 4 is causation. Now, this is the one thing that gets most medics off the hook, because duty, breach of duty, and harm, those are pretty easy, but proving that harm was approximate cause of the breach of duty is the hardest part, and this is where most good attorneys can make a good defense for medics and say, well, this person, unwitnessed arrest, dependent lividity, maggots already crawling, they've been dead for a while, right? So the extra 6 minutes it took our medics to get there had nothing to do with their death, okay? So there was no causation, in other words, okay? But for a drowning, a witness drowning, 6 minutes is a long time, right? There's going to be a really good, I think an EMS service would be dumb to fight that. It's like, just how many zeros do you want on this check to make this go away kind of thing, right? So duty, breach of duty, harm, and causation. That's the anatomy of a medical negligence lawsuit, right? So you have to have all 4 things. Any one of those 4 things can be on a test question. Now, when we talk about the anatomy of a negligence lawsuit, let's say that the attorneys, which I'm sure you've all seen the billboard ads and the late night TV commercials on for medical negligence attorneys, what do they always say at the end? We don't get paid unless you get paid, right? That's called contingency practice, right? These attorneys are not in the business of taking cases that they're going to lose. They want cases they'll win, easy money, right? They especially want the egregious cases where even if the medics did nothing wrong, they can make the medical service squirm and just say, how much money do you want to make this go away? Easy money, right? They're looking for that easy payout. So what do they normally do before they decide to take on a case? Discovery, right? They get all of the facts of the case first, and what do they do with those facts? They give it to a subject matter expert, a SME. A SME is a subject matter expert. Sometimes they're hired guns, unfortunately. What the legal system intended was to simply find a subject matter expert in the area of expertise in which this lawsuit is centered, but unfortunately, the legal system has become corrupt by hired guns. In other words, people who claim to be experts, even though they may not be experts, but they make themselves out to be experts so they can get this. They're paid to be an SME and look at a case and tell the attorney, you have a case or you don't have a case. Okay? So that SME is going to say, well, I think, something bad happened, but the medic, their documentation is really spot on. I don't think their actions or inactions had anything to do with the bad outcome. You don't have a case. Versus, yeah, I think they screwed up. You have a case here. Then the attorney will take it. You understand? So the importance of your documentation can't be overstated, especially critical care, which are high stakes, high risk. You want to be able to have a subject matter expert look at your documentation and say, this is very well written, very well documented. The patient was really sick anyway. Bad outcome, yes, but nothing to do with their actions or inactions. Okay? But if you're sloppy in your documentation, you contradict yourself in your documentation, worse, you actually violate protocol and it's documented, that's bad. Okay? Even if, here's the thing, even if your action or inaction didn't have anything to contribute to the bad outcome, what do you think a good plaintiff attorney is going to do? Highlight your inconsistencies, highlight your violation of protocol, highlight your contradictions, and just make you squirm during the discovery phase. And finally, the agency is just going to say, well, you know what, we're just going to pay out. How much do you want? Right? Get it settled. Specific items to carefully consider: consent and refusals. Remember that consent and refusals are among the most risky parts of documentation and a call. You have to make sure that you understand EMTALA, HIPAA, and COBRA. What is EMTALA? EMTALA is the Emergency Medical Treatment and Labor Act, EMTALA. Can you tell me in a nutshell what your understanding of EMTALA is? Anybody, like, in a nutshell? You cannot get a wallet biopsy first, right? Inability to pay, socioeconomic status, none of that stuff matters in EMTALA. It requires hospitals to treat, stabilize, transfer regardless of the ability to pay within 250 yards of hospital property. In fact, as soon as your front tire hits the property, that patient is considered to have come to the hospital, so they now fall under that EMTALA obligation. It applies to ambulances that are hospital-owned and operated, and that also respond to unscheduled immediate requests for service. Remember, the government does not care about lights and siren or not. If it's scheduled and you run lights and siren, you can't bill at the emergency rate. It has to be scheduled or unscheduled. If it's an immediate response requested, then it's unscheduled. Whether you go lights and siren or not, you get paid at the higher rate for an immediate response requested. Okay? It does not apply to ambulances, air ambulances that use a hospital helipad merely as a rendezvous point. That's another big thing. If you are a flight paramedic, which some of you might become as a critical care paramedic, and you land at a hospital just as a rendezvous point for a ground ambulance to pick up or whatever, there used to be a lot of consternation because now the hospital said, well, you've landed on our helipad, we have to do an MSC, a medical screening exam. That is not the case. Now, if you land at that helipad and then you wave at the ER doc, come out here, we're having some problems. And they come out, and now they came to that hospital, and they have to have a medical screening exam, okay? So, but if you're using it as a rendezvous point, you don't have to. That might be a test question as well. So EMTALA just means we can't refuse to help somebody because of their ability to pay or lack thereof, okay, mostly. Now, under EMTALA, you as a paramedic do have some obligations. So it isn't just the hospital. That's another confusing thing. A lot of paramedics say, well, EMTALA applies to hospitals. It does not apply to us. Well, actually, it does. So the critical care paramedic has to verify that the receiving facility has accepted the patient. What's the easiest way to verify that the receiving facility has accepted the patient? For you, you're there to pick them up. You're at Barnes St. Pete's. They said, we're going to Big Barnes. How do you know that you have fulfilled that obligation? They give you a form. It says the form, right? And it says, you've all seen this form. It says, receiving facility, BJH, name of doctor that took report, Dr. Jones. Great. Okay, that's all you need. Okay, do you have to call the hospital yourself and verify that this doctor? No. If you have no reason to believe that the hospital is lying to you, they gave you the form, that suffices for your obligation of verifying that the facility has accepted the patient. Here's the other thing. You have to verify that transport can be done safely under the circumstances. You've got the personnel to do it. You've got the equipment to do it. You've got patient consent. You have a chart. In other words, you can't just take a patient to Barnes and say, well, it's St. Pete's, so you should be able to see everything. We don't have a chart. They actually have to give you their paperwork as well. Okay, so you have to have an intact chart, patient consent, and everything else. Now, how do I put that into a real-life example? Real-life example in a tragic OB case where a sending facility had verified with a receiving facility that they could accept this patient, but it was like a 2-hour transport with an unstable eclampsia patient. Long story short, very bad outcome for the mom and baby. About an hour into the transport, they diverted to another hospital that tried to stabilize them and then airlifted them the rest of the way to the receiving hospital. But the lawsuit against the paramedic and the ambulance service was that you should have known that this unstable eclamptic patient was too unstable for a 2-hour ground transport to the receiving facility. You should have known that you only had 1 dose of MAG anyway, and you didn't even have a MAG drip. You should have known that you didn't have the training because they were not a critical care paramedic. This was a small mom and pop EMS agency. They had no critical care ambulance. They had nothing. You should have refused this transfer. That was the main plaintiff's argument. And well, the ambulance service lost and went out of business. It was bad, okay, because they were one of very few medical resources in that area anyway. So when they went out of business, now there's this desert of no ambulance services. So it was bad for everybody. But that EMTALA, just to illustrate that does very much apply to you as a critical care transport medic. Okay. The other one is HIPAA, the famous HIPAA. The HITECH Act updated HIPAA to include electronic records because when HIPAA was first written, there was really no electronic records all written. But now it applies to electronic patient care reports as well. It only pertains to covered entities. So healthcare providers who transmit PHI electronically for billing or claims, that is the definition of a covered entity. Or you are a healthcare plan or insurance entity like a managed care organization. That's the second type of covered entity. The third is a clearinghouse, so an intermediary between provider and payer. They handle protected health information, PHI. Those are covered entities. Now, why is the first bullet point, who provide PHI electronically for billing or claims, in red? Because that's the caveat that a lot of people forget. So I've had this friendly argument with my police department for some years now. Okay, they give Narcan. Narcan is in their report. It is healthcare information. And they want to treat that like a patient care report. And I said, well, you're not a covered entity, you're a police department. Yes, but we have PHI. I said, yes, but you don't transmit that for billing or claims. Are we sending them a bill when the officer gives an Narcan? No. Are you transmitting anything electronically? No. Then you're not a covered entity. Now, an organization like a police department can self-impose HIPAA requirements on themselves. My point is the federal government cannot come after the police department for not following HIPAA for their Narcan and in the police blotter because they're not a covered entity. Right? Now, lots of non-covered entities do self-impose HIPAA requirements on themselves, but that's on them. That becomes an internal policy. And if they want to sanction an officer for not following their policy, well, that's fine, they can do that. But the government cannot come after the police department for a HIPAA violation because they're not a covered entity. Do you understand what I'm saying? Okay. So covered entities, right? Is any information generated by a covered entity is patient health information. Okay. Now, it gets a little wonky here because there is a term called business associates or BAs. What are BAs? BAs are persons or agencies that perform services for a covered entity and interacts with or has access to its patient health information, private health information. You follow? So you may not be a covered entity, but if you work for a covered entity and you have access to their PHI, you may need a BA. That covered entity has to have a business associate or BA with that entity.
Would that be like contracted anesthesiology for a hospital?
Oh, I'm so glad you asked that question because that leads right into our live quiz. Ready for our live quiz? Live quiz. Hospitals should typically have a BA with their janitorial services, because sometimes they empty the trash. There might be PHI in the trash. I don't know. The Postal Service, because the Postal Service handles all their billing, all their paperwork they send. The credit card processor, you ever been to a doctor's office, you have to pay your copay? You swipe your credit card? Does Visa or MasterCard have to have a BA with your doctor's office? Their consultant that does utilization review, they have access to PHI. So what's the answer? All of them? C? So according to the government, the answer is D, because the consultant is hired by, say, the doctor's office. They go through all the charts for utilization review. They say, well, this is going to be covered, this won't be covered. A utilization review, right? The consultant is not a covered entity, but they're hired by a covered entity, and they interact with the PHI for business purposes. So they're looking at everyone's chart, okay? So if your dentist contracts with a consultant to do utilization review before they take all your teeth out or something like that, they have to have a business associate, a BA agreement with that consultant. Make sense? Why not the janitor service? Because they're not hired by the covered entity to interact with PHI. They're hired to clean up the trash cans and wash the toilets. The Postal Service, unless they're opening all the mail and reading it, they may be handling the PHI, but they're not reading the PHI, right? And the credit card processor is simply an intermediary for payment. They're also not interacting with PHI. They know that Joe Smith was at the doctor's office, but they're not there for purposes of managing or utilizing the PHI. They're there to collect payment for services. So the government does not consider the credit card processor to be a B. And C, actually a lot of people choose C, which is why it is a distractor. So make sure that you know that if you happen to see that on a test question. And finally, Cobra Kai. Consolidated Omnibus Budget Reconciliation Act. This is not the same thing as EMTALA. It sometimes gets looped in with that for some reason, but COBRA is the law that gives workers and their families who lose their health benefits the right to choose to continue health benefits for up to 36 months under certain circumstances, so that you're not high and dry, okay? Now, you're paying a pretty penny to keep your employer's health benefits after you're terminated, or after you retire even, for up to 36 months. But at least you're not without any health insurance for catastrophic things. Okay. The next thing we talked about after consent, refusals, EMTALA, HIPAA, COBRA is decision-making capacity versus competence. Now, in your textbook, one of the things that they have in there is wrong. So just notice this. In your textbook, there's a chapter that talks about documentation of competence. That is incorrect. We as paramedics do not document for competence. We document for present mental capacity, or PMC. Okay? What is the difference then between competence and present mental capacity? Oh boy, you should know this, because if you're on an interfacility transport and they say, yeah, little Miss Millie over there has to go to the hospital, and you go in there, hi, little Miss Millie, I'm paramedic so-and-so, I'm here to take you to the hospital. She says, what hospital? I ain't going to no dang hospital. I don't want to go to no hospital. And you go back out to the nurse's station and say, well, Miss Millie doesn't want to go to the hospital. And the nurse says, her power of attorney says she has to go to the hospital. What are you going to say? Oh,
Is she oriented? The girl
she's
probably
complete.
doesn't.
The patient is completely awake, oriented, knows who she is, where she is, why she's there. She says, I'm watching Wapner. That's Wapner. Wapner's next. You know, I can't miss Wapner. I'm watching Judge Judy or whatever the favorite show is, and I'm not missing this episode, and I don't want to go with you. Can you force Miss Millie to go with you because the power of attorney says she has to go?
No.
Well, why are you so confident in saying no? I mean, you're right, but why are you right?
She has capacity to make her own medical decisions.
Okay, what if the nurse's station instead said, well, her legal guardian says she has to go? Then do you take her against her will? I get a yes and I get a no. It is a guardian ad litem for everything. Then do you have to take him? Solomon. It's a legal guardian.
Legal guardian, then yes. In that case, the legal guardian has to.
So I'm hearing yeses.
It's my understanding that the power of attorney is only in the case that the patient becomes mentally incapacitated.
Okay, so now you are veering into the truth. So yes, so you've answered the question correctly. So now we go back to the original question. What's the difference between competence and present mental capacity? Which is another way of asking, well, what the heck is the difference between a guardian and a power of attorney? And you really ought to know this, because as a critical care medic doing transfers a lot, this comes up all the time. Like I get calls for this still today.
And they understand the decision that they're making.
That's present mental capacity, yes. So does that make them competent? What if they know who they are, where they are, why they're there, but they have a guardian? What does that mean?
It means the state as a governing body has taken away their right to make that decision for themselves.
There you go. So competence, here's the test answer. The test answer is competence is a legal term. Only a judge can declare someone competent or incompetent. If someone has a guardian and you have paperwork that says they have a legal guardian, the state has taken over, here's the legal guardian's name and phone number 24/7, that means a judge somewhere has declared this patient incompetent. Now, very often that patient also has no idea who they are, where they are, why they're there, okay? But that's not always the case, right? They may be fully awake, alert, and oriented, and otherwise fine, but a judge has declared them incompetent. They have to have a guardian, okay? Now, it doesn't matter whether they want to go or not. The guardian says they got to go, okay? A power of attorney, you are correct. That does not typically take authority unless they have lost the ability to make those decisions. So they are incapacitated. They don't have present mental capacity. They got hit by a car and they're in a coma. And the hospital wants to know, do they want tube feedings? Do they want to be on the vent? The power of attorney says yes or no. Okay?
Is it also possible that you're competent, but you lose capacity, such as like being under custody?
That's still a competency thing. So when you become a prisoner, for example, you may have capacity, but you are now I want to say temporary, not really ward of the state, but they are, the police department is the one who's going to sign your refusal form.
Yeah, or the
Not
more
them.
reasonable one also would be like a protective custody, right? Like so.
Yeah, oh yes, yeah.
The patient's competent-ish, can
Yes.
know their whereabouts, but they're in protective custody, so they don't have capacity to make their decision.
Yes, if they're placed in protective custody, then the state assumes care for them, yes. And whether they go to the hospital or not, all those kind of things. Yeah.
Now, the book brought up like somebody who was under the influence
Yes.
and could answer all orientation questions appropriately. And like I started thinking back on, calls that I had been on that I felt like, well, this person can,
Answer
easily
questions, yes.
Answer questions and, I believe they could fend for themselves after I left. And is there kind of an obvious line there? I feel like that's really.
So that is a perfect segue into the next concept, which is PMC, present mental capacity. Okay. So present mental capacity is something that, the reason why we're talking about it under documentation is because you have to be able to prove later on, if they sue you for taking them against their will, or vice versa, for not taking them and they later died or lost a limb because you didn't take them to the hospital. Your documentation has to be such that a subject matter expert can say, well, yeah, this was very well documented, and I think the paramedic made the right choice, and it was your client's own stupid fault that they died or they lost an arm, versus, yeah, this was very sloppy, and you could make a case for not having present mental capacity, even though the paramedic says they were alert and oriented times 3. They probably didn't have capacity. And here's where documentation comes in. So when I talk about documentation of PMC, present mental capacity, I use the Narcan example as a well-known, easily understood explanation analogy. When we have someone who was dead 5 minutes ago, clinically dead 5 minutes ago, we revive them with Narcan, they wake up, and 10 minutes later they are completely awake, they're in withdrawal, but they know exactly who they are, they know exactly what happened, they know exactly where they are, what year it is, what time it is, all the alert, they are alert now, sadly, okay, and fully oriented, and they do not want to go to the hospital. And they're like, we were just doing CPR on you and begging you like 15 minutes ago. I said, I don't care, I do not want to go to the hospital. Do we let them refuse?
Yes.
Yeah, we do all the time, right? Now, I would rather that our documentation reflected a little bit more of the decision-making process besides A&O times 3 or 4. Because we all know people that are alert and oriented times 4 that are drunk. If they walked into a bank and tried to sign a promissory note, would the bank allow them to? Heck no, they wouldn't allow them to if they're obviously intoxicated, right? They'd say, come back tomorrow when you're sober, okay? A refusal is a legal document just like a promissory note. There's no different. So why would we let them sign a refusal? But that's my point. A present mental capacity is way more than A&O times 4. It is understanding the circumstances, the consequences of refusal, the risk and benefits of transport or non-transport. And it's difficult to quantify that. The way I recommend our medics do it is through documentation. Well, what are you documenting? Well, easy stuff like recall, abstraction, calculation, following commands. All these things will help document, paint a picture for the SME, the subject matter expert, and more importantly, if it goes to court, for the jury to understand what your reasoning was for transporting them against their will or for letting them stay in their living room. Either way, you want to be able to prove, why did you decide? How I do it is I start with alert and oriented questions, okay? That's easy, because if they can't tell me what their name is or where they are or the year, then I can stop right there pretty much and I'm like, get in the truck kind of thing, right? But usually they can do that stuff. Where I get them is where I say, okay, I'm going to give you 3 things to remember. I want you to repeat them back to me. Can you do that? Yes. And I give them 3 things. Usually I give my 3 things, you can take if you want, is necktie, elephant, and honesty. I use those 3 things. Why do I pick that? Because necktie and elephant, these are things you can touch, right? A necktie you can manipulate with your hand. An elephant, you can touch that elephant, right? Honesty is more of an abstract thought. You can't really touch it or manipulate it, but it's an idea, right? So 2 physical things, 1 non-physical thing. Can you repeat that back? And if they're like no immediate recall, get in the truck, right? But usually they can get those 3 things. I said, good, I'm going to ask you those same 3 things in 5 minutes. Can you remember those things? Yes. Okay. Then I go on and I say, what is that? It's a penny. Okay, great. If I gave you 5 quarters, how much money do you have? $1.25. Okay, that should be pretty easy, right? Can you spell world backwards? A 5-letter word, world, like whole wide world. Get in the truck, But if they can say, yes, world, D-L-R-O-W, world, okay, great. I usually give them something to do, like I give them a piece of paper, fold this piece of paper in half. And if they go and they rip it, well, they're not following commands. Show me your right thumb. And they're, nope, give them simple commands like that. Ask them to name things like, what do you call this? That's a watch. But if they're like, I had someone say clock once, I said, well, close enough, I guess. But, if they say that's a baseball, that's a problem, right? And then so I do these series of things. I'll say, can you subtract 7 from 100? And I don't care if they have to use their, fingers and come up with 93. Okay, great, close, But if they're like, 10, okay. The reason why I don't give integers like a 5, some people say subtract 5 from 100 and keep going. Well, 95, 90, 85. That's even someone who's pretty drunk can do that. But 7, odd number. They have to stop and think a little bit and use their fingers. I'm okay with that. If they can do it, great. And then a few minutes have gone by, and I'll say, what were those 3 things again? And if they can't remember any of them, then that's like there's no delayed recall. How are they supposed to understand the risks and benefits that I am explaining to them to sign a refusal if they can't give me these 3 little things 5 minutes later, right? That's the argument you want to give in court. I took them against their will because they couldn't even remember any of these 3 things 5 minutes later. And part of refusal is predicated on proving that they understand the risks and benefits of the refusal. See? So if I can document all these things in my chart that they passed with flying colors and later they die, or they lose an arm, I have much stronger grounds to say, well, they passed my mini mental static exam, they're awake, beyond they're awake and alert and oriented. Mini mental static exam, immediate recall, delayed recall, abstraction calculations, spelling, commands. I had no basis to force them against their will. The Supreme Court of the United States years ago already said that people have the right to make stupid decisions, as long as they have the capacity to make that decision. And so you're going to come across that as a critical care transport medic a number of times. And so you have to understand this concept. So if you get a test question on competency versus capacity, that's the difference, right? And when you read that in your book, understand that just make an X through that word and put documentation of present mental capacity, not competency. Other related things in this chapter, CAMES and ARMS. So I don't know why they pronounce it CAMES because it's spelled CAMPS, but I think CAMES is easier to say than CAMPS. But the Commission on Accreditation of Medical Transport Systems and ARMS are 2 entities you should be at least familiar with. CAMES is typically over air ambulances, but not always, but it can be surface medical transport services, but basically it's an accreditation for industry established criteria. Almost all air ambulances are CAMES accredited. It's not just one, but 22 other organizations, and here's just a smattering of the more well-known organizations that make up CAMES. ARMS is the Airline Resource Management System, which is actually a commercial product. But why is it so influential? It's because ARMS is the commercial product that makes AMRM easy. AMRM is an advisory from the FAA, started back in 2005, which basically says that any police, fire, or EMS agency conducting air medical transport should incorporate air medical resource management into their training. And ARMS has a turnkey solution that makes that easy. So checks the box, makes it easy. Almost all of them use ARMS. Okay. All right, that was a very quick overview of Chapter 2. Be sure you understand HIPAA, its violations and fines, EMTALA examples, and pearls about documentation. Yes, take a break. That's a good spot to take a break. Take a 5-minute break, and we will go on to Chapter 3.
You guys all should have received an email with the Google Classroom invite.
Where's the pause button?
Go to the top bottom left.
Record stream.
My man's over here
Very nice, Miguel.
collecting eggs.
Well, now you know, so you can put him in for it.
Right.
Give him a shout out.
Amanda after this.
All right. Chapter 3, patient safety. There are some important concepts here. Chief Stewart reminded me I need to step it up because we're taking too long. So we're going to go a little bit faster. So what is patient safety? Is it a philosophy? Is it a field of study? Is it its own discipline? Is it an attribute, maybe a combination of all 3? I think you'll probably find there's probably a little bit of all 3. What is the first rule of medicine? And can you say it correctly in the Latin? But you've heard of it, yes? Primum non no quiere. I think that's how you say it. What does it mean? First, do no harm, okay? And that is kind of what the culture of safety is built around. Locally fostered and managed, we acknowledge that error is inevitable. In other words, a lot of people think that patient safety means trying to eliminate mistakes. That's not what we're trying to do. We know that mistakes are going to happen. What we're trying to do is make sure the mistake doesn't hit the patient. Okay? The reason why we're spending some time on this is because as a critical care paramedic, guess what? You have some sharp instruments and dangerous drugs, way more dangerous than usual. So patient safety has to be baked into your DNA if you're going to become a critical care paramedic. We want to also, of course, improve systems. And how do we learn from our mistakes? Probably the most important thing is making error reporting easy and blame-free. Because if it's not easy to report mistakes, and if we just tend to blame people and punish them for making mistakes, guess what? Are medics going to report errors? No. Therefore, are we going to learn from our mistakes? No. We're going to be doomed to repeat our mistakes if we don't make it easy to report and blame-free. So that's something I think SCCAD has really tried to do through a concept called Just Culture. Anybody here Just Culture certified? Anybody? I don't blame you. It's a 24-hour course. It's a 3-day course, 8 hours each. It's very good, I'll tell you that. If you ever go up even further beyond Lieutenant, BC, and above, I think we're going to try eventually to get all of our leadership staff certified in Just Culture, but it's because Just Culture is what makes all of this possible. So Just Culture, to make a really long story short, is it teaches you to accept mistakes as inevitable, and instead of trying to eliminate them, we try to keep the mistakes from hitting the patient. How do we design a system where if you're going to make a mistake, fine, we're human, we're going to make mistakes. How do we design systems to trap it? Trap the mistake so it doesn't hit the patient. That's the most important thing. Well, Just Culture helps us do that. When a mistake occurs, notice I didn't say if, I said when you make a mistake. At SCCAD, we encourage a blame-free culture where you can self-report, and I'm happy to say that I get self-reports fairly frequently about, hey, I made a mistake. And we put it through the Just Culture algorithm. Basically, it's a series of questions that leads us into one of 3 outcomes, either consolation, coaching, or punishment, which again, the culture of safety makes this pretty rare, pretty uncommon, okay? What do I mean by that? I mean, if we look at a mistake you made, and after the series of Just Culture questioning and interviewing, we find that actually it was our fault. SCCAD designed a really bad system that basically almost forced you to make the mistake. Guess what? Not only are you not punished or even coached, you are consoled. SCCAD apologizes to you and say, yeah, we should not have put these 2 drugs that are identical in labeling in the same compartment. That was a mistake just waiting to bite you in the rear end, okay? From now on, we're going to separate these 2, or we're going to put a different color tape around it, something, so that you don't make that mistake again, okay? That's consolation. We change our process, procedures. We change our training. We change the environment, something, and we say we're sorry. However, if we find that, hey, actually that's something that you could have prevented, we're still not going to punish you, but we're going to coach you. We're going to say, hey, man, I know that you feel like doing the medication administration cross-check adds 10 minutes to your call, but it actually doesn't. By the way, how much time does a MAC add to your call, if done from start to finish? By video, 27 seconds. So 30 to 35 seconds if you talk slow? Absolutely. My point is, it ain't no 10 minutes. It adds 30 seconds to 60 seconds to your call, but it saves you hours of paperwork, hours of depositions, hours of court appearances if something really bad happens, right? So if you say, hey, I just didn't feel like I had time, we'll coach you. We'll create incentives maybe. We'll increase your situational awareness. Maybe you didn't know that it only takes 27 seconds. And that's how we will coach you to be better, okay? Now, there are some times when, you just did something that should never have happened, and You consciously made a decision to do something dangerous and it hurt the patient. Just culture is not a get out of jail free card. You're going to be punished in that regard. But I would say that is so rare, but we have to mention it, okay? That if you do something willfully and wantonly wrong, you're going to pay the consequences for it. But that's very rare, okay? So medical errors, examples, sound alike, look alike medications. You either separate them or you put different colored tape around it. You do something to call attention to it. I'm sure you've seen tall man lettering. Have you ever seen tall man lettering where the middle letters are in all caps so that when you're reading the label, it stands out? Oh, this is not nifedipine. Like I thought this is a card, nicardipine. Oh, man, that's the wrong drug. Tall man lettering is when they capitalize the middle so that you can see it, In just culture, you should know what a near miss is. A lot of people think that a near miss is a mistake almost happened. That's not what a near miss is. A near miss is a mistake did happen, but it didn't hit the patient, okay? So I had a great example of a near miss a month ago or so. A medic self-reported. They made a mistake. They drew up the wrong medication, but they caught it and never gave it to the patient. So it never hit the patient. Patient never knew a mistake happened. That's a near miss. A mistake did happen, but it didn't hit the patient. Follow? And we investigated that and we learned from it and we said, okay, here are some system things we can do in place so that reduces the chances of that near miss ever happening again. The reason why aviation, commercial airline travel is statistically the safest form of travel is because just culture has been baked into pilot training in aviation for decades. It's relatively new to us, but it's in airline it's been decades. So that's why. Okay, a sentinel event occurs is a mistake that does happen, but it does hit the patient. And not only did it hit the patient, but it caused death or serious injury. Okay, if a mistake hit the patient but it didn't cause any harm, that is a medical error, but it's not a sentinel event. Okay, so you gave 6 milligrams of morphine instead of 4. Was it a mistake? Yes. Did they get harmed for the extra 2 milligrams of morphine? No. They never stopped breathing. They never vomited. They never got sick from it. That's a mistake, but it's not a sentinel event. Okay. You accidentally give a paralytic when you meant to give a diuretic, and they died because no one noticed they stopped breathing. Sentinel event. High reliability organizations. These photos here represent HROs, high reliability organizations. What do you notice about them all that have in common? What do they all have in common? HROs.
Jobs with inherent risks.
Yes, they are all jobs that if you make a mistake, people die. People die or great calamities result. Okay? These are jobs where you cannot make mistakes. You just can't. HROs are organizations that they routinely do high-risk operations with very few, if any, errors. Okay? That's a HRO. Why do I think 9664 critical care should be an HRO? Because I think 9664 routinely does very high-risk operations with very few errors. Okay? And what are the 5 traits of an HRO? Well, that by itself is a 2-hour lecture. I'm going to focus on the top one, though, preoccupation with failure. Preoccupation with failure means HROs, no matter how successful they are, they obsess about what could go wrong. And they make systematic engineering processes to make sure that hypothetical error doesn't even happen to begin with. Okay? They are obsessed with failure. Every operation on SWAT, no matter how successful our operation is, we always meet afterwards and do a hot wash, and we debrief it, no matter how perfectly it may have gone, because we don't care how good it is. We don't care about outcomes. We care about the process. Did we follow the process? What could have gone wrong, and how do we prevent the hypothetical from happening? And heaven forbid, if something wrong did happen, boy, we debrief the heck out of it. We say, how did that happen? And when the next training day, we replicate it, and we find out where the engineering needs to happen so that doesn't happen again. That's why SWAT is an HRO. We do hundreds of call-outs with very few, if any, errors because we are constantly obsessed with failure and how to engineer it out of the system. Okay? Crew resource management, or CRM, is another concept in patient safety that you have to understand. Does anyone recognize what this picture represents? I'll give you a hint. It is still to this date the single most horrific airline incident in history, the most lives lost. That's Tenerife. So Tenerife is a resort island where a Pan Am jet and another jet collided on the runway. I think almost 800 people died. It was back in the 70s. That single incident transformed aviation to this day. Things still happen. I'll give you just one quick example. The word takeoff. Tenerife, of course, is a resort island, so lots of pilots where English is not the first language use that airport. And air traffic control, also not English, not the first language. But English is the language of aviation. So the weather was bad, very overcast, lots of clouds. The radios weren't what they are today, and there was some broken traffic. Air traffic control said hold for takeoff, and the pilot said, did he say takeoff? Yes, he did. He said takeoff, whoom, and ran right into that other airplane. So to this day, the word takeoff is not used by any air traffic controller or pilot until they are physically at the takeoff point and ready to move forward. Now they say departure. They say hold your departure, or I'm ready for departure. But the word takeoff is never used until they are physically ready to mean go throttle up. That's just one of a dozen lessons learned from that incident, what makes aviation safer. As part of crew resource management, air ambulances, crew resource management is so successful that now the fire service has adopted CRM. Ambulances have adopted CRM. You all know Sully Sullenberger. He was on the cover of EMS World because his interview, he said, CRM has worked for aviation for so long that everyone, including ambulances, should use CRM principles. Crew resource management basically says that it does not matter who the paramedic in charge is. It doesn't matter who you are. You could be a visiting medical student. You could be a medic student. You could be an EMT student. If you see something that does not seem right, you should say something, and that's crew resource management. In the aviation industry, one of the many lessons learned a long time ago was that the culture used to be that if you're the captain of the airplane, no one questioned the captain. The captain's word was final. But now in aviation, it doesn't matter who you are. You could be a flight attendant. If you feel like something's unsafe or you see something that doesn't look right, you need to speak up. And I don't know if any of you have ever done a ride-along on an air ambulance like ARCH or AirVac. One of the first things they told me when I did my first ride-along and subsequent was, even though you're just a ride-along, you are now part of the crew, and crew resource management says it takes 3 to go, 1 to say no. You've heard of that before? That means all 3 on the crew, and now if I'm around all 4 to go, 1 to no, means if one person says something's not right, I don't think we should take this flight, then without question, they all turn around and go back. Now, that doesn't mean that later they can administratively say, hey, why did you get our flight canceled? But at the moment, they're not going to argue with you, okay? And that's part of CRM. Someone says, hey, man, that's lightning over there. The wind is shifting. This is not safe. Then it's canceled, okay? That's part of CRM. If you are not the paramedic in charge, but you're like, I don't think we should be giving this guy ketamine, then it should not be given, or there should be a discussion anyway. That's part of crew resource management, you follow? Part of the culture of safety, right? So, very quick review of Chapter 3. Those were the highlights. There are a lot more things in Chapter 3, like the history of patient safety initiatives, how to create a culture of safety, common errors. They also talk about Reason's Swiss cheese. Reason was the last name of a researcher that developed the Swiss cheese model. Anybody heard of the Swiss cheese model before? Yes? Okay, yeah, good. So for those of you who haven't, very quickly, Swiss cheese, holes in the cheese, right? If you take slices of cheese and you mix up the slices, then you can't see through the cheese. But if you line up all the holes, then a mistake can hit the patient. So each slice of cheese is a safety initiative that tries to keep the holes from aligning. We don't want the holes to align. If the holes line up, then the error hits the patient. But if you can move the slice of cheese so that you close the hole, the patient is safe. Okay? The medication administration cross-check, or MAC, is an example of a slice of cheese. If you do this MAC, that's just another slice of cheese that helps keep a mistake from hitting the patient. Okay? In fact, some people will say that each step of the MAC, when you say the RCV, ready, contraindications, and volume, are 3 slices in and of itself. Okay, good. So be sure you go over that for chapter 3. All right. Next, chapter 20. Chapter 20, we're talking about infectious disease and communicable disease. And I get, wait a minute, aren't they the same thing, infectious disease and communicable disease? So, second quiz question of the day, which of the following is a communicable disease? A, B, C, or D? D as in Delta? Correct. Well, then what do you call A, B, and C? Well, influenza is acquired. Infectious disease. That's the umbrella term. They're all infectious diseases. But D is communicable disease. So an infectious disease is an illness caused by germs. And germ could be what? Bacteria, virus, parasite. Okay. Anything capable of causing a disease is an infectious disease by germs. Okay. But a communicable disease is an illness by germs that can spread from one person to another. So Lyme disease is an infectious disease. But can you catch Lyme disease from standing next to someone in the grocery store that has Lyme disease? No. So it's not communicable. But influenza is communicable. You can catch that from someone hacking all over you in the grocery store. Okay? Next question. Which of the following, therefore, is considered contagious? A, B, C, or D? C? Everyone says C? Correct. Tuberculosis is contagious. Well, then what's the difference between contagious and communicable? Well, communicable spreads from one person to another. Contagious just means highly communicable. Okay? So there's communicable and then there's contagious. Right? So TB, meningitis, COVID, influenza, measles, those are contagious, like fairly easy to catch from other people. Now, you can get HIV from another person, but it's not contagious. It is communicable, though. See the difference? Hepatitis, Zika virus, these are all communicable. They're not contagious. Okay. So, you should know what an R naught is. You've heard of R naught, R0. The R naught is the basic reproduction number. It is a number that basically expresses the average number of cases of an infectious disease arising by the transmission from a single infected individual into a population that has not previously encountered the disease. So the R naught of influenza is 0.9 to 2.1. That means if someone has the flu, depending on the population, they can give the flu to 1 or 2 more people. What's the R naught of measles? 0. That means if the R naught of measles is 0, that means one person with measles cannot transmit it to anybody else.
Isn't it that way because of vaccines?
So, unfortunately, there's a ton of people that don't have vaccination anymore. 100?
If you're in contact with measles, unless you have vaccine, you're 100% immune.
Right. Now, in our population where there are vaccinated and unvaccinated, in the general population, the R naught of measles is 12 to 18. That is nuts, right? One person with measles will infect 12 to 18 more people in our current population. What does that have to do with EMS? A lot. Because EMS is now being called to help because it's getting out of control in some parts of Texas, especially. In the South, there's an outbreak, almost 1,000 cases. This was from 3 days ago, to June 17th of this year. And it's uncontrolled right now down there in some parts. So EMS has to understand this because are you at risk even if you are vaccinated? Is the measles vaccine 100% protective? It is not, okay? It's pretty good, but it's not 100%. So even if you've had the measles vaccine, you should absolutely exercise precautions if you have a measles patient, okay?
What was the R naught of COVID when it first hit? Do you know?
I used to know. I don't think it was 18. I think it was like 6 or 7. So a lot,
Yeah.
but not like measles. Yeah, not like measles.
What about like evolutions of the measles because of outbreaks and stuff? Or something
Yeah.
that would we
Oh, like influenza vaccine? Like influenza vaccine changes every year, depending on the strain. I actually don't know. I don't know that measles mutates like influenza does, at least not as much. In other words, I don't know that the MMR vaccine has changed every year. It might be, I just don't know. But in answer to your question, for certain diseases like influenza, yes, it evolves. And so every year, the CDC tries to predict which strain is going to be most prevalent, and they make the vaccine for the following year in that strain. Sometimes it's a hit, sometimes it's a miss. Okay?
The measles vaccine a one-time thing, or do you get
It's a series when you're a kid. I think it's 3. Yeah, 3 vaccines. Most of you should have had your entire series of MMR, which confers a pretty good immunity, but it's not 100%. My point is, if you pick up a patient that you suspect of having measles, doesn't matter if you're vaccinated, you should don gloves, respiratory protection, eye protection, everything. Because it's very contagious with a very high R0, 12 to 18. Okay? You should know the difference between a disinfectant and an antiseptic. You might get this on a test question. What is the difference? A disinfectant is different from an antiseptic in that what? Which one's a disinfectant, the purple thing or the green thing? Purple thing is a disinfectant. A disinfectant is something you don't want to put on your skin. A disinfectant is something that you use on surfaces, like toilets, countertops. The oxygen tank in your ambulance, which by the way is one of the most contaminated things in an ambulance, is the O2 tank. Because everyone touches it with gloves that are contaminated with poop and influenza and crap, right? You touch your O2 tank all the time, okay? People also touch the surface of their monitor with their gloves all the time. Dude, it's horrific what's going on there. So you should use a disinfectant on your monitor knobs and your O2 tank a lot, okay? But you don't want to put an antiseptic on there because it's probably not as strong. What do you put antiseptics on? Your skin, okay? So like Bactine is an antiseptic. You squirt that right in your wound, okay? But you don't want to put Santa Claus in your wound. That's pretty toxic to your skin. And it hurts. So you've heard. Another concept you really need to know is the types of immunity. This is also very easy test question fodder. We're going to slow down a little bit on this because this can get very confusing. Let's just focus on the 2 major divisions of immunity. There's innate immunity, and then there's acquired immunity. Those are the 2 first branch points, right? Innate immunity is innate. That means you are born with it. So guess what? The organs, tissues, and cells of the immune system that you're born with, like skin and the spleen and the macrophages in your lung, these are all types of innate immunity because you were born with it. Make sense? That means everything else you're not born with has to be acquired. Okay? Acquired immunity is immunity that develops during your lifetime. You're not born with it, but you develop it. Okay? That's acquired. Now here's where it can get a little bit confusing. Okay? We're now in acquired. We're done with innate. You follow? We're done with innate. We're now in acquired. Acquired, you further subdivide into 2 more categories: active and passive. People get active and passive mixed up with natural and artificial all the time. And I'm telling you, it's easy to do if you don't remember how this flows. Okay, so first there's innate, then there's acquired. We're done with innate now. Now you're in acquired. Acquired is further subdivided into active and passive. Active and passive both can be subdivided into natural and artificial. Let's take a look at active first. Active immunity develops in response to an infection or a vaccination. In fact, active means your body is actively forced to develop an immunity. That's how I remember it. If you want to use a different way of remembering it, pick a way that you remember it by. For me, I remember, okay, active, you're actively forcing your body to do something. How do you actively force your body to do something? Well, you can either get sick or you can make it think it's sick. What do I mean by that? Well, a natural active means you get sick. You actually acquire a cold, rhinovirus. You know what the cool thing is? Once you acquire a cold, you're immune to that cold the rest of your life. Well, why do you keep getting colds? Because there are thousands of rhinoviruses out there, okay? So you may be immune forever to rhinovirus number 1085, but not 1,086. Okay, so you'll still get a cold next season, all right? But antibodies developed in response to infection is a natural, active, acquired immunity. You follow? You made your body make antibodies by getting sick. Okay? But artificial active acquired means you didn't get sick, but your body thought you were because it got a vaccination. And it saw these invaders that thankfully didn't make you sick or not very sick, but it made antibodies to that invader. So COVID vaccine, measles vaccine, tetanus vaccine, all these vaccines trick your body into thinking, hey, we're being attacked. We make antibodies, but then when you really get attacked by the real invaders, you already have antibodies. That's the whole point of vaccines, okay? So that's an artificial, active, acquired immunity. Now we're done with active. Let's go to passive. Passive immunity means you're not forcing the body to do anything. The body is receiving passively, okay? So breastfeeding, still recommended as the primary source of nutrition for the neonate. Why? Because mother's breast milk contains natural maternal antibodies that are passed through the breast milk to the baby. That's natural antibodies. You're not forcing the baby's body to do anything. It's receiving it through breast milk. It's passive because, again, you're not forcing the body to do anything, but it's natural from the mom. Okay? But you were dumb and you tried to catch a raccoon and it bites you. What are you going to get besides rabies vaccine? What are you going to get? You're going to get rabies immune globulin too, okay? A series of injections where you are doing both an artificial active, but if you get bit by a raccoon, you also get artificial passive, both. You're now going to get a gamma globulin injection or infusion to rabies. So your body is now receiving passively the antibodies while the vaccine is forcing your body actively, artificially, to make antibodies as well. Why do we do both? Because rabies is usually fatal. The stakes are very high, okay? You get bit by a raccoon, you're going to get both. So you follow? Less confusing now, yes? So that would be artificial, passive, acquired immunity. Rabies immune globulin. Cool. You'll never be confused about that from now on. And this is in your notes as a nice little reminder, okay? Now, speaking of that, let's say that in spite of all of these protections, you get sick. Well, let's say that rhinovirus 1086 got into your nose somehow. Well, first of all, that was a pathogen, correct? That's a virus that then gets into some reservoir, like other people. A person that was sick with that virus sneezed on you in the grocery store. That then was their portal of exit, the sneeze, which made direct contact with your eyes. And that was your portal of entry, was the eyes. And because you didn't get any sleep, because the last week you've been staying up late studying for your critical care test and working, so you're stressed, overworked with no sleep, your immune system is down, now you're susceptible. Now you got sick, okay? That is the 1, 2, 3, 4, 5, 6-step process in the chain of infection or cycle of infection. If you break any one of those chains, you don't get sick. Isn't that cool? So you have 6 opportunities to not get sick. There's not a whole lot we can do about pathogens or reservoirs or their portal of exit, really. But we do have lots of control over modes of transmission, portal of entry, and susceptible hosts. We can make sure that we wash our hands a lot and that we avoid vectors by using bug spray, for example, when you're outside in the summertime and there's lots of mosquitoes and ticks and other vectors of transmission. We can make sure that we use eye protection when we're intubating. I can't tell you how many people I see intubating with no eye pro still. We're pretty good about wearing a face shield, especially if they're coughing and you think they might be sick, but people don't use the eye protection very often. Okay? People are very good about using gloves, sometimes too good. What I mean is they never take them off. So they have the gloves at the start of the call, they're doing all the stuff, they're handling blood and feces and blah, blah, blah. Then they're opening the cabinets to grab more gauze. Then they're touching the screen on their cardiac monitor with the same gloves. And then sometimes they get and drive. It's gross. It's gross, right? And then they take the gloves off and wash their hands in the ER. They get back in and put their hands on the steering wheel and drive back with a filthy steering wheel, okay? So there's your port of entry. They didn't protect that. And then anyone who works in EMS is susceptible because we don't get enough sleep. We don't eat the best foods, and we don't always, I know. Quick Trip is faster than Fresh Time, you know. So anyway, just know the cycle of infection. Be able to complete a diagram of the cycle of infection and label it, and be sure that you know that if you break just one chain, you are able to break the entire cycle. Immunodeficiency is a concept that is especially relevant for critical care who receive patients with weakened immune systems. We think about ourselves, but really, who's at most risk on a transfer? You or the patient? The patient is, because the patient is the one who's sick. They're really sick. So reverse BSI is essential. We don't want them to get sick from us, okay? This is something I had to remind a Subway sandwich maker who was wearing gloves and was, cleaning with a broom as I walk in for my sandwich, and same gloves on the broom. What can I get for you? Whole wheat? And I'm like, could you please change gloves? Oh, yes, thank you. The gloves aren't there to protect them. The gloves are there to protect me. Okay, so reverse BSI, same for you, okay? So if you're handling feces and other waste products and then you have to go touch the patient for whatever reason, take your gloves off and put a fresh set on, okay? True story, intern, their first level 1 trauma in the ER, they're all excited. What's the intern's job in a level 1 trauma? The cool stuff like chest tube placement or intubation? No. Their job is the rectal exam. Yes. So intern dutifully does the rectal exam, okay, and then, okay, good rectal tone, no gross blood. And she starts to do the rest of the assessment. And I'm like, let's not put poop in the wounds. Oh yeah. Grabs another set of gloves. So reverse BSI is essential. They have risk factors like malnutrition, stress, the stress of illness, immunosuppressive treatments. Maybe they're a cancer patient, a transplant patient, an autoimmune disease patient. They are more at risk from you. So be sure you think about immunodeficiency and reverse BSI when you're doing transfers. Other workplace mitigation strategies. Avoid splattering. I know it's really fun to snap your gloves and into the trash can, but that just creates all kinds of airborne particulates. Don't do that. Proper handling of sharps. If you're walking through an ambulance with a sharp to go in the sharps box, you should do what? Announce sharps, 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 and people will move out of your way so that you can put it in the thing. Whatever you do, don't stick the sharp in the bench seat. I've seen people do that. They stick it in the bench seat as like a pin cushion, and then they take it out, put it in the thing.
Oh, I've never seen someone.
Yes, don't do that, because someone's going to sit on it. I guarantee it. Remove contaminated gloves. Like I said, no proper disinfection techniques. What does the label on the purple disinfectant box say about dwell times? What is a dwell time? How long it has to be on the surface? So lots of people think that if I take the purple and just wipe it, good to go. It actually has to stay wet for 3 minutes. You can't dry it off. You have to wipe your surface down. It has to dwell for 3 minutes undisturbed for it to work. So you don't just wipe it and you're done. Okay? So dwell times for disinfectants, make sure you understand that. All right? All right. Chapter 20 overview. There's lots more for the classification of microorganisms. Just understand things like kingdom, phylus, genus, species, right? For microorganism, understand pathogenicity versus virulence, the various types of infections. You should know the concept of antimicrobial resistance, and that means antibiotics don't work because we overuse them, for example. Organs and cells of the immune system, be sure that you kind of go over leukocytes, neutrophils, basophils, things like that. That's also in your book. And then, of course, protecting your cells, vaccines, PPE, and risk mitigation. We doing okay? Keep going? All right. Chapter 5, patient assessment. I'll say this is the first of the 2 big chapters we're going over. So patient assessment is going to be a lot of stuff, and then lab values and cell physiology basically is going to be the second one, okay? So let's see how far we can get under Chapter 5, patient assessment. Patient assessment in the critical care environment. What you need to know as a critical care paramedic is that you are not essentially using the same field assessment you learned in paramedic school as you do in the critical care environment. What do I mean by that? I mean that the patient acuity in your truck is going to be far higher than a standard ALS trip. That's why you're there. So the patient acuity is higher. It will be often dependent on technology not used in the field. In other words, a standard road paramedic may not feel as comfortable reading an art line and what an art line means and what the little squiggly lines mean. Okay, so your assessment is going to be way different from whatever you learned in paramedic school. Critical care patients have often already received treatment and stabilization before you got there. So not only do you have to understand their disease process, now you have to understand in report what they did. Because if they said, blah, 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 they're intubated, 20 at the teeth and blah, 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 and their P-plat is this, you have to know what that actually means, right? So you have to understand that their stabilization and treatment prior to transfer is already well above most standard, usual, customary paramedic knowledge. You have to then understand lab values and advanced imaging in addition to that. So we're going to talk about increasing your depth of assessment and the treatment of patients in the critical care setting, and that the amount of information that you get is going to vary greatly in the critical care setting. But wherever possible, you should use your response time while you're going to the call to develop some kind of a plan. So can you get an updated patient care report? If you can, you should. Provide an estimated time of arrival so that they can be prepared. You also don't want to just be standing there for 2 hours because they didn't know you were coming. So I know some of that is sometimes out of your hands, but where you can affect change, go ahead and do that. There are 4 major variables influencing your transport planning. One of them is, what's the reason for transport? Because a transport, just because they're on a vent and maybe a couple drips, is way different from they're on ECMO. What is a type of facility or location within the facility? Because going from a level 2 trauma transport to a level 1 is different from a critical access hospital with no trauma capabilities to a level 1 trauma center. Does that make sense? What they got first. You would hope that if you're going from level 2 to 1, they've been much more stabilized than for a critical access hospital. Make sense? Number 3 is, how long is your transport? Going from Barnes South to North MICU is not the same as from St. Joe's West all the way to SLU or Barnes, right? That's way different duration of transport. Or Mercy and Troy all the way downtown to Big Barnes. And finally, the receiving facility type and destination bed. Way easier to go to the ER because once you get there, you're there. But if you're going to the South MICU, one of the South MICUs at Barnes, it adds another 20 to 30 minutes to get to the ICU. It can take you 15 just waiting for the elevator, right? I mean, for real. So getting through the hospital to the elevator to the right place can add another 15 to 30 minutes. So that will influence your transport planning. What I mean by that is, if you're going just to the emergency department, you may not have to bring an extra O2 tank with you. But at Barnes, crews routinely bring an extra O2 tank if it's anything less than half a tank to get to the ICU, because it can take you 20 to 30 minutes to get there. And you don't want to run out of O2 in an elevator. Worst place to run out of oxygen. Okay? So that's going to influence your transport planning. So these are things that you wouldn't think about as a normal, usual, customary road medic. But as a critical care medic, this should be on your regular checklist. Okay? Understanding the variables helps you frame your expectations for your ongoing management plan. I'll tell you this, that the remainder of your textbook coverage in this regard talks about like logistical aspects of a call for service and getting your H&P and general paramedic level knowledge. We're not going to go through that because you're all paramedics already. We have very little time. So go ahead and just review that on your own, but we're not going to waste face-to-face time on that. Okay? So what we're going to do now is emphasize our own assessment priorities for the rest of our time on assessment. Copy? All right. Probably one of the most important assessment things that we at SCCAD want you to know is your pre-intubation airway assessment, if at all possible. If you have the luxury of doing a pre-intubation airway assessment, you should. Okay. Now, lots of times your patient will already be intubated, but can I convince you that somewhere an hour into your transport, they might somehow become dislodged, or they wake up and pull their tube out, or something happens where they say, oh, their airway will be fine, and then their airway is not fine and you have to do something? Nod your heads, yes, that can happen. So, patency.
Happened to me last night.
Do tell.
Yeah, we had a patient coming from ICU at St. Joe's St. Charles going down to SLU.
Mm-hmm.
They intubated with an 8.0 tube, and it was only 20 centimeters deep at the teeth, which, if you guys remember, that's pretty shallow. Like, it should be 3 times the interior diameter of the tube. However, I'm still getting a nice 4-point square waveform. Lung sounds were clear and equal. When we got him to SLU, they were a little overzealous when moving him over, and once we got him to the bed, it was now at 18 centimeters and was no longer producing a square waveform. And
Oh.
they had to re-intubate in right then.
Like right then and there.
Right then and there, luckily it was in one of the larger rooms, in the trauma rooms. They had all their equipment ready. It was at the ready right there, so they were able to do right back in.
Whew, that was a close call.
Yeah, so it does.
That could have happened to you en route.
It could have happened to us, yeah. So Adam, Don, and I were ready to go if we needed to. So yeah, some of you guys over there.
Very good. So just happened yesterday. So be sure that you don't take it for granted and that you have to manage an airway immediately, sometimes totally unexpectedly like that. So one of the things that will help you make that decision of like patency, anatomic barriers, pathologies, is a Mallampati score. And if you see someone like this at the top photo, or someone like that at the bottom photo, you already have just some physical barriers, right? Anatomic challenges to getting a tube in the airway that you know you're going to have. What is the Mallampati score trying to give you an idea about? I'm sure you're familiar with Mallampati scores. Say. How basically it guesses how easy or difficult it would be by the view or the POGO. What is POGO? Percent of glottic opening. So you want your patients to have a POGO score of 100, meaning if you see this, that means when you put the blade in, you should see the entire 100% of the glottic opening because they are a Mallampati of 1. Versus a class 4 Mallampati, your POGO might be 5%. Sometimes it's 0%. You don't see any of the glottic opening. All you see is the epiglottis, right? But you know that everything just underneath your epiglottis, that has to be airway. Still not the best, but at least hopefully, okay? But you know how difficult or easy it's going to be. That's what it means. Now, we know that once you get plastic in the trachea, or at least you think you do, the gold standard is still waveform capnography. Assesses for placement and positioning. You should still visually inspect for size and depth. And again, a good rule of thumb that Nate just said was 3 times the internal diameter of the tube is a fairly good approximation of where it should be at the teeth. So 20 on an 8.0 tube is a little shallow, right? You'd like to see it at 24-ish. Nonetheless, he also mentioned he had a nice, good 4-phase square wave, so it was in. Remember, the gold standard is not visualization even the chords. It's this. Why is that? Why isn't direct visualization even considered the gold standard?
Well, that's proof of gas exchange.
Yes, which is better. You would think that the gold standard would be seeing in. But remember that a lot of people think they're putting it in the trachea when in fact they're putting it in the esophagus, depending on their technique. Lots of people have fooled themselves and saying, I saw it go in the airway, and it was not in the airway. That's why the gold standard is still this, because that's still a little subjective that you were in. This is very objective. Either you have a 4-phase square wave or you do not. And the only way to get this is in the trachea. You might get a little blip if there's some gas in the esophagus, but it won't stay like this. Right? You might get a little squiggly line here. It's not 0, it's like at 5. So, well, I must be in the trachea. No, you're not in the trachea because it's not a 4-phase square wave. Okay? That is the gold standard. Okay? Now, you may get a 4-phase square wave, but what's the problem with this one? Yeah, you can see that it's in the right mainstem, and you may get a 4-phase square wave, but that doesn't mean it's correctly placed. It just means it's in the trachea, now is it in the right place? Well, this is a right main stem bronchus intubation, right? So then how do you tell? Good old-fashioned ears, auscultation. So you get a 4-phase square wave, that's great. You should still listen equally left, right, for equal bilateral breath sounds. More often than not, if it's main stemmed, it'll be on the right. Why? Because anatomically, the right main stem is much more a direct shot versus the left, which kind of makes a more of an acute angle, right? So if you're going to hear decreased breath sounds, it's going to be on the left, not the right. Okay. So you should prompt careful repositioning if it is way too deep. You shouldn't have only that much coming out of the mouth typically. Right? So we put a lot of emphasis on airway management in the form of optimizing your conditions using suctioning. We are strong believers in optimizing your airway and using suction devices. So we do not like the Yankauers. We like the Ducantos much better. You should at least know what these 4 types of suction devices are, because that might be on a test as well. But the Ducanto is, you'll get lots of hands-on experience with the Ducanto in your lab. But as you can see, it's much, much bigger. Dr. Ducanto sometimes literally takes Campbell's chunky soup, pours it into a bowl, and can suck that whole thing out with a Ducanto. But a Yankauer is made for dentist's office, for spit, right? So it's got the little bulb on there, but look how tiny the opening is compared to a Ducanto. What is a whistle tip? A whistle tip looks like a whistle. The hole is on the side, not on the end. Theoretically, it's a little bit less prone to gooping it up because you're not jamming it into crap. The side port, the bottom jams the crap away, the side port suctions suckable material. Okay. And finally, inline suction is just what it sounds like. It's inline, so it's built into that sterile tube. Typically for intubated patients, you can put on top of the anotracheal tube, do a deep suction, and get lots of mucus and crap out of there too, okay, for inline suction. Securing devices. This is your commercial Thomas tube holder, pretty popular. Make sure that whatever device you're using, you reassess it and that it's tight. And during transport, make sure you keep an eye on the depth, that it's not migrating either way, up or down. Just make sure that it stays. For pediatrics, there's a nice little cheat sheet. Anyone used the hand-heavy method before? Great. Super easy. They've got apps now. I think SCCAD will very soon be transitioning over to that app because everything you need is right there, including endotracheal tube sizes. So since most of you are familiar with hand-heavy already, you know how it works. It just kind of helps. It's a play on his name. Remember, Peter Antevy is his name. He's the guy who invented it, and you just use your hand. 1, 3, 5, 7, 9, 10 to 15, 20, 25, 30 kilograms, and so forth. What the size of your tube is, your first doses of epi, etc. So the estimated weight ages for 1 to 6 is 8 plus twice their age in years. From 7 to 2, it's 2 plus 3 times their age in years is how they figure out that estimated weight. But if you have this little cheat sheet, it makes it really, really easy. The other thing is how to estimate tube sizes. Again, cheat sheet's going to make it much easier, but just so you kind of know where the calculations come from. If you take their age in years plus 16, divide that by 4, that's your approximate tube size in millimeters that you should be using. Tube size times 2 is the French for your NG tube, OG, and Foley. Tube size 3 times the depth, centimeters, as was mentioned, so an 8.0 tube should generally be about 24, right? Tube size for chest tubes in French is going to be tube size times 4 is your chest tube. So, for example, a 4-year-old child would get intubated with a 5.0 chest tube. If you take a 4-year-old plus 16, 20 divided by 4, 5.0 ET tube. You then take your 5.0 tube times 2. You'd use you'd insert that a 10 French NG to ET would be a depth of 15 because it's 5 times 3 times, so that's 15 centimeters. If they needed a chest tube, tube size times 4 would be a 20 French chest tube. Okay. But we've been talking about units of measure like French. What the heck is that? So if someone says, I need a 5.0 ET tube, what does 5.0 refer to? It has nothing to do with the police. You might hear that on a SWAT raid sometimes. Hey, it's 5.0. No, if you want a 5.0 tube, what does 5.0 mean? It's the interior diameter of the tube in millimeters. Okay? So that's what 50 means for millimeters of your tube. What does 20 French mean? 20 French doesn't mean 20 Frenchmen on a bicycle. 20 French means the external diameter of the tube, whereas 1 French is equal to 0.333 millimeters. So a 10 French tube is 3.33 millimeters external diameter. A 24 French is 8 millimeters external diameter.
I guess just 8 millimeters is too hard to say.
You know, why in medicine do we even have French millimeters, centimeters? Why are some internal diameter and some are external diameter, right? It makes no sense. I don't, I don't know. If I made the rules, I would just stuck to one thing, one unit of measurement, and just call it good. The tan, yeah. The units and tan measurement, yeah. I need a 10 tan tube, a 5 tan. I like that. We'll come up with something that uses tan. Okay. Now, as if it wasn't confusing enough, guess what? French is directly proportional, but gauge is inversely proportional. How about that for confusing? Okay? So the higher your French, the bigger, but the higher your gauge, the smaller. In fact, that would make a great quiz question, right? And here's the other thing that is really baffling. Gauge has many different units of measurement as well. So anyway, so a 30 gauge needle is way smaller than an 18 gauge needle. Okay? But a 32 French is way bigger than a 8.3 French. Okay? All right. You hear someone that says, I want 0 silk on a straight stick. What does that mean? I want 0 silk on a straight stick. When would you hear someone say that? Probably if they just put a chest tube in, now they're asking you for 0 silk on a straight stick. 0 is the size of the thread. Silk is the material of the thread. And a straight stick means it's a straight needle, not a curved needle. Most sutures have the curved needles, right? But when you're sewing in a chest tube with 0 silk, it's typically on a straight needle. So 0 silk on a straight stick just means big old silk on a straight needle, uncurved. Okay? 0 silk is, comparatively speaking, like rope, which is what you want when you're trying to make a chest tube not move. You want rope, right? So 0 silk, you can see that with the naked eye very easily. From across the room, you can see 0 silk. That is 8O suture material, which the only reason you can see that is because the lights are making it easy to see, glistening, and it's a microscope. So ophthalmologists use 8O suture for the eyes all the time. Sometimes they use 10O. You can't even see, it's like hair. Okay? So that's units of measure that you'll see in critical care. The other thing I want you to know is even things like respiratory assessment. In paramedic school, we talk about equal bilateral breath sounds and where to put your stethoscope on the chest, etc. You do talk about briefly some patterns of breathing, but really not much beyond that. In critical care, we want you to understand that patterns are important. Rate, effort, patterns. So like this, for example. Why is it important? Because it's clues to underlying pathology. So what is Kussmaul respirations? Kussmaul respirations is most easily depicted on this line, right? Because this is someone who's breathing normally, just in and out, nice and normal. But this person is breathing like big in, big out, big in, big out. And is it slow or fast? It's fast, because look at this. I mean, it looks tachycardic, right? But this is your breathing. So they're just breathing fast, but also really heavy, like full in, full exhale, full in, full exhale. What are some conditions that would cause Kussmaul breathing? Typically acidosis, things that make you acidotic, because you're trying to blow off as much acids as possible in the form of carbon dioxide. So people in metabolic acidosis, people who are uremic, people who are septic, for example. The toxic alcohols, people who have a lactic acidosis, these are all people that are going to be trying to breathe this way. So especially as a critical care medic, if you suspect some underlying acidosis and you pay attention to their breathing, it may clue you in that this is probably underlying pathology, how they're breathing. So Kussmaul respirations. The other way that you assess respiratory is palpation. We don't spend a whole lot of time on palpation, but you really should in critical care. Things like identifying rib fractures, flailed chest, subcutaneous emphysema. These are all things that are easily missed if you're not intentional about finding it. safe mechanical ventilation. Part of your respiratory assessment is going to be involving the ventilator. And by the end of this class, all of you will be experts at the Hamilton T1 vent. It is the Cadillac of ventilators out there. But you're going to assess all the squiggly lines on that ventilator. You're going to assess tidal volumes, different pressures, different rates. Practice good cyclic care by assessing and reassessing their level of consciousness, especially in non-invasive positive pressure ventilation like BiPAP, because hopefully they're going to get better in your care. You're going to have to make some adjustments. And unfortunately, if they'd get worse, you're going to have to make some adjustments as well. Or move to invasive from non-invasive. We'll talk about that later. Something that you absolutely will be tested on, both at the IBSC and here, is lung protective strategies. How many of you have ever heard of that? Yes, at least? Good. Lung protective strategies. It used to be that we did more damage after intubating someone than good a lot of times because we just didn't understand this concept. We gave high volumes and we caused lots of barotrauma, lots of pneumonias, lots of iatrogenic pneumothoraces. It was bad. So we know that tidal volumes should be about 6 to 8 cc's per kilo of ideal body weight. If they have ARDS, probably a little bit less to start with, like 4 to 6-ish. It is way easier to use a table like this than to memorize anything. And we have this table available in the ambulance. I think it's posted in most of our ambulances. I do believe it's also in our app. So if someone is 5'10" and they're male, and you want to do 5 cc's per kilo, let's say middle of the road because they have ARDS, you can just go to 5'10", male, 5 cc's per kilo is going to be, 5 is 370, right? So 370 milliliters per kilogram is going to be 370. For a female of 5'10", 5 cc's per kilo is going to be 340. So it makes it very easy for you to set your parameters on your vent. And I would highly recommend that you just make it a habit to do that based on ideal body weight. Okay? So one of the things that you're going to look at is the normal pressure time curve. Again, you're going to be experts at looking at this by the end of this class. But just to kind of give you an introduction to the terms and what it looks like, can someone tell me why the curve looks the way it does? And it's labeled pretty well, so you should be able to tell me what this means even before you've spent a whole lot of time with the ventilator. So why does it look like this? So first of all, this part is inspiration or expiration? Inspiration. And it's usually a 2-to-1 ratio, like you're breathing longer by about 2 than you are inhaling, right? That makes sense. When you're just sitting here, you're like, right? 1 to 2, that's normal. So here, inspiration is about 1 second, expiration about 2 seconds. How come this doesn't go to 0 when you're exhaling? Yeah, because this is showing someone that has about 5 centimeters water of PEEP. And that's generally thought to be physiologic PEEP, right? You're never completely exhaling every milliliter of air from your lungs, even when you exhale. There's always a little bit, right? So physiologic PEEP is about 5 centimeters of water. Why is there a spike there and then a plateau? Even when you're normally breathing, why is that?
Time for gas exchange.
Yes, there is a little bit of time for gas exchange. Yeah. This is a pressure curve. So how do you explain that little peak in the pressure and there's a plateau? How about this? When you breathe, think about your breathing right now as you sit here. Are you breathing or do you breathe like this? You don't breathe like that, right? Because what would the curve look like if you breathe like that? It would look like a QRS complex. But it doesn't, because we don't breathe like that. We breathe like, we have a natural pause before we exhale. It may be milliseconds, but we do pause. We don't breathe like, we breathe like, so there's a little bit of millisecond of pause before we exhale every time you breathe. It may be imperceptible, but I think when I exaggerate it, it's obvious, right? We don't breathe like, we breathe like, okay. So there's when you inhale, it overshoots a little bit. That's your peak inspiratory pressure. And then that millisecond that you're about to exhale but haven't quite yet is your P-plat, your plateau pressure. And then you finally exhale all the way out. That's when it precipitously drops. And then you hit your physiologic peak, and then you repeat for every breath. Okay? Now, that's even more exaggerated on a ventilator, for sure, but we all breathe like that normally to some degree. Now, if you're doing a marathon and you're jogging and you're at mile number 25, then yeah, that may be very different because you are breathing more up and down just to stay alive. But when you're just normal physiologic breathing, you'll have this little P-plat that you can see. Does that make sense? Right. The reason why this is important to know is because when you have a patient who's sick and on a ventilator, guess what? You can manipulate that curve to your advantage. Depending on their lung physiology, which you're going to do a whole lab of this, so don't worry. Depending on your pathophysiology you're trying to fix, you can manipulate this curve to the patient's advantage. But you can't manipulate the curve if you don't understand this curve normally first. Right? So now that you understand what this curve means and how we normally breathe and how we breathe on a ventilator, now when you have an intubated patient and you're looking at this curve, you can manipulate that curve to the patient's advantage, depending on their pathophysiology. Okay? So let's look at the peak inspiratory pressure. The peak inspiratory pressure is that point right there. In somebody, so for example, in someone who has their highest inhalation pressure during PCV, or pressure-controlled ventilation, your normal peak inspiratory pressure is going to be about 22 to 26 centimeters of water. You really want to keep it under 35 centimeters of water as your peak inspiratory pressure. And your maximum really should be 40. So under 35 is a goal, normal 22 to 26, but you certainly don't want it to peg out more than 40. There is an exception to that though. What is that exception? ARDS. Again, ARDS is the one exception to that, when you might allow the peak inspiratory pressure to be a little bit better. What is the problem with ARDS? Is it oxygenation or ventilation? Well, depending on how, yeah, it is. In ARDS especially, you get very stiff, non-compliant lungs. And so, especially on positive pressure ventilation, to optimize oxygenation, you might have to allow for a little bit higher of a peak inspiratory pressure. But the problem is, you're still trying to balance oxygenation and minimizing at least barotrauma. Right? What is barotrauma? What does baro mean? Pressure, like barometric pressure, right? So barotrauma just means trauma that we create from too much pressure, positive pressure on lungs. But because ARDS has very stiff, non-compliant lungs, sometimes to optimize oxygenation, you have to give it a little bit, allow for a little bit higher peak inspiratory pressure. But you also have to do that fine balance between oxygenation and limiting ventilator-associated lung injury. So this is something that we're going to spend way more time on in the lab. But just understand this basic concept as you go into the lab and peak inspiratory pressure. That's all I'm really trying to do today. In cardiovascular assessment, you're going to think about things like skin color, temp, cap refill time, but vital signs to a critical care paramedic is way different in that you're going to have way more ability to trend than your typical, usual, customary ambulance trip, where you're with the patient for maybe 15 to 20 minutes. With IFT, you might be with them for several hours. Nate, what's your record for an IFT call? How many hours were you with the patient?
I had one that was mechanically ventilated, had an Impella, had 3 vasoactive medications, and then 3 other infusions that didn't require any titration. It was a heparin, an antibiotic, and I think maybe albumin, I don't remember. But from the point that I walked into the room to start getting a report to the time that I did handoff was probably close to 3.5 hours. Total.
That's way longer than your usual transport.
Yeah.
So,
I mean, the lion's share of that too is getting. I'm going to send out a checklist that I made to you guys, so you guys can kind of understand what we were talking about here. But the lion's share of that honestly was just getting all of the information straight. Probably, I would say the most of that.
yeah. Well, that's a ton of drips, a ton of different variables that you have to know. So yeah, but
Yeah, there are a lot of questions that we have to ask because when they're in like an ICU, for example, there's a diffusion of responsibility that happens once because there's an entire care team that's associated with it. So each one person is kind of compartmentalized It's so that we can keep track of and notice when things are starting to go wrong so that we can stop the catastrophe from happening, and then also have the ability that if we can't stop the catastrophe from happening, we can properly address it.
Yep.
And like that, I said that, and like you make your money with your information gathering. 'Cause you have to know like what to anticipate. So yeah, it takes a really long time.
And that's probably the take-home message is information gathering. That's something that as a critical care paramedic, you're gonna have to start getting used to because the information gathering, as you said, almost 4 hours, but the majority of that was information gathering because you don't wanna be halfway through a transport and say, what was that line? And why do they have that drip? And what was I supposed to do with that titration? That's the worst time to ask that is halfway through a transport and you're gone. So information gathering, understanding trends before and after sets and then in between, that's a change in practice for most of you. So all that information gathering and all the trending that you're doing is gonna take some getting used to. But once you get used to it, would it be safe to say that you kind of depend on it now, that you're used to it?
Oh, absolutely. And
Yeah.
like the other thing I was gonna add on it is you will become very surprised, like when you drop patients off at a receiving facility, how sometimes like major, very important pieces of information were not relayed to them. You know, and like they're getting it from you. You know, so,
Yeah.
so do not underestimate like how important you are in chain of custody as far as information is concerned.
Yeah.
I mean, again, it happened last night. Like, I had a patient, the patient that I was taking had pancreatic fasciitis that they discovered on the OR table at St. Charles. Decided that it was beyond their ability, and that's why they were sending them to SLU. I got down to SLU and I was like, yep, they discovered the infection while they were on the operating table. The doctor snapped her head and looked at me and, what do you mean the operating table? Like, she had no idea that this patient had already been operated on. She thought that they were being brought to SLU for the operation, not just for furtherance of care, you know, so.
Yeah, that's a significant detail.
Sometimes it just, again, like there's kind of confusion and responsibility that happens when
Yeah.
there's 10 people that are part of the care team, but then when it's just you and you're doing it, like, a really good, thorough report is, I mean, you can attest to
Oh,
this.
yeah.
When he was in anytime he was in the ED at Barnes, I'm sure, like, that information is as good as gold. Like, you know.
Oh, yeah.
A really good, thorough report, they will
Yeah.
absolutely let me know.
We absolutely try to teach our residents there at Barnes, do not let the ambulance personnel leave before you interview them first. And they're usually pretty good about that, like getting in before you leave, because we know that there's information that only you have. And it will, probably one of the biggest errors a paramedic can make on IFT is thinking, oh, the hospital already got a report, they know all this stuff. My only job is to tell them what happened en route. Oh, no, it's not. It conveyed the information you got at your report. And more often than not, I've gotten information that I never got in my report, that only the paramedic gave me, which changed management sometimes. So like, they already had an operation. What? That's really important to know. So these trendings, it's more than just words in a textbook. I mean, from a practical standpoint, you've got to be able to do that. This helps not only diagnostically, but your threshold for interventions, like they've already had surgery, or they've already gotten this medication or this drug, which may have been missed in report. That will change my threshold for an intervention or adding something else to management. It also indicates their stability or their lack thereof. And one of the most important indicators of stability is trending their mean arterial pressure. How do you calculate mean arterial pressure? There are several ways to do it. What's the easiest way to know MAP? Look at the monitor. Very good, smart Alec. But you're absolutely true. It's absolutely right? Some people still don't actually know that the number in parentheses here is supposed to be your MAP. So yes, but you should always trust but verify, right? And one way that you do that is doing some quick math in your head. This method is in many textbooks, but it involves fractions, like 1/3 and 2/3. Come on, I can't do that in my head. I can do this in my head pretty well. That's why I like this one better. I can double the diastolic, add the systolic, and then about 1/3 of that is my MAP, right? That's easy to do. I can do that in my head. I can't do 1/3 times this plus 2/3 times that. Way too much math, okay? This is why I like this particular one. I don't care which one you use for the test. And make no mistake, you'll have a test question where Chief Stewart wants you to calculate someone's map, and he ain't going to give you the monitor screen. So you should at least know how to do it. I like this one again because I just double the diastolic, add the systolic, about a third, and then about a third of that is what the map is. Okay. The other thing that you should know that we emphasize a lot here at SCCAD is the shock index. Has anyone here ever used shock index in their practice of medicine? A couple, yeah? Yeah. It's not very commonly used by paramedics, but I'll tell you, we are really, really pushing it here at SCCAD because we've been pushing it, but we are really going into high gear the next 6 months because of what development? What's coming in the next 6 months, hopefully? Blood, right? And one of our criteria for giving blood is going to be based on shock index. So what is the shock index? The shock index is simply heart rate divided by systolic blood pressure. So if their heart rate is 100 and their systolic blood pressure is 100, what is their shock index? 1. Very easy, okay, 1.0. Now, for adults, non-geriatric, it's not a horrible shock index, but it's above 0.9. So you should be very wary of that person decompensating quickly. In fact, someone that's less than 0.6 is considered to be not at high risk for shock. 0.6 to 0.9, maybe they're in mild shock. Anything more than 1 to 1.4, moderate. Anything more than 1.4 is considered severe. Now, there may be some variations of this scale, but that's a general rule of thumb. Okay? Notice that the threshold for elderly patients is not 0.9, it's 0.7. Why is that?
Their buffers for something like that don't work as well.
Their reserve, their buffer is almost none, right? I mean, the elderly have a much lower tolerance for shock. And so we don't want to wait till they hit 0.9 or 1 if they're bleeding. If they're hemorrhaging and they're at 0.7 already, we're going to give them blood. We're not going to wait for them to code. We're not going to wait for them to decompensate. Okay? So you should definitely know how to calculate heart rate divided by systolic for your shock index. The way this usually will come up in a test question, either, I don't know if IBSC, hey, does IBSC have shock index questions or just our exams? Do you remember?
I think they also.
Do they? Okay.
They had it in there when I took it.
When you take it? Okay, shock index, okay. So you should definitely know it. I'll tell you in our exam that we write, the way that we often will see if you understand it, we'll give you a scenario. We won't tell you what the shock index is, but we'll give you all their vitals. And a second order question is you're going to have to realize that, okay, this is a sick patient, and you have a series of test, question, and answer choices, but the differentiating factor is we want to see if you had the wherewithal to calculate a shock index and realize, oh, it's 1.1. Or it's above 1. You know, it's going to be above 1. And then you have to intervene on it. Okay. So sometimes it'll be a first order question where we actually tell you what the shock index is, but more often than not, it's going to be second order where we give you the vitals. And you have to know the shock index. Make sense? All right. So some gastrointestinal pearls that you might see. We want you to, when you're looking at the abdominal exam, you inspect the abdomen, then you auscultate the abdomen, then you palpate the abdomen in that order. Why can't you do it in reverse order? Like, why do we say inspect it first, then auscultate, then palpate?
Because you say it that way, so we're gonna do it that way.
Yes, but why do I say do it that way? Smart aleck?
If you palpate, you can mess up the accuracy of your auscultation.
Yes. So if you palpate first, you're mashing on someone's belly first. That might irritate it or upset it, and that might trigger borborygmi, okay, which is the medical name for gurgly sounds, okay? And you may irritate whatever condition is underlying. So that's why we would go least invasive to most invasive first. Okay, so least invasive first is inspect it. Just look at it. Do you see bruising? Do you see swelling? Do you see ecchymosis? Do you see distension? Okay. Does it look like the movie Alien where something is underneath the skin trying to get out? You know, do you see, movement underneath there? So you're inspecting it. Then you auscultate. Now, even auscultating, you're putting a little bit of pressure on the belly, but you're not like mashing on. You're not palpating. You're just putting the stethoscope on their belly and listening. Do you hear bowel sounds or not? hyperactive, hypoactive, normal sounding bowel sounds, what do you hear? Then you're palpating, you're feeling for masses, AAA, tenderness, stuff like that. Okay? Kerr's sign is pain in the left shoulder when you palpate, typically from diaphragmatic rupture, or diaphragmatic irritation rather, from blood, like a ruptured spleen. So blood is very irritating the diaphragm. A lot of times when you have peritonitis, it's from blood that's irritating the diaphragm. And so if you have a ruptured spleen and it's bleeding, you can get that pain in your left shoulder. So it's not because the shoulder has a problem, it's because there's bleeding in the belly. So I always have a bad feeling whenever an MVC patient comes in and they've got seatbelt sign and they're like, man, my shoulder, I must have hit it on the door because it's really hurting. And I look at their shoulders, and there's no bruising there, there's nothing on the shoulder. I'm like, oh boy. And more often than not, they got a solid organ injury or something.
So do you ever come across them having that shoulder pain without the abdominal pain?
Yeah, sometimes the abdominal pain is not as prominent. Like they have a seatbelt sign, but their pain is ironically a lot. They have some tenderness, but it's not horrible, but they're complaining of left shoulder pain. And that's from blood, from diaphragmatic irritation. That's Kerr's sign. So remember, just like almost every sign in medicine that's classic, it means it's there maybe 25% of the time. So it's not helpful if it's absent. Do you mean what I'm saying?
Yeah.
Like if someone does not have Kerr's sign, I can't say, well, they don't have bleeding.
Right.
But if they have it, I'm super concerned. Okay. Just like an EKG, what is the percentage of their first EKG and chest pain in someone who's actually having a heart attack, having any kind of changes? Either T-wave inversion, STEMI, ST depression, anything. Do you know what the percentage is? That's a little bit better than that. It's about 50%. So it's literally 50-50. So a person with chest pain that has a normal or unchanged EKG, I might as well go, doop, it's 50-50. In other words, an EKG is only helpful if it's positive. Just like Kerr's sign is only helpful if it's there. Okay, if it's not there, it doesn't help me at all. If the EKG is normal, but I have a hypertensive diabetic smoker with chest pain, they're getting admitted for an MI workup regardless of what their stupid EKG says, right? But if the EKG shows a STEMI, it's a fast track to the cath lab. That's the only change, right? So, okay, good. The other things that you may see are Gray-Turner sign. Gray-Turner sign is an example of internal bleeding. Remember, Gray-Turner is not hyphenated because Gray-Turner was his name. A lot of people hyphenate Gray-Turner like it's two last names, but it's not. Anyway, Gray-Turner sign is typically a sign of just internal bleeding. Cullen's sign is another example of internal bleeding, but this is periumbilical. It's much more, it was originally indicative of a ruptured ectopic. So it was developed by an OB doctor, Dr. Cullen. So Cullen's sign. Again, if it's not there, doesn't mean they don't have a ruptured ectopic, but if it is there and you suspect the ruptured ectopic, this is very, very bad. So just know that. Okay. Some neurologic pearls. You all know how to do AFPU, GCS, the Richmond Agitation Sedation Scale, or RAS, yes? Okay, that shouldn't be anything that's new to you. A good review in your book, just go over that. Pupil assessment, checking for size, symmetry, and reactivity. This is your typical pinpoint pupil, right? This is indicative of an injury. You can see part of the iris coming through what is an actual globe injury. What is the medical name for that? What do you see there? Anisocoria. Anisocoria just means unequal pupil, okay? Some may say that's a blown pupil, okay? What if you see what is a blown pupil supposed to indicate? Brain. Yeah, uncle herniation typically when the brain is herniating from brain swelling. That's usually seen in severe trauma, right? What if this person is like that, but they're awake and talking to you, no head injury at all? It might be normal. What else? Let's say they don't even have pain. There's no headache. Their mental status is normal. It could be. It could be something old, like a past injury. You ever heard of corn picker's eye? Corn picker's eye was, it's just because like certain chemicals, insecticides, etc., if they get on their hands but then they rub their eye, it can cause a pharmacologic dilation. So it's, they're not blowing their pupil from brain herniation, they just have a chemical pharmacologic dilation. Okay. Maybe they were just at the doctor's office and had a dilation because they had an ophthalmology exam or an eye exam. You can ask them that too. But no, someone like this, they're unconscious and they are not known to have anisocoria. You do worry about brain herniation, things like that. So now, your secondary assessment. Your secondary assessment, reviewing head to toe like you've been taught in trauma classes, but evaluating for change in condition. You're repeating your vitals. Again, we talked about the importance of trending, map and end tidal. You want to manage your pain, you want to manage your temperature. You'll likely get a 12 lead, and remember, a 12 lead EKG, a single 12 lead, say, in the management of acute coronary syndrome is malpractice, right? You can't do one 12 lead and call it good. A 12 lead is only a snapshot in that 6 seconds of time. That's all it is. It doesn't tell you what happened in the previous 6 seconds or the after 6 seconds when you hit the stop button. It only tells you what happened in that snapshot in time. So I have caught many STEMIs in my career on the third or fourth 12 lead. So especially if you're really suspicious this person is having a dynamic acute coronary syndrome, you should take several 12 leads as you go. Okay? Low suspicion, at least get 2. Okay? So you can trend them again. But high suspicion, you should be getting one every 3 to 5 minutes until it changes, and it probably will. Okay? There's a concept in critical care medicine that will follow you through this entire course in your career. That is this, that the eye only sees what the mind knows. Have you heard of that before? The eye only sees what your mind knows. It means that if you have never heard of corn picker's eye, you will never diagnose that, or you'll never see it. But now that you have heard of it, when you see anisocoria, that's something that you'll think of in your diagnostic, perhaps, okay? So it's important for you as a critical care medic to really start expanding your differential diagnosis about what things can be. You have to know certain things as a critical care medic in order to ever diagnose it. So what if you see this? What if your eye sees a fall in your systolic blood pressure every time someone takes a breath in, an inspiratory? Like they breathe in and their systolic blood pressure falls by 10, or you can't feel a radial pulse. Every time they take a deep breath, you can't feel the radial pulse anymore. Very good. And notice pulses is not pulses like SES, it's SUS, pulsus paradoxus. It means a drop in their systolic of usually around 10 with inspiration, which you normally shouldn't get. Clinically, you lose your radial pulse when they breathe in. How do you explain that physiologically? Like, what's going on? Very good. So that is one of the first things that you should think of, especially if you're transporting a patient, let's say, that has, it's a trauma patient. They're going to a level 1 trauma center for rollover MVC. They've been stable. Now all of a sudden they're not so stable, and you notice that when they're breathing in, they're like, I'm losing their radial every time. They're developing pulsus paradoxus. Now, if you had a suspicion for tamponade, now that suspicion just went really high, right, all of a sudden. So good. Your eye sees what the mind knows because you know what pulsus paradoxus is, and that's what you're ready to diagnose. Physiologically, how would you explain this drop in systolic pressure? There are many mechanisms. What's a proposed mechanism? Proposed mechanism. You're right, tamponade is one of the classic examples. How do you explain it, though?
The pressure in the chest cavity isn't allowing as much cardiac.
Yes, cardiac output is dropping. Can you put it all together? Like, what's the pressure doing?
Due to increased pressure on the heart, so it's constricting the heart.
Squeezing the, or not letting the heart expand all the way, so it can't.
Well, it's not letting the heart relax.
Right. So what's happening to venous return?
So you're not getting,
When you take a deep,
getting venous return because it's backing up.
when you're taking a deep breath, what normally happens to venous return? Go up or down? What happens to pressure in your chest when you take a deep breath? Well, the reason why air is going into your mouth and nose when your diaphragm drops is because there's negative pressure, right? We're negative pressure breathers. This is the concept behind sucking chest wounds. Besides the fact that chest wounds suck, it's sucking because that becomes the path of least resistance. It's trying to equalize pressures. So if you have a big hole in your chest, it's actually easier to go in this hole than it is your mouth and nose. So the patient is breathing, but they're suffocating because all the air is going here instead of here. So you just put your hand over that hole, now they're breathing again. Okay, so we are negative pressure breathers. So the pressure inside your thoracic cavity begins to fall, become negative when your diaphragm drops. That also brings in more blood typically, right? But what happens when you have tamponade is the increased venous return dilates the right atrium more because more blood is coming in to a heart that's already kind of being squashed by the tamponade. It makes the left atrium smaller in the setting of tamponade because the heart is being squeezed, but that increase in venous return kind of is now, the right atrium is kind of pushing against, theoretically, the left atrium, making it even smaller. So now the left atrium has that much less blood to put into the left ventricle. The left ventricle preload is reduced, which is already reduced because of a tamponade. So therefore you have a double whammy. The atrial kick has way less blood to kick in, and then the left ventricle has way less blood in the first place from tamponade. So now you have a double whammy. Your stroke volume is that much less with inspiration. So now, because your forward output is being squished from both the increased venous return, right atrium squishing the left ventricle, left atrium rather, left ventricle being squished by the tamponade, decreased stroke volume during inspiration, pressure drops. Remember, your radial pulse, a pulse is just a physical wave, right? It's a physical propagation of blood moving forward. So if that physical propagation is less during inspiration, that's one of the theories of pulsus paradoxus. Additionally, the increased volume in the RFV decreases the LV volume by the same exact mechanism. So the left atrium and left ventricle theoretically are already being squeezed by the tamponade. Then the increased venous return to the right atrium and left and right ventricle are further squeezing the left atrium and left ventricle a little bit more, and so stroke volume is decreased that much more. That's one of the theoretical mechanisms of pulsus paradoxus, and there are some. While tamponade is one of probably the classic example of why pulsus paradoxus exists, things like constrictive pericarditis is also similar. Right ventricular infarction is another reason. From a pulmonary standpoint, look, tension pneumo does the same thing. A PE might do the same thing. COPD might do the same thing. But clearly, cardiac tamponade is the classic example of why that happens. How about this? What if you have hypotension with a narrow pulse pressure, muffled heart tones, and JVD? Very good. That is Beck's triad, named after cardiac surgeon Claude Schaefer-Beck. They used this to also diagnose cardiac tamponade, but it can also be used to diagnose tension pneumothorax. So how do you know the difference between tamponade or tension pneumo if someone has muffled heart tones, JVD, and hypotension? Lung sounds. Bilateral lung sounds that are equal, but probably not tension pneumo, it's probably tamponade. But you have a trauma mechanism, maybe subacute emphysema, unilateral lung sounds, you probably want to do a chest decompression and not a pericardiocentesis. Okay. Very good. How about this one? Your ICs, hypertension, bradycardia, and very irregular respirations. Now, some textbooks will use widened pulse pressure instead of irregular breathing, but this is known as what? Cushing's triad. Okay, Cushing's triad, which sometimes can indicate ICP problems. But Cushing's triad is the clinical manifestation of Cushing's reflex due to brain ischemia, often from increased ICP. Activates the sympathetic nervous system in an effort to increase cerebral perfusion. The body just knows, hey, my brain needs more blood, and it's trying to get more blood to the brain through hypertension, bradycardia. Okay, good. What if you see this breathing pattern? Very good. You've heard that before? Cheyne-Stokes respirations, shallow, then big, and then shallow, then apneic, shallow, deep, shallow, apneic. Okay. This repeating pattern is also often associated with sometimes hypoxia, drugs, brain injuries to the respiratory center. It's not a good prognostic indicator when you see Cheyne-Stokes respirations. Not to be confused with Bio's respirations. The reason why we don't talk about Bio's respirations very much is because Well, a lot of things. One, the literature is pretty contradictory over what causes it. Number two, patients in a critical care setting, this would often be covered up by the vent and meds anyway, but it's just that's why it's not clinically useful today. It's just a historical thing for you to know. The other one is that we mentioned once already is Kussmaul respirations. They're breathing fast and deep, inhalation, exhalation, typically in acidotic states, trying to get rid of CO2. So understanding that is also very important. How about this? Hypotension with a discrepancy of more than 20 millimeters of mercury in their blood pressures in each arm. Yeah, you worry about, well, I've heard AAA, I've heard dissection. Which one is it? Well, I'm glad we're talking about this. Actually, I reviewed a textbook once where they kept using the term dissecting aneurysm as if it was the same thing. And I said, these are two different things you're talking about, and you're using the term like it's the same thing. Is it a dissection or is it an aneurysm? So half of you are saying that this is indicative of a dissection. Others are saying it's an aneurysm. I will say, is it possible to have a dissecting aneurysm? Yeah, it is. That's a really bad day, but usually it's one or the other. So what's a dissection and what's an aneurysm?
Aneurysms of the vessel, while dissection is the active separation of the inner lumen and outer lumen.
Good. So then, for this discrepancy, this arm has a blood pressure of 180 over 60, and this is 110 over 60. Aneurysm or dissection? How about this? What if I showed you the anatomy? Is it a dissection or an aneurysm? So you have to ask yourself the question, why is my blood pressure higher in one arm and not the other? So think about this here. Where am I typically getting my blood pressure? Brachial artery, right? I put my blood pressure cuff over here, and that's where I'm measuring from. But then work backwards. Where does the brachial artery come from? Where does the subclavian come from? Where does that part of? The aorta. Good. So now that you work backwards, the origin of where our blood pressure is coming from, now answer the question. Where are aneurysms typically and where are dissections typically? Higher, right? Near the artery. Good. So when we talk about dissections, which is a separation of the layers of the aorta, that usually occurs higher up in the aorta, like up in the arch somewhere, right? That's where dissections usually are. I mean, you can have it down here too, but the ones that are going to cause a discrepancy in your blood pressures in the brachials are going to be coming from higher up, right? Because if you say that aneurysms are more typically down here, a thoracic aortic aneurysm or an abdominal aortic aneurysm. I also hear people say AAA a lot to mean aneurysm anywhere, and that's not accurate either. Because if there's an aneurysm here, that's not a AAA. That's a thoracic aortic aneurysm. Make sense? Now, most commonly, aneurysms are in fact here in the abdomen. Those are AAAs, abdominal aortic aneurysm. It's the ballooning of the vessel. And if the aneurysm is here, will that affect your blood pressure at all up there? No, because it's coming off the arches, right, of the aortic arches, coming down here to your brachials. Makes sense? That's where you're checking your blood pressures. Okay, so now that we've had a nice quick anatomy review, you can see how if I have a dissection, which is a type 3B, that is distal to where the takeoffs of the subclavians are going to come from, right? So my blood pressure should not be affected. But if I've got a dissection up here, a type 1 or a type 2, particular type 1, in a type 1, I may actually have equal blood pressures that are equally low because it's dissecting through both the takeoffs for the left and right subclavians. Make sense? But notice, if I have a type 2 dissection and it only goes up to here, it doesn't involve that one. Which arm is going to have the lower blood pressure, my right or left? Remember, you're looking at the patient this way, that's the left and that's the right. So the right will probably have the lower pressure, right, because it's dissecting through the origin of my right brachial artery. It's stealing blood away from it because some of it's being shunted into the dissection. Whereas my left arm is still getting the full flow unimpeded by a dissection. So it might be higher over here. Does that make sense? And it's a lot easier to understand when you look at the picture. Versus down here, my dissection is not affecting my blood pressures at all because both the left and right are getting equal flow. Make sense? So back to the original question. Someone has a discrepancy of more than 20 milliliters of mercury in their upper extremity blood pressures. Are you worried about an aortic dissection or an aortic aneurysm? Dissection. Okay. More specifically, you're worried about a type 1 or a type 2 aortic dissection, okay? Which means it's higher up, which means it's more likely operative. A lot of dissections, like beyond that, they might manage medically depending on how stable or unstable they are. What's interesting is that a type 3B or or this one can actually cause, what arteries are those? The renals, right? That's the left and right renal arteries under the diaphragm that feeds your kidneys. This can cause renal failure that can cause the left to become hypoperfused, an infarct or fail because it's not getting any flow anymore. And that can cause its own problems, but it's not going to cause a discrepancy in blood pressure. Make sense? Okay. Yes. So the other cool thing that you'll notice in your handout is that this diagram especially is super useful to know as far as the secondary assessment based on location of aortic dissections. So if you have, again, pulse deficits, you're going to think about more proximal aortic dissection near the arch. If you have paraplegia, like they can't move their legs anymore, but they've got a blood pressure of 210 and they've got pain that's radiating to their back, and now they can't feel their legs anymore or move, now you're thinking the dissection is actually lower and it's taking out the iliacs and also the blood supply to the spinal cord at that level. Now the spinal cord is getting ischemic as well, and it's basically causing a spinal cord injury from ischemia, not from a trauma, and they're paraplegic now. Or they've got an ischemic leg. Here we talked about renal infarction. Another bad one is ischemic gut. Remember, your mesenteric arteries also come off about the level of the renal artery, somewhere around there. If it dissects through your mesenteric artery system, you get ischemic gut pretty bad. In fact, they're going to present more like you think appendicitis or a real bad stomach flu or something innocuous like that, when in fact they've got dead gut, which has a very high mortality rate, right? But all these things you would suspect with hypertensive emergencies. So someone who's super hypertensive especially, they've got all these weird symptoms, you got to think about a dissection, but also where is it dissecting through? So it depends totally on which artery is being compromised, right? So I like this one because it tells you basically how to think about people's otherwise vague symptoms in the setting of a suspected dissection. How do you think this sending facility is going to manage these patients? Because they're going to want you to leave as soon as possible. They say, get out. Just put the patient on your stretcher and go. You're like, wait a minute, time out. I still need a report. Just tell me what happened. What have you done? Okay, and they're probably going to be controlling their pain with some opiates, okay, some fentanyl, morphine, whatever. They're also going to want to give beta blockers, like labetalol and esmolol. I guarantee you they'll probably be on an esmolol drip. Why beta blockers? Why is beta blockers the favorite for dissections and aneurysms? Why not just nitroglycerin? That is true.
Well, the beta blockers, you can control blood pressure through the heart rate.
Yes.
Vasoconstrictors, you don't want to mess with the arteries, and sorry, I got something in my eye. But
You're going to give yourself anisocordia? Yeah, so beta blockers will attack the problem both ways. So nitro would just decrease afterload, but it won't do anything to the pulsatility, right? It won't do anything to contractility, heart rate, anything like that. You want to attack it both ways. You want to attack it from the impulse. Impulse is what? Impulse control. When they say impulse control, that's like the pounding nature is what's causing the problem, right? So not only do you want to lower pressure and afterload, but you also want to decrease the pounding itself, okay? So you give nitro that reduces afterload, but it does nothing to the heart rate of 100, right, or the pounding nature of it, but you can slow not only the pounding through reducing the rate down to 60-ish from 100 and instead of a big old squeeze like normally, you make the squeeze a little bit weaker. So your impulse control, but you're also going to do a little bit of vasodilation to reduce afterload. So the pressure going across the dissection is what you're trying to reduce. It's impulse control, and only beta blockers do that ideally. So almost all of them are going to be on beta blockers, and then that's the impulse control, and then of course they are decreasing afterload. So they're going to be on a nitroprusside drip or nicardipine, probably both impulse control and afterload reduction. So expect them to be on pain medications to reduce their anxiety and sympathetic nervous system response, beta blockade for impulse control, and then afterload reduction like nicardipine or nipride drips. All those things, because they don't want that dissection to keep on going. Because the further down it goes, the more organs it's destroying, right? So we want to keep it from getting any bigger.
So as far as blood pressures go, that says use arm with higher BP. Is that going to be your more accurate blood pressure?
No, they're just trying to go for the highest, like the arm with the highest BP is what they're trying to control because that's your highest pressure. So if you're already using the arm with the lower BP, well then you don't know what you're actually chasing because it's already artificially low. You want to use the actual impulse control, which is going to be your higher blood pressure. Make sense? Okay. Because if I'm starting with the pressure already is 80, I don't know what my target should be. I want to go with the one that's 180 and get it to 110. Cool. All right. Then reassess, reassess, reassess. I can't tell you how important it is to do your vital signs are vital. So reassess them a lot. Make sure you've got good vascular access. Mind your tubes, GI tubes, GU tubes, neuro tubes, airway tubes, all your tubes. You're going to have to mind. As Nate said, his last one last night had all kinds of tubes. He had vascular tubes, he had airway tubes, he had drips, the whole 9 yards. So that's a lot of stuff to keep track of. The reason why we spent so much time on that is really because patient assessment is still the bedrock of clinical medicine. All the awesome ultrasound machines we have and CT scans and blah, blah, blah will not take the place of your eyes and ears looking at the patient and examining the patient and understanding the pathophys. Best example, I'm so glad this happened organically, is your all's understanding now of dissection versus aneurysms, right? Because you instantly knew what these things meant because you learned that in paramedic school. But now as a critical care medic, you got to know the why. Yes, correct answer is dissection. Now tell me why. Now you can tell me why, okay? This entire semester is all going to be about the why. You're already paramedics. That's why we're skipping the whole thing about, you know, how to use your stethoscope. You should know that already. What we are going to teach you is where to place your stethoscope, how to interpret what you're hearing. You already know what a dissection and aneurysm. Now it's going to be why. Like, tell me why you have discrepant blood pressures. Tell me why not every dissection has discrepant blood pressures. Now you can tell me why. Isn't that fun? This is what you get in this class for. And we're going to go through all semester like this. I'm going to say, okay, you know the answer, smarty pants, now tell me why. And that's the fun part. Cool? Critical thinking, that's what you're doing. Expanding your differentials. All of you can give me a couple reasons for chest pain, but by the end of this semester, you're going to give me 5 reasons that have nothing to do with the heart of chest pain. Things like that. Expanding your thought process, reassessment. These are all fundamental tenets of critical care medicine. Right? Any questions? Shoot. I'm sorry, I'm 8 minutes into your lunch. You're still going to get, did we get 30 minutes? That what we gave you, or 45 minutes? Did y'all bring a lunch? You have to go get it. Okay. How about be back, can you be back at 12:55? You think that's enough time? Okay, cool. Be back in your seats, ready to go at 12:55. Well, thank you for coming back. Quick check-in. You doing okay? Are we going too fast, too slow? About right? It's actually about right? Okay. Sometimes I talk kind of fast, but we have so much to go. We have a total of 271 slides just today, and we're about halfway through. So I think we'll make it through everything by 5. So
It's nice to, like, kind of dictate the pace based on what we're talking about, like to stop and talk about aneurysms versus dissections, even if that wasn't.
that's what I'm trying to do.
It's nice to.
Yeah, I'm trying to gauge where everyone's at, and the nice thing about having a relatively small class is that we can do that.
Very low end, so.
Okay. Oh, and
Half step of crane eaters.
Yeah.
but at least it's a half step above.
Yeah.
Okay. We had someone join us after the introductions. Tyler, you want to say hello to everybody, who you are, what you're doing?
Hello, my name is Tyler Albrecht. I'm a new hire here. I was part of the class until I got hired. New hire orientation kind of got into the way of me being able to take this class. I have my board certification as a CCP. I just had never taken the class, and I wanted that opportunity, and Brian Stewart is letting me sit in on this class, so that is what I decided to do whenever I'm off on Fridays.
Cool.
Sit with you guys.
So auditing the class, and that's great. Welcome. Nice to have you. He's going to let you sit in this afternoon?
Yeah.
Awesome. All right. Will, you want to say hello and tell everyone who you are?
Hi, my name is William. William, I work at St. Charles City Fire, and I just got on the SWAT team, and this is one of the requirements. So, and I've wanted to do critical care for a little bit now, so this is a good reason to do it.
Awesome. Welcome, Will. Nice to have you. So, see, Solomon, you're not the only hose dragger in here. Yeah, makes you happy. And look, both of them sit in the back row. What's up with that? We got prime front seats open here, but okay, that's okay. All right, folks. Good. I'm glad to hear that we're doing okay. The pace is okay. If there's anything, again, that just we need to spend more time on, just holler, and we'll try to stop and do that. This afternoon, the timing is perfect because we're on our last chapter, Chapter 9, Lab Values and Analysis. And it's going to probably take us all of the rest of this time to get through it. It's a big one, but it's a very, very important one. I'll tell you, one of the most common reasons I get when I ask medics, well, why do you want to become critical care? What's something you really want to learn? Very often they say labs. Like I do these transfers, and they hand me a stack of labs, and I don't know what half of these mean, and I want to know what the labs mean and what the significance is of it. Well, today's your lucky day, because that's what we're about to spend the afternoon on, lab values and analysis. And a little bit more on that, we're going to also spend time along those lines helping you become more facile and skilled at interpreting scientific studies as well. Because another thing I get from critical care students is I also want to learn how to pick up a journal and read it and say whether this is crap or not. And I just don't know enough about studies and to understand whether something is good or something is crap. So that's something else we're going to talk about in the next few minutes, okay? So lab tests. Lab tests are something that you're going to start getting a lot of and paying attention to a lot more, because in a critical care transfer and transport, you're going to often see these things, which can include analysis of blood, urine, cerebrospinal fluid, and other bodily fluids. And so having some understanding of how this affects your care and the patient's status is going to be important. What I want you to know is that as a critical care clinician, your responsibilities include understanding just normal ranges for each lab value, and then what is the physiologic meaning of each test? And then if they are abnormal, how does that help you as a clinician to anticipate, plan for problems or interventions that will occur during transport because of those test results? And that's probably the one thing that really differentiates you from a usual and customary paramedic, which is, okay, if you kind of can see what is normal and abnormal, that's great, but what do you do with the abnormal ones? And what does it mean? That's what's going to help differentiate you from everyone else. So tests and imaging studies really supports an evidence-based approach to patient care. As we mentioned this morning, SCCAD is just a few months away from getting blood to the patient before they get to the hospital. And one of the things that we said was using shock index as one of several criteria: who gets blood, who doesn't get blood. Well, we're using an evidence-based approach to patient care because we're looking at, from all our trauma studies, who benefits from blood, who meets, this is where we get our inclusion criteria from, all from evidence-based data. Understanding this data is going to be invaluable in anticipating, preparing, deploying things like blood and other critical interventions, and then establishing trends. And that's one of the things that's super exciting about pre-hospital blood, because in looking at systems that have already started this, you can see things like their shock indices getting better before they hit the ER. Mental status improving before they hit the ER. And that's something that we've never been able to see, at least not as impressively as with blood. Blood is probably one of the most significant pre-hospital interventions in decades. And so we're going to get into some pretty nerdy stuff ahead as far as lab analyses, but it's going to make you a more sophisticated paramedic when evaluating the latest and greatest stuff. As a paramedic, especially if you go to trade shows like EMS World and stuff like that, you're going to be inundated by vendors trying to say, hey, this is the best and this is the greatest and you need to buy this test, you need to buy this equipment. And what you really need to ask is, well, what is the accuracy or precision of this instrument, this test, the sensitivity and specificity of this test, validity? What is the positive predictive value, negative predictive value? And I guarantee you the vendors will not be able to answer your questions, okay? But it will let them know that you're not just going to fall for a flashy device. You want to know how it works and why it works. And so in order to be a discriminating paramedic, you have to understand these concepts so that you can be discriminating and say whether this is crap or whether it's quality or not. So first of all, the principles of lab analyses and lab tests. Don't you want a test that's accurate and precise? Or do you want it to be both? Is it possible to have a test that's accurate but not precise? Or a test that's precise but not that accurate? People use the term accurate and precise interchangeably. They're two very different things. The easiest way to explain it is through this illustration, right? Everyone understands the concept of a target. Well, if you have a test like this, this is a great test. It's accurate and it's very precise. But what about this test? If the bullseye is considered the truth or the goal, is that test in the top right corner accurate or precise? It's all over the place, right? So it's not at all precise and it's not accurate. Whereas in the top right corner, that is very, very precise. But is it anywhere near the truth, the bullseye? So what can you say about that test? Low accuracy, but very precise. Okay. If I'm teaching a new shooter how to shoot, and I say don't change anything, just put where you think the bullseye is, put the front sight right there, and just slowly squeeze the trigger, and I'm watching their technique, how they shoot, and it looks like that, that's really great, because I can fix that. This, I'm not sure what to do with this student. I'm like, you know what? You should probably just get some pepper spray or something. Okay. But this one, it's either I can fix the rear sight to make it more accurate, or I can watch if they're healing it a little bit or something, right? So that's something I can fix. This high accuracy but low precision is also actually pretty good, something that I can help and work with. But this is what we aim for, of course, as a shooter. Now, other than precision and accuracy, there's also a concept called validity and reliability. Very close to accuracy and precision, but a little bit different. So when you say a test is valid, validity measures the accuracy of a test or degree of achieving your intended result. So again, the bullseye is the target. It's either your intended result or it's the accuracy. Reliability, however, is the consistency or reproducibility of a result. So kind of related to precision, right? Low accuracy, high precision. This is also kind of it's reliable, but not valid if the target is your goal, right? Here, these two, low accuracy, low precision, low validity, low reliability, not reliable, not valid at all. This is both reliable and valid, kind of akin to our previous slide, which is high accuracy, high precision. Okay, so a little bit related. The reason why validity is important to understand is because if we say validity is the accuracy of a test or the degree of achieving an intended result, and you apply that to a lab test, for example, you want a lab test that is valid, that has validity, meaning how accurately a test is able to correctly classify patients who have disease versus those who don't. And this is what we really want as clinicians. We would love 100%. Is there any test out there that's 100%? No. I mean, even home pregnancy tests, right, are almost 100%, but not quite. They're pretty high, right, but they're not foolproof, not 100%. So Validity depends mainly on two things that are typically inversely related. I'm going to pause here because this is a very important concept. Okay? So validity is related to sensitivity and specificity, which are inversely related. Meaning, the higher a sensitivity of a test, typically the lower its specificity is going to be, and vice versa. The higher a test specificity, the lower it tends to have sensitivity, at least a good test. Okay. What then is sensitivity and specificity? Well, sensitivity is accurately detecting someone who actually has disease. You follow so far? Sensitivity, accurately detecting a person with disease. In other words, if a test has high sensitivity, most people with the disease will test positive. That's a true positive. That's good. That's green, thumbs up. That's what we want. In other words, a negative test would rule out the disease, okay, if it has high sensitivity. On the other hand, if a test has low sensitivity, that means many people who are actually sick with disease will test negative, falsely. Okay, that's a false negative if a test has low sensitivity. Specificity then is kind of the opposite. Specificity is a test that accurately detects a person with no disease, correctly rejecting healthy patients. In other words, if a test has high specificity, most people who are well, who don't have disease, will in fact test negative, truly. It's a true negative. In other words, a positive test would rule in the disease because it's good at rejecting healthy patients. Does that make sense? Okay. So, low specificity, however, means many people with no disease will test positive. Oops, falsely positive. So it's not so good at rejecting healthy patients if it has a low specificity. Now, in a perfect world, we would have tests that are 100% sensitive and 100% specific. But if you think about the logistics of designing a test that is 100% sensitive and specific, that's really not possible to do because you either, based on the disease, you either want to be sure someone who has it, or be sure someone who doesn't. But you really can't have both in the real world. In the real world, we have tests like this. We have tests that are either really good at rejecting healthy patients or really good at discovering ill patients, but it's a trade-off, right? Think of it this way, athletes. You're either really strong or you're really fast, but it's hard to find athletes that are both strong and fast. Does that make sense? It's a trade-off, right? Either you can run a 4-minute mile for 26 miles, like that guy that keeps winning the New York Marathon, what's his name? I would know his name if I heard it, but anyway, he's won the New York Marathon like, I don't know, 5 times, 4 times. And he, at mile 25, he's still not even breaking a sweat at a 4-minute some mile pace. But he looks like a skeleton with skin, but he is fast. But he could probably not pick up the stable, okay? Probably could not. But he can run 27 miles without breaking a sweat, okay? But then the Incredible Hulk, very strong, but probably could not outrun a bumblebee, all right? Pretty slow. It's hard to find an athlete that's both strong and fast. It's just like a test. You're either really sensitive but not so specific, or really specific but not so sensitive. It's hard to find a test with both, okay? So when you look at most tests, you're gonna live in a world where there's gonna be some degree of false negatives and some degree of false positives. You just have to know that, and that's what's helpful. And knowing that, you can calculate, if you know a test sensitivity and specificity, you can calculate its clinical usefulness by knowing its positive predictive value and negative predictive value. What is a PPV? The probability that a patient returning a positive result is actually sick, is actually disease. That's a positive predictive value, the value of a positive test. The negative predictive value is the probability that a patient that comes back with a negative result is actually negative, is actually healthy. So the negative predictive value is, what is the value of a negative test result? Are you following so far? Okay, cool. So how do you then calculate PPV and NPV to know if I'm going to make a clinical decision on this test, how much weight should I give this positive result or negative result? Well, you know what the positive predictive value and negative predictive value is, and you do that by calculating, for example, the number of true positives over the number of samples that actually tested positive. That's the positive predictive value. Or the number of true negatives divided by the number of samples that tested negative. What is the negative predictive value of that? In other words, if you know that the number of true negatives is 80 out of 100, but the number of samples that tested negative was only 10, well, that's horrible, right? But if it's 80 over 80, that's great. That means it actually correctly identified, rejected the people that were healthy. Okay? That's kind of an example. I'm starting to see some glazed looks a little bit, so I think it helps. This is where I put in a real world example. And I think it's going to start to gel a little bit, okay? You following so far? So let's look at AccuChecks. Everyone knows what an AccuCheck is. Everyone understands low blood sugar, high blood sugar, okay? So I think this is going to make it gel for you here. Remember that we said sensitivity is what? The ability of a test to test positive in someone who truly is sick, or your target, whatever you're testing, okay? So truly positive. Specificity is when a negative test actually genuinely healthy, genuinely negative. Whatever you're testing for isn't there, okay? That's specificity. We said that if a positive predictive value is the number of true positives over the samples that tested positive, and negative is the true negatives over the number that tested negative, we can then look at this matrix for how AccuCheck defined diseased. In this case, AccuCheck said that hypoglycemia, being more accurate at detecting hypoglycemia, is more important than hyper. Is hyperglycemia bad? Sure it is, but will it kill you immediately? No. Will a blood sugar of 20 kill you? Yeah. Okay, so they said, well, we have to pick a side. Are we going to be more worried about hyperglycemia or more worried about hypo? And AccuCheck said, we're going to be more worried about hypo. So we're going to design a test strip that is more accurate for detecting low blood sugar than it is high. It can detect high, but not as well as it detects low blood sugar, because that's what we really cared about. So AccuCheck said, we're going to define disease as a blood sugar less than 70. You follow so far? So right now, what's the bullseye? Is it hyper or hypo? The bullseye is hypoglycemia. The bullseye, what they're wanting to be really good at, is low blood sugar, less than 70, because that's what's going to kill people. Okay? So if AccuCheck says, well, hypoglycemia or disease is any sugar less than 70, we want to now test these test strips against people that we know what the actual blood sugar is. So they run the actual blood test and actually measure what the real blood sugar is, and then they compare it to their test strips and say, well, how good are we at finding less than 70, or which is what they define as disease. Okay, so that would be a positive, is disease, okay? Less than 70. So truly positive that tested positive, meaning they knew that the blood sugars in the samples were less than 70. 160 tested truly positive. 720 were truly negative, in other words, truly not less than 70, so it was accurate, that's why it's green, okay? But they missed 80 false positives. In other words, 80 of the test strips were less than 70, but it read as 72 or 75 or 80 or something like that, right? 40 were falsely negative, meaning it says, oh no, it's, blood sugar is 72, when actually it was 65. Okay, so it falsely said there's no disease, okay? And when you take it all together, you have to know the denominator. They tested 1,000 patients. 1,000 patients, 1,000 samples with they knew what the blood sugar was and compared it to their test strip. So remember what we said. Sensitivity is the ability to detect people with disease, in this case, people who truly had a blood sugar less than 70, over how many they tested. So if they tested 160 plus 40 is 200, 720 plus 80 is 800, that's where your denominator comes from. Okay, that's where 1,000 patients came in. 200 people had a true blood sugar less than 70. It got most of them, 160 out of them, that missed 40 of them, okay? So if you take 160, which were truly positive, out of the 200 that truly had disease, that means 80% of patients were correctly identified as having low blood sugar. That's pretty good, right? 80%. It didn't say whether they were off by 5 points or 50. It just said the target is less than 70. That's our bullseye. That's what we're looking for. That's disease. 80%, not bad. When you look at the specificity, 720 out of the 800 90% correctly identified as not having low blood sugar. So its specificity was about 90%. Now we take those numbers, the number of true positives divided by the number of samples that tested positive. So how many tested positive? 160 plus 80, 240 tested positive. 160 of them were correct, were accurate, bullseye. 0.666 or 67% chance of being accurate. Do you see where this is starting to take shape now as far as clinical utility? Like what does this mean clinically? Because at first we said, well, the sensitivity was 80%. 80% correctly identified as having hypoglycemia. That's not bad. But then when you look at the positive predictive value, that's only 67%. Which now you're like, that's interesting. Well, what's its negative predictive value? Well, you had the number of true negatives, 720, over the ones that actually tested negative, which was 760, a 94.7, almost 95% chance of being correctly negative for low blood sugar, for their target, which is less than 70. In other words, Accu-Check is better at ruling out low blood sugar than ruling it in. Make sense? So if you get an Accu-Check and it says it's greater than 70, that's ruled out hypoglycemia. Then your dizziness and your nausea and your weird feeling is probably not from low blood sugar. So it's better than, ruling it out is better than ruling it in. So an Accu-Check's measure that it's more than 70 is probably a lot better than if it says it is low. Does that make sense? Because it wants to make sure that you're not hypoglycemic. It cares more that you're not hypoglycemic. So that's putting sensitivity, specificity, positive predictive value, negative predictive value all together into a real-world clinical situation. To follow? Pretty cool when you look at it that way, right? That's something that we all understand. We've all done 1,000 Accu-Checks before. Now you kind of know that it's better at ruling out low blood sugar than ruling it in. Now the bottom line is this, for purposes of passing your exam, just understand the basic principles of sensitivity and specificity. You'll probably have a question or two on something like that. I don't know, Tyler, if you remember any questions that might have had to do with like sensitivity, specificity, positive predictive value, reliability, validity. I'm not sure, but do you remember any specific questions that might have been on there?
Your quiz will have some next week for sure.
Yeah. Yeah, your quiz here will for sure have it, okay? Just know that there are certain statistical issues with applying clinical tests that we haven't touched on quite yet, but you do have to know just these fundamental principles of statistics, sensitivity, specificity, predictive value, that kind of thing. Just know this isn't perfect because we don't have perfect tests. I'll tell you this as a teaser on the next slide though, that if you think about sensitivity, specificity, and its inverse relationship, it's really important for you to understand this critical concept, which is only the tests falling at the very edge of the plot, the greens, are capable of providing strong evidence. In fact, most tests, if you don't understand its sensitivity and specificity, which is one of the first things I look at when this latest and greatest test comes out, I go through the fine print and I find out, well, what was its sensitivity and specificity? Because, in fact, some tests can be flat out misleading. So if you have a test that has 90% sensitivity, you're thinking, wow, that's a great test. But its specificity is about 40%. That's weak evidence of disease. And worse, if it's 90% sensitive but about 10% specific, you're saying, oh, well, that's good because then it's mostly sensitive. It's good at finding disease. Well, actually, if you think about it, if it's 90% sensitive and 10% specific, your test results can just be flat out misleading. Ideally, you're going to want a test that's 100% sensitive and 100% specific, right? It's perfect in both categories, which is the very edge, the top right edge in the solid green, but which doesn't really exist in real life, okay? You want relatively high sensitivities and specificities, if at all possible. Even if you're at the top of the orange corner, where it's about, 95% sensitivity and 95% specificity. I mean, that's pretty close. That can provide moderate evidence that you can believe that test result, but it's still not quite in the green. So just understand that tests have its limitations. Still, to this day, I believe that experience, clinical gestalt, is not quantifiable, that it's worth a lot more than any test. And this is why I learned a long time ago that when it comes to figuring out complicated medical issues, it really does matter that you go to a gray-haired doctor as opposed to one that's straight out of training. Does that mean the doctor straight out of training is incompetent? No, not at all. They're a very good doctor. But they haven't developed enough experience yet for that X factor that you can't measure. The clinical gestalt, the feeling, the funny little voice in their head says, you know, it's probably not this, but we're going to check this anyway. It's only after years of experience and being burned yourself that you develop that sense of who's sick and who's really not sick. What should you do, what shouldn't you do? Okay? You're going to have the exact same way. You're going to develop this after hundreds of critical care patients and transfers. You're going to develop a gestalt over, hey, their numbers look okay now, but there's something about this patient that bothers me, and I'm going to do this instead. I'm going to prepare for the worst when I normally wouldn't. You should trust that still small voice because that's something subliminal that you're not liking. Okay? You develop that over time, and you'll get it. All right, so now that you've got that kind of in the background, talking about the lab values and its accuracy, the fun part begins. We're going to talk about the major components of blood, starting with the CBC, the complete blood count. There are 4 major components in blood. You've got your RBCs, your formed elements, which the medical term for is erythrocytes. You've got the platelets, medical term, thrombocytes. Plasma, or the liquid component of blood, but actually is most of your blood, like 55% of your blood is the liquid component. And then finally, white blood cells, medical term, leukocytes. As you can see, plasma makes up most of it. Platelets, a very small percentage. Formed elements like your RBCs and white blood cells, the other 45-ish% of it. Red blood cells are going to be carrying the oxygen to your cells. Thrombocytes, critical in coagulation. Plasma is what's carrying your proteins, hormones, nutrients, especially coagulation proteins. There is a study that is going to be published very, very soon that's talking about how in services that even give plasma, not blood, their survival rates and decrease in mortality and morbidity is fairly close to those that give blood, which makes us believe that the value of blood has more to do with the plasma, or at least as much to do with the plasma as it does RBCs, the oxygen carrying capacity, which is intriguing, right? So at SCCAD, we're going to be trying to give RBC, well, eventually we'd like to give whole blood, which has everything in it. Logistically, right now, we're probably going to start with component therapy first, but we are moving towards whole blood in the future. And then, of course, your leukocytes are responsible for fighting infections. When you look at centrifuge blood based on density, you can easily see this percentage visually because most of it at the top is plasma, and then your spun down elements are your formed elements. So someone who's anemic, for example, you'd expect to see a lot more liquid portions than you would formed elements. Someone who has polycythemia, which just means what? What does poly mean? More of, or too much. Cythemia, cell products or formed elements. You'll have a much thicker formed element than you will to plasma. Okay? So when you see these fishbone diagrams, which you'll often see on handwritten reports, these are the numbers that are represented in this fishbone diagram. I will tell you this. As we move more and more to electronic patient care records, I'm seeing fewer and fewer fishbones. Like when I first started training, fishbones were all over the place because we had to write charts by hand. There was no electronic report, but now everything's just printed out in tables. So we don't see fishbones a lot. But if you do, this is how you write it for shorthand. Actually, you might need this for your own just internal notes to keep track of trends or whatever if you want to just for yourself. So you don't have to go through pages and pages of stuff. If you just write your own little fishbone diagram out and so you know trends, you can do that too. But this is essentially what it means. of course, the letters will be replaced by numbers. So you'll see, like for that, for example, you'll see 145, 4, 31, 30, 15, 1, and 120. And you'll know that those numbers each represent the respective, glucose, sodium, etc. Same for all those other fish bones. So this one, for example, if you saw numbers normal-ish between H&H and platelets, that's what those numbers would mean. Okay? So when you're looking at a CBC, the complete blood count looks at many components of blood, but these are the main things on a CBC that you care about as a clinician. I want to know, what's their white blood cell count? Because if it's super high or super low, frankly, that could be sepsis. There's some kind of infection, okay? What's the cutoffs for sepsis? Remember? White count less than what or more than what? Less than 4 or more than 12? Remember that? So that's one of the criteria for sepsis. Your H&H, hemoglobin and hematocrit, you're typically going to see in certain ratios, like typically about 1 to 3-ish. And then your platelets between 146 and 429, around there. That's your normal standard range. Those are the main things on a CBC that you're going to pay attention to, although a CBC also includes lots of other things like your mean corpuscular volume, red cell distribution width, mean platelet volume, all these things that can sometimes speak to either iron deficiency or vitamin B deficiencies. But I'll tell you what I pay attention to most on a CBC are these 4 things, really. What's their CBC, H&H, and platelets? Because that's what's going to guide my therapies more than anything else. The internal medicine doctor might look at mean corpuscular volume, et cetera, but it's not, I don't do a whole lot with the mean corpuscular volume. The hematologist does, internists do, but in emergency medicine, I don't a whole lot. Now, you're going to maybe hear somebody say, I need a CBC with diff. What does that mean? A CBC with diff, a complete blood count with a differential. That's really what it means. A diff is slang for differential. So I do look at the differential when I have it because that helps me lean towards a bacterial infection versus viral infection. Again, not 100%, but at least it gives me some idea of where to look if I'm wondering. So, for example, if somebody has a neutrophilia, am I thinking more bacterial or viral? Bacterial mostly. If someone has a fever, they look kind of sick, they have a white count of 20 and a neutrophilia, like a high neutrophil differential, I'm worried that they have some bacterial infection someplace. Okay? People who have a lymphocytosis are more likely to be viral. So if I highly suspect the flu, they have a high white count, but their lymphocytes are off the chart and their neutrophils aren't so high, I'm thinking, well, more likely than not, this is a viral syndrome. People with malaria, TB, they often have monocytosis. Eosinophilic reactions are really seen in allergies. Eosinophils are the ones with all the red granules on a microscopic H&E stain. What are those red granules? Histamines. And so people who have horrible mold and pollen allergies, they're sneezing, they look terrible, they sound terrible, but they don't have a fever. I don't think they're sick, but their differential shows eosinophilia. I'm like, do you have hay fever? Yes. Are you supposed to be on Allegra or Claritin or Flonase? Yes. But you haven't been on it? No. I said, well, this is what you need. Okay. And then basophils you can see in certain things like cancers, chickenpox of all things. Let's look at the form cells first, erythrocytes. So erythrocytes have this biconcave disc shape. What does biconcave mean? It's got this little dip on the front and back, or the top and bottoms of it, or each side, yes. So this biconcave disc actually helps it pack in more hemoglobins and more oxygen to it as much as possible. It basically increases the surface area of a red blood cell. It also helps the red blood cell get through where? The capillary bed. Remember, the capillaries are only one red blood cell in width. So it's easier to get a squishy like that versus like a inflatable inner tube. It's easier to get that through than a frisbee. If it were just round disc, you can think, it's hard to get a frisbee through a little pipe, but you can get a little inner tube through a pipe a lot easier. Same thing, the capillary bed, one red cell width in diameter, it's easier to get that through there. Okay. So there's no nucleus in it. It outnumbers the white blood cells 1,000 to 1. Normal range, there's your normal ranges. Just be familiar with what those normal ranges are. Bone marrow is the site of red blood cell production, and roughly 1% are removed and replaced every day. The average lifespan of a red blood cell, and this is a common quiz and test questions I've seen, even on mine, are 120 days. About 120 days. So about 4 months-ish is the average lifespan of a red blood cell before it's consumed or breaks apart or whatever. So RBC production in the bone marrow is happening constantly. The average is about 5 red blood cells per microliter. What is the relationship between red blood cells or erythrocytes and hemoglobin? Well, remember, the oxygen and CO2 enters the plasma before the hemoglobin on the RBC, and that makes sense because the plasma is the liquid portion of blood. It has to get into the plasma and then get attached to the hemoglobin on the RBCs, but the hemoglobin is a critical factor to account for when trying to assess if a person's hypoxic or anemic. SpO2 and PaO2 are 2 different things, and you do have to know this. What's SpO2? Partial pressure of oxygen on a pulse ox. That's what you get from pulse ox, right? It measures the O2 saturation of the hemoglobin itself on your pulse oximetry, whereas a PO2 is the partial pressure of oxygen in the plasma in the artery, and you get that on an ABG. So if you have a matching question or some kind of test question where you're figuring out the PaO2, you don't get that from the pulse ox. You get that from ABG. SpO2, I remember SpO2 as SATs. So that's the partial pressure of oxygen saturations on your pulse ox of hemoglobin. O2 and CO2 molecules actually bind to the iron portion, the heme portion of the hemoglobin molecule. And that's also testable material. Now, if hemoglobin is what carries oxygen and carbon dioxide, how about hemoglobin that's carrying the poison carbon monoxide? That's a carboxyhemoglobin. Okay. Fire departments and EMS services both typically carry the Massimo pulse ox, which has both SpO2 and carboxyhemoglobin capabilities on it, right? In fact, I think our new LifePak 35s have that built in, don't they? Carboxyhemoglobin and SpO2, I think it does. But when you go through your LifePak 35 orientation, they'll talk about that. You can get a SpO2 SATs as well as a carboxy, which is important if you're on a fire scene. I don't think our Zols did, which is why we had the separate carboxyhemoglobin, those red Massimo meters, because I remember being on a fire ground one of my first months here, and as the firefighters were coming out of this raging first alarm commercial in rehab, we put the red carboxyhemoglobin monitors on their fingers just to make sure that they weren't having CO exposure. Hemoglobin carrying CO can cause even a falsely elevated SpO2 level, which is why if you suspect CO poisoning, I don't really care what their SATs are. I won't even bother to check. I'll check what their carboxy is, and then I'll care what their SpO2 is. Now, what is methemoglobin? Have you heard of methemoglobin before, at least? Methemoglobin is hemoglobin whose iron has been oxidized to ferric iron, so Fe3+. So you have a 2+ state, which is ferrous iron, and it becomes oxidized to ferric iron, or 3+ state. The problem with that kind of hemoglobin, heme group, is it can't carry any oxygen or carbon dioxide. So something is wrong with the heme group in methemoglobin. And we'll talk about what causes methemoglobinemia in just a second. So you know what oxycarbaminohemoglobin is? That's your normal states. You know what carboxyhemoglobin is? You should equate that with CO poisoning. Methemoglobin, there's something functionally wrong with the heme group itself. It can't carry either oxygen or carbon dioxide. Okay? The hemoglobin protein on a 3D electron microscopy looks like that. From just a artist rendition, to make it easier to understand, the heme group carries these 4 molecules that actually bind to oxygen and carbon dioxide, as we said. Normal values of hemoglobin in the blood is about 15 grams per deciliter. So 15 is your typical normal median amount. And if the hemoglobin hematocrit ratio is typically 1 to 3, if you look at someone's number in the top of that fishbone is 15, what would you expect the normal hematocrit to be below it if it's a 1 to 3 ratio? If the hemoglobin is 15, you would expect the hematocrit to be 45, 1 to 3, okay, 1 times 3. So, yeah. And that way you can eyeball it to kind of know what someone's volume status is by looking at that ratio. So if I see someone's hemoglobin is 10, before even looking down at hematocrit, I would expect the hematocrit to be about 30. Okay, so transfusing 1 unit of RBCs increases the hemoglobin by about 1-ish, and the hematocrit about 3%, which makes sense. So hemoglobin carrying oxygen from the lungs and waste products, CO2, from the tissues, is about 98% via oxyhemoglobin, about 2% are dissolved in the plasma, so it's mostly that oxyhemoglobin form that carries the oxygen to the tissues. So this little diagram is using the white little ping pong ball looking things to represent your hemoglobin, and the blue dots representing oxygen from the lungs. As it passes through the lungs, it's picking up oxygen that gets bound to the hemoglobin. When it gets to the tissues, where it's a little more acidotic, because the tissues are trying to dump its waste, guess what? It's actually easier for the hemoglobin to get rid of its oxygen and easier to pick up carbon dioxide, which conveniently enough is what you need in the tissues, in the final target. Okay? The reverse happens in the lungs, where it's easier to get rid of CO2 in the lungs and pick up oxygen, and vice versa in the tissues. It's amazing how that works. Waste, which is carbon dioxide, is then eliminated from the tissues mostly by lung exhalation, as you'd expect, 80%, another 10% as carbaminohemoglobin, and another 10% in blood plasma, but mostly eliminated in exhalation. And when you put it all together in this nice little round robin diagram, it makes sense. Your lungs, a high affinity state for oxygen, decreased pH in the acidotic environment will offload the oxygen into the tissues where it's needed, pick up the carbon dioxide. That's going to be the Bohr effect or right shift. We'll talk about that, the oxygen dissociation hemoglobin curve, in much greater detail later this semester. But that's the right shift we're going to talk about. Then, as it passes through the tissues, it's going to take the waste, which is the CO2, to be exhaled into the lungs. Remember, 80% of that waste goes out through the lungs in exhalation. It hits the more alkalotic environment of the pulmonary bed. The Haldane effect or left shift allows them to offload that waste into the lungs much easier, and then pick up the oxygen as it passes through the pulmonary capillary bed to just start that whole process over again. So it is chemically favored to give the hypoxic tissues oxygen at the target, and chemically favored to release that CO2 into the lungs for exhalation once it gets to the lungs. And you'll know, we'll go over the whole oxygen dissociation curve when we talk more about acid-base. The hemoglobin being the actual molecule, again carrying oxygen and carbon dioxide, decreases could suggest anemia either from bleeding, sickle cell disease, maybe iron deficiency. You've heard of iron deficiency anemia. Cancer therapy, chemotherapy, drugs causing hemolysis. Increased hemoglobin or polycythemia could be people who live at high altitudes. People who live in Denver, a mile high, actually do have some level of polycythemia because they're just acclimating to the altitude. This is why professional runners, for example, if they're going to run a marathon or compete, football teams used to do this. When they played the Denver Broncos in Mile High Stadium, sometimes teams would get there several days early when they normally wouldn't, just to get more acclimated and kind of stimulate their bodies to produce a little more red blood cells so that Denver didn't have the advantage over them. Some athletes, you've heard of blood doping. What does blood doping mean?
Draw your own blood and then
Yeah.
kind of like reinsert.
It's basically transfusing yourself with blood. You're saving your blood, and you have an advantage over your other athletes because you have greater oxygen carrying capacity. So you're artificially increasing your oxygen carrying capacity. Okay? Blood doping. You could also be dehydrated because you have less plasma, so you have more formed elements. Burns can do that sometimes because you're losing more plasma, you move more fluids. Chronic diseases, chronic lung disease especially, can cause that. Okay. How many of you have ever seen this painting before? It's a pretty famous painting. This is called the Blue Fugates of Kentucky. The Blue Fugate family was a real family in Kentucky, where it's an area of Kentucky where there's a lot of inbreeding. So a lot of relatives marrying relatives, a lot of very sparse branches on a tree. And what does inbreeding do? It magnifies and amplifies genetic mutations. And this particular family had a genetic mutation causing methemoglobinemia, where the hemoglobin was functionally, remember we said methemoglobin is a functional abnormality of that molecule. Well, Walt Spitzmiller, who was the artist that made this famous painting that rarely ever gets credit, which is why I made sure to put his name on there, because he rarely gets credit for this painting. But he took interest in this family and actually drew this famous painting, which has been reproduced in textbooks all over the world, as the example of genetic methemoglobinemia. Now, most of the methemoglobinemia I've ever seen, which is maybe one or two in my entire career, is not from a genetic mutation, but from a toxic exposure of some kind. So any substance that oxidizes the heme groups on the hemoglobin that can change hemoglobin into methemoglobin can cause methemoglobinemia. And if the methemoglobinemia gets to a certain level, you actually look like a blue Smurf. Of course, that guy is not methemoglobin. That's from Blue Man Group. Have you heard of them before? A weird kind of music. Anyway, their music's not that great, which is why they have to come up with some gimmick like that. Anyway, things like amyl nitrate, nitric oxide, nitromez, like even nitroglycerin. Food-grade nitrates can sometimes cause this methemoglobinemia. One of the telltale signs of methemoglobinemia is that it's unresponsive to oxygen. So most patients that are blue, if you give them oxygen, they get better. The cyanosis goes away. And if it doesn't, you have to strongly suspect methemoglobinemia. SpO2 is an unreliable measure of oxidation because the O2 is bound on the hemoglobin and is not delivered to the tissues. So you get this chocolate brown looking blood, unresponsive to external oxygen, and you get blue skin at super high levels. And so the treatment is to discontinue the offending substance, and the antidote is something called methylene blue, 1 to 2 mg per kg IV over 5 to 30 minutes, that can serve as the antidote for methemoglobinemia. I think for testing purposes, you should be able to equate methemoglobin to a defective hemoglobin structure itself and know that methylene blue is the antidote to it. Anything else they'd have to know for the test? I know it's methylene blue and methemoglobinemia.
Yeah, no methylene blue for sure is the treatment.
That's a favorite quiz kind of test question. Now, hematocrit. If I ask you what is the difference between hemoglobin and hematocrit, what would you say? Well, what's the difference between hemoglobin and hematocrit? Like, what is hematocrit? What's the big differentiator between hemoglobin and hematocrit? From a lab, remember we're talking about lab tests. So I'm not talking about physiology. I'm talking about lab testing. This is a lab testing module. So what is the primary differentiator between hemoglobin and hematocrit? You're very close. Hemoglobin is an actual measurement of the hemoglobin molecule. Hematocrit is not a measurement. Hematocrit is a percentage of red blood cells or formed elements to plasma. So the hemoglobin shouldn't change so much as hematocrit does with volume, for example. If you drink tons and tons of water and you're overhydrated, your hemoglobin should stay the same, but your hematocrit may go up or down. Does it go up or down? It goes down because there's more liquid to the formed elements, okay? But I see nursing home patients come in quite frequently who has a normal hemoglobin of 15, but instead of being hematocrit of 45, it's 57 or 60. Do they have polycythemia rubra, or did someone just not water them in a few days? Yeah, they just haven't been watered in a couple days. So they're dry, you know, so they get very concentrated. So I would say in one word, the difference is percentage. Hematocrit is a percentage formed elements to plasma. Hemoglobin is an actual measurement.
So you should suspect a high with dehydration.
That is one of the things that can cause that ratio to be upset. In fact, when you look at it right here, if your hemoglobin is normal, but your hematocrit is low, that's the opposite of dehydration, right? That's overhydration. But you can also see that normally in pregnancy. Why? What happens to blood volume in pregnancy? It goes up by like 25 to 30%, okay? But it's not because they have more blood, it's because they have more plasma, more formed, more liquid portion, okay? Their blood, the volume of the blood to support a growing fetus without an actual increase in formed elements will make their hematocrit, the percentage go down, but their hemoglobin stays the same. But Miguel, to your question, if it's hemoglobin is normal, but the hematocrit is really high, yes, they could have polycythemia, which is an abnormal production of more red blood cells, or instead of overhydrated, they're dehydrated. Okay?
Write that in your slides, Scott. I didn't
Okay.
put that on the slide there, but write it in.
Yep, write that in. Polycythemia / dehydration. What if both of them are up? Your hemoglobin and hematocrit are up. Well, you might live in Denver. You have a chronically low O2 state, or you live in Missouri, but you've got bad COPD, so you're always a little hypoxic, so your body's just trying to create more oxygen carrying capacity, and you have a hemoglobin and hematocrit go up because you are physically making more red blood cells to try and make up for the hypoxia all the time. If both of them are down, if the hemoglobin is 8 and the hematocrit is 24, then yes, I'm worried about hemorrhage because you're losing equal amounts of plasma and formed elements. Okay? Maybe they're just anemic too, their body's not making formed elements.
That chart looks like a good way to get a test question or two, doesn't it?
I see at least, you could do 12 test questions on that thing, easy, matching, whatever. All right, can you take a 5-minute break? Okay, take 5, we've been here for an hour already, take 5. Just 5, please, because we still got a lot to go through.
We're in the process of, Tim, we're gonna add the show number thing, is that all right? The guy, the SWAT guy?
Oh, yeah.
We're gonna add him to the process.
Yeah, I said it was, I told him it was, because he's wondering if it's okay. I said, Chief Stewart's the course director. If he says yes, I'm good with it.
Yes, first week, I got
Blood cells that are primarily going to be part of your infection fighting army. 5 types of leukocytes all have their own different purpose and function. You should be familiar with the 5 types: basophils, eosinophils, neutrophils, monocytes, and lymphocytes. I can tell you that I could easily see a test question like all the following are white blood cells except, and you should be able to know that, or something like that. Or maybe which of the following leukocytes are primarily responsible for allergic reactions, or in allergic reactions you would say eosinophils, right? So, or bacterial infections, neutrophils, or viral infections, lymphocytes, things like that. So know their functions and typically what they do. Normal range is 4 to 12. Less than 4 or greater than 12 is already one of the 4 criteria for SIRS, or sepsis if the SIRS is due to an infection. These are nucleated. Leukocytosis just means a higher white blood cell count. Leukopenia means a lower white blood cell count, okay? So you should definitely know those terms, leukocytosis and leukopenia. One of the things that I've always said is that as a critical care paramedic, I would expect you to also use appropriate terminology. So instead of saying high white blood cell count, you could more precisely say he had leukocytosis. Okay. Platelets are part of the formed elements with red blood cells and white blood cells in that they... Oh, hey, that's great.
Whatever it takes. They're not used to, after we started lectures.
Don't I get one?
You gave great lectures, but it's just, you know, well, yeah, of course you do. You get full back.
Actually, I shouldn't, but I'm going to. You know where I was last weekend? Hershey, Pennsylvania. I had a meeting there, and I actually took time to go to the Hershey chocolate factory tour, and it was really fascinating. They changed it. You're not at the actual factory. It's like a facsimile of it, but you go through. They have actual video of the real factory, and they gave away little free samples at the end, which of course was great. Did they have what? No Oompa Loompas there. I didn't see. I looked for the Oompa Loompas, but I didn't see any. Yep, I didn't see any. No one was falling into the vats of chocolate. Anyway, platelets, 150 to 400. Generally, if you know that number, and also to note is that it is assumed to be in the thousands. So if it says If you're writing your fishbone and you write 150, that's 150,000. Okay. What do you call, if leukocytosis is high white blood cell count, what do you call a high platelet count? Thrombocytosis. And decrease would be thrombocytopenia, just like leukopenia is low white blood cell count. Good. Remember common lab values. And this is something that, again, is also easily testable, but you should know that the normal common lab values for RBCs is 5. We already mentioned the common normal lab value for hemoglobin is about what? 15. And if you know that it's a 1-to-3 ratio, what's the common normal lab value for hematocrit? 45%. Usually, you get an RBC transfusion when you're below 7, usually. If you have known coronary artery disease, some docs will give it even before, like at 8 or 9 even. Why is that? If you have known heart disease, they want your hemoglobin to be a little higher. Why is that? Because you already have ischemic heart disease, and having low oxygen carrying capacity doesn't help any. So they have a little bit of a lower threshold for giving a blood transfusion to people with known coronary artery disease, depending on their sum totality of the circumstances. We move now from the formed elements in blood that are oxygen carrying capacity, and we now talk about stuff that runs around in the plasma, and that stuff is electrolytes. So we're going to talk about the next thing. What we just finished talking about was the CBC. Now when we're talking about electrolytes, what are we moving on to? What's the name of that blood test? CMP, complete metabolic profile. The old name was a Chem 14, I think it was. The essential part of a complete metabolic profile is a BMP, basic metabolic profile, and that used to be a Chem 7, but now it's BMP and CMP. So CMP is pretty much everything. BMP is just your first fishbone, the sodium through glucose that you saw earlier. So in order to understand the CMP, you first must understand the concept of electrolytes and ions. So let's go over that. What are ions? Ions are just atoms that have an uneven number of protons or electrons giving you an overall positive or negative charge. That's an ion. Okay. What if the ion has an overall positive charge? What do you call it? Cation. What if it has an overall negative charge? Anions. Okay. So when you hear cation and anion, they're both ions. It's just that cations have net positive, anions have net negative. Okay. So you'll see shorthand for calcium as Ca2+ or Ca++. Same thing. What does that mean? Does that make calcium an anion or a cation? It's a cation with how many? 2 extra positive charges. It lost 2 electrons. A chloride is often written shorthand as Cl negative. Why is that? Because it gained an electron. And so it has a net negative charge. So when we talk about ions, one of the reason why we mention ions first is because next we're going to talk about the attraction between elements, one of which is an ionic bond. We can't talk about ionic bonds if you don't understand what an ion is. So now that you know what an ion is, what's an ionic bond? An ionic bond forms when one atom donates electrons to another atom, like one metal atom and a non-metal atom. The second bond is a covalent bond, and the third is a metallic bond, but we're not talking about those two because it doesn't really pertain to the CMP. What it does is ionic bonds. Okay, so ionic bonds, one atom donates electrons to another atom. For example, probably the easiest one for you to understand is when a sodium atom and a chloride atom combine an ionic bond to form what? Table salt, sodium chloride. Okay? So the sodium atom donates an electron to the chloride ion. They form an ionic bond, and now the 2 atoms, sodium and chloride, form a molecule, a sodium chloride molecule. So salt, sodium chloride, is probably the most commonly talked about electrolyte molecule that we're going to talk about when we talk about lab values. Okay, salt. What then is an electrolyte? Now that you understand what ions are and ionic bonds, what is an electrolyte? An electrolyte is a substance that dissociates in water into ions. and conducts electricity as a result, which is, of course, an essential mineral vital to many bodily functions. So, for example, if you put sugar in water, it dissociates into various ions, but it doesn't conduct electricity. So is sugar an electrolyte? No. But if you take sodium chloride that we just talked about, you take salt, you put it in water, guess what it does? It dissociates into its individual ions in water, and it conducts electricity. And it's vital to bodily functions, which makes sodium chloride an electrolyte, right? So that's an electrolyte. It dissociates in water into ions, conducts electricity, vital to bodily functions. Okay. Where are electrolytes found? Well, you should be able to recognize on a quiz, for example, what the extracellular electrolytes and intracellular are. So potassium, for example, the major intracellular cation, and extracellular, the major extracellular cations are sodium and calcium. So be able to recognize extracellular and intracellular primarily substances. Let's take a look at the first cation in the CMP, sodium. Probably one of the key substances in the body is sodium. When you look at your fish bone, sodium is the very first thing in the top corner, Na. We mentioned what the fishbone diagrams are, and this is again what it means. Sodium, normal between 135 and 145 milliequivalents per liter, one of the most abundant extracellular cations in the human body. It's key for maintaining the balance of fluids. Why is it key for maintaining the balance of fluids? Because water follows sodium. Remember that concept, because it's going to play a key role when we talk about osmolarity and osmolality. Water follows sodium. Okay? So, as you saw a couple slides ago, sodium binds very easily to chloride by donating one of its atoms, forms an ionic bond, becomes a sodium chloride molecule. Sodium attracts water, and it pushes it very easily within the body through osmosis, because water follows sodium. Sodium levels are the perfect marker for fluid status in a patient, which is why if I'm wondering if somebody is dehydrated, overhydrated, or volume overloaded, what is their real volume status? How significant is it? I look at sodium first. I get a BMP, what's their sodium? Okay. Total body water, most of it is in your cells, as you'd expect. About 2/3 of it. The rest of it is extracellular, so the other 1/3 of it. In the extracellular space, most of it then is interstitial. Where is that? The interstitial. What the interstitium? Where is that? It's in the tissues, right? So the interstitium is in that nebulous space. It's not quite in the vessels. It's not quite in the cells, but it's in between everything else. That's the interstitial fluid. Okay. So of the stuff that's not in that's extracellular, about 8% is the plasma itself that carries your formed elements through your blood vessels. Okay, that's about 8%. So total body water, mostly intracellular. Of the extracellular, most of it's interstitial, in that nebulous space between all the stuff in your body. As we said, movement of water in the body is very dependent on what electrolyte? Sodium. Salt. Yeah, sodium. So water follows sodium. So when you know that water can freely move within our body spaces, it's not restricted by receptors, channels, pumps, like electrolytes are. Osmosis is the process of net diffusion of water caused by a concentration gradient. That concentration gradient is made by what? Sodium. And so the diffusion of water always occurs from an area of low sodium concentration to an area of higher sodium concentration, which is osmotic pressure in action. And because water follows sodium, water wants to equalize sodium concentrations within body spaces. So when you look at a place that has your cellular plasma membrane, your phospholipid bilayer here, almost everything else has to go through channels and pumps, etc., except, remember, we said water can move freely based on that pressure, osmotic pressure. So if sodium there's a lot of sodium on this side, but not so much sodium on this side. Where's water going to want to go? Over where there's a lot to kind of make it more equal. Okay? Sodium is the most important regulatory electrolyte in the body's fluid balance requirements, most important. So if you remember anything at all, remember that sodium is the most important regulatory electrolyte in fluid balance. Again, because water wants to equalize sodium concentrations within body spaces, which is why net water flow will be that way, because that's where water follows sodium. So if you are hypertonic in the extracellular fluid space for whatever reason, remember the poor nursing home patient who hasn't had water for a while, and her sodium is 160 or something like that. Okay. Compared to her intracellular body fluid, which should be normal, where's water going to want to go? Where the salt is. Which means in a hypertonic situation, water's going to want to move in the extracellular fluid. What do you think they're going to look like externally? Shriveled up or kind of doughy? A little edematous, right? Because they're going to look like they're retaining water, because what little fluid they do have is leaching out in the interstitium, because that's where the salt is. Well, if they're hypertonic because water follows sodium, that's the direction that it's going to want to go. Versus, again, isotonic and hypertonic. Versus if it's the other way around, if for some reason the hypertonicity is in the intracellular space compared to the extracellular space, water's going to want to move into the tissues itself. Okay. So the concept of osmolarity and osmolality is very related to sodium concentration. Water follows sodium. So let's say that your normal is 275 to 295. One of the questions you may see on a quiz is the difference between osmolality and osmolarity. They're very related, but they're a little bit different in units of measurement. So osmolality is the calculated amount of dissolved substance in a kilogram, so it's weight-based, versus osmolarity is the measured amount of dissolved substance in a liter. So it's volume-based. So related, but different. So which one is weight-based? Osmolality. Volume-based, osmolarity. Either way, water moves in the direction of the compartment that has more solids. In this case, we're talking about sodium, right? Water follows sodium. So more osmolarity is the same as osmotic pressure, or the process of osmosis. Get it? So we already saw that pictorially, where water tends to move where sodium is. So in other words, water will move towards the higher osmolarity solution, leaving the area of lower osmolarity, because water follows sodium. Clinically, when you think about concepts like cerebral edema, sodium derangements can result in, especially, central nervous system disturbances and problems, because water follows sodium. Let's talk about this in the context of hyponatremia and hypernatremia, shall we? Hypernatremia, where is most of your solute going to be? Where is this? Remember, we're talking about lab tests now, right? So we talked about what sodium is. We talked about water follows sodium. We talked about where we're drawing this lab from. When you drew a lab test on a BMP, where's that coming from? The cells or the plasma? Plasma, right? It's a blood test, right? We're talking about blood tests here. So let's say that your blood test comes back with a sodium of 160. They're very hypernatremic. What's this going to do? Water follows sodium. So where's this water going to come from? And the cells, right? It's going to draw water out from wherever water is, interstitium cells, whatever, draws water out of the body cells, causing shrinkage of the cells because it's drawing the water out to try to dilute that. Water follows sodium. It's trying to dilute that out a little bit. Anything more than 145 milligrams per liter is hypernatremia. So if it's 160, that's substantially high, right? So we talked about nursing home patients, psych patients, victims of dementia, infants as being at risk for hypernatremia. Chief?
Sorry, Dr. and Coach Al, we gave you that workbook, guys. So here's the point where you give us your workbook.
Oh, yeah.
You start filling that in, if you want. Yep.
That workbook becomes a really nice self-assessment tool to see where you're at and your understanding. And you can use it for quizzes too. The signs and symptoms of hypernatremia tend to be neurologic in nature. Because the brain is not immune from the effects of severe hypernatremia. What's going to happen to the brain? Is it going to swell or is it going to shrink? It's going to crenate a little bit, right? Because we said water's being drawn out from wherever. And at super high levels, it's going to affect the central nervous system too. Brain, spinal cord, nerve, everything like that. So your signs and symptoms are going to be most obvious neurologic in nature. You're going to get things like restlessness, altered mental status in the form of agitation, intense thirst, because your body is going to say, I need water to dilute this salt. So your body's going to try to force you to drink. Well, if infants and demented patients, can they take a drink of water? No, right? So they are dependent on being watered, by being fed, given water. Eventually, as it gets progressively higher and untreated, eventually they'll have a depressed level of consciousness, can go into a coma. Notice there's no EKG changes in hypernatremia like hyperkalemia. You expect to see peak T waves, right? There's nothing pathognomonic on EKG about hypernatremia. That's more of a lab diagnosis, clinical suspicion based on, I've got a confused nursing home patient coming in for altered mental status and they're agitated. The first thing I do is not give them a sedative. I'm establishing an IV, checking some electrolytes, and doing a hypernatremia workup. So there are such things as hypovolemic hypernatremia, euvolemic, and hypervolemic hypernatremia. Now, the most common thing that you're probably going to see is where they just haven't gotten water. Their total body water is down. Total body sodium may be down as well, but they've got either decreased water intake, excessive losses like burns, diarrhea, fistulas, stuff like that. So they're just losing lots and lots of plasma. They're getting concentrated, and they get hypernatremic from that way. Other categories of hypernatremia can be hypervolemic, where your total body water is up. Total body sodium may be up as well from endocrinologic diseases like primary hyperaldosteronism or Cushing's syndrome. Hypertonic dialysis can do that. They got hypertonic sodium bicarb. External intake of sodium chloride tablets. Sometimes people are like thinking that they need more salt tablets because they're trying to exercise or something like that. That can sometimes cause hypernatremia as well. This is just a general diagnostic algorithm for how someone may look at hypernatremia. My point is this: I don't think IBSC is gonna want you to have to differentiate urine sodium and what exactly category hypernatremia you have. What they are gonna want you to know is that the treatment of hypernatremia is basically based on etiology. Eventually, the hospital will figure out what their most likely source of hypernatremia is and go after that etiology, depending on where they fall here. I do think that it's okay to give some fluids. I think it's perfectly fine to give some, especially if they're hypotensive, to give some IV fluids until their BP improves. But we don't necessarily want to overly correct too fast hypernatremia. Overly rapid correction can lead to lots of just fluid shifts. Remember, water follows sodium, so we don't want to like make them normal immediately when they're hypernatremic. But I think slowly getting them re-equilibrated is fine. But you're going to find what the actual underlying etiology is and go for that. It may be simple, again, if they're taking extra salt or salt intake for whatever reason, it may just be as much as stopping the extra salt intake and letting the body equilibrate. Okay, so hypernatremia is probably not as immediately life-threatening as acute hyponatremia. Acute hyponatremia in the blood decreases your plasma osmolarity, right? It's less concentrated. What does this do? This draws water into the body from the blood, causing swelling and edema of those cells. Anything less than 135 is considered hyponatremia. When you start getting less than 125, that becomes critical. I will tell you this from a clinical standpoint, it matters more as to the speed of hyponatremia than it does sometimes with the actual overall number. In other words, if you go from a normal of 140 to 120 in a couple of hours, that's going to cause way more problems than it took a week or two to get there for whatever reason. Okay, so it's acute hyponatremia that is immediately problematic, life-threatening. Excessive water intake or water intoxication is an actual thing, and that is an often fatal cause of acute hyponatremic decompensation. For some reason, psychiatric patients are more prone to this. They suddenly get the urge to drink water, lots of water for like no reason, no one understands why, but they'll just be drinking free water constantly for hours, to the point where we have to admit them to the ICU, because if we admit them to a regular hospital bed, what they're going to do is sneak out of bed and drink from the faucet without someone watching them. And if you shut off the faucet, they're going to drink from the toilet. They've done this before. So they have to either have a sitter who's actually physically watching them, or they just put them in the ICU where they can be monitored 24/7 with free water restriction. Sometimes you can get reduced renal excretion, so you get hypervolemic from kidney failure. You don't get your dialysis done. Everything you intake, everything you drink just stays in your body because you're not urinating out at all, and you get hyponatremic that way. Or you get a huge overinfusion of IV fluids. It can be asymptomatic if gradual, but a rapid decline is what's fatal. So I'm not sure if any of you have heard of Jennifer Strange, but Jennifer Strange was the name of, from all accounts, a super sweet lady who was trying to win a Christmas present for her kids. I mean, this is tragic. The contest was called Hold Your Wee for a Wee. Ever heard of this? Hold Your Wee for a Wee. The radio station said, hey, we're going to have a fun contest. Whoever can drink the most water without peeing, who holds their pee the longest, will win a wee. It's called the Hold Your Wee for a Wee contest. Whoever wins, wins. So this is a picture at 9 o'clock in the morning from Ms. Strange drinking her water, and she's in the lobby of the radio station, and they break for commercials, and they've got all these people in the lobby drinking water, and no one's, they're not allowed to go pee, so they're holding their wee for a wee, and well, the sad thing is she didn't even win, but she went into acute hyponatremic seizures and died. As you can see, the family was awarded $16 million in damages, but that's not going to bring mom back, and it's horrible. I think the radio station guys were also criminally charged. I don't remember if they actually went to prison, but it was bad. Anyway, during hyponatremia, water follows sodium. So water in the plasma passes from the hypotonic serum into the hypertonic brain cells, causing cerebral edema. And the funny thing is, well, not funny, the tragic thing is she complained of not feeling good. She said, I'm not feeling so good. I'm kind of nauseated and I got a headache. And they're like, oh, you're fine. You're in second place. You're almost going to win. Just keep on drinking this water and think about your kids. You're going to win this wee. But she eventually went and had seizures, coma, and death. Now, unlike hypernatremia, if in hyponatremia this developed in less than 48 hours, you actually want to treat this rapidly. If it's been more than 48 hours and the sodium is less than 115, then you don't want to treat too fast, because then you can also cause swelling, right? If too fast. Central pontine myelinolysis is the feared complication of treating hyponatremia with hypertonic saline too fast. The problem is this does not apply to acute water intoxication. So CPM is rare in patients with acute hyponatremia or plasma sodium more than 120, so you do want to treat it if it's acute. And the way you treat it is with actual hypertonic saline. And hypertonic saline is defined as 3% sodium. Hyponatremic encephalopathy is one of those things where if it's acute, again, less than 48 hours, they've got headache, nausea, vomiting. Certainly if they've got coma and seizures, you want to give it quickly. And they're talking about 100 to 150 ml pushes of 3% sodium chloride over 10 minutes in rapid succession to increase the plasma sodium by 4 to 6 milliequivalents per liter as a safe way to treat hyponatremic encephalopathy. This author group has been studying hypertonic saline and hyponatremic encephalopathy for over 30 years and has been really espousing this rapid correction if it's acute. So, for hyponatremic seizures, if you don't know whether it's been less than or greater than 48 hours of duration, you can certainly do normal stuff like benzos for hyponatremic seizures. But if you do know that it's been less than 48 hours and the sodium is at least 120, to give the hypertonic saline. An alternative is sodium bicarb. Why? Because sodium bicarb has a ton of sodium in it as well. Okay. It's not every hospital has hypertonic saline. So if you don't have it, you can give sodium bicarb instead. Okay. An adjunct is DDAVP, which is synthetic ADH. So how would that work? If DDAVP encourages the body to retain water, synthetic antidiuretic hormone. I just thought of this. Why? Someone explain that physiologically.
So you're not going to be giving the hormone and
To not pee.
So you don't lose sodium because you're not peeing?
So if you give it in conjunction with the hypertonic solution, then you're gonna retain that concentration.
Yeah, and not urinate it out.
Because if you, like the opposite, inversely, like if you are diabetic and you have a lot of sodium output, it's like that you're really thirsty, you're peeing a lot. So if you're not peeing a lot, then the molecules in your system.
Right, and you're keeping the sodium in to try to
More time to attract.
more time to attract water and more time to equilibrate. That makes sense. I think it has to be in conjunction with sodium, though. That's the thing.
Yeah, I said that.
It doesn't make any sense to give antidiuretic hormone in the absence of hypertonic saline. But with it, I can kind of see how you're letting it equilibrate. You're retaining all the sodium you're giving. There's more sodium than water, so you're trying to keep the sodium in the body as much as possible without peeing it all out or chasing your tail. So that only makes sense if it's in conjunction with hypertonic saline. And I think that's precisely why it says in conjunction with hypertonic saline. So then what is DDAVP? DDAVP is the synthetic. It's a less potent vasopressor, but it is a more potent antidiuretic. And it's also effective in head trauma patients that develop diabetes insipidus where they're peeing too much as a result of hypothalamic damage. So it restores the kidney's function to retain water when needed. ADH is also known as vasopressin, also causes the kidneys to retain water. It's a defense mechanism where the body is experiencing a low blood volume or higher concentrations in the blood. Diabetes insipidus is an impairment of ADH release. So diuretic, not diabetic, diuretic-induced hyponatremia, almost always due to thiazide class like HCTZ. Well, that was a big one because sodium is such a key electrolyte. Not all of them are going to be that many slides, but potassium is going to be a lot because potassium is also a key cation. Normally, a very narrow therapeutic range, 3.5 to 5. In fact, most labs say 4.9 is their cutoff. One of the primary cations, and remember, K is the primary intracellular cation in the cells, is the key electrolyte for cardiac dipole, cell metabolism, and protein productions. Anything more than 5 is hyperkalemia. Causes can be excessive potassium supplementation. And what's one of the culprits of potassium supplementation in your diet that most people don't even realize until they do it to themselves? Like what in the diet, like not bananas. I mean, it could be, I guess, but you have to have a lot of bananas.
It's not like Tums? Yeah, yeah.
It's salt substitute. So the doctor says, hey, you've got too much salt intake, your blood pressure is high, you need to cut out your salt intake, but use a salt substitute instead. So you've seen this product called no salt, so it's salty, but it's not salt. It's potassium iodide is what it is. And so people will put this no salt all over their broccoli thinking they're healthier, and they just put it on everything, and they're just eating pounds of potassium. And they accidentally give themselves hyperkalemia from all the salt substitute that they're using. But that's where the excessive potassium supplementation comes in. Crush injury, tissue necrosis, Rhabdo, another significant source of hyper K. What's the mechanism of that?
Lysis of the cells, so intracellular potassium becomes extracellular.
Yep. Remember, we just said that potassium is the major intracellular cation, and when you destroy all the cells, the potassium has nowhere to go but your blood. So rhabdo, crush syndrome, our USAR medics are very good at recognizing and treating crush syndrome. Now they say succinylcholine administration causes increases in calcium. Yes, but it's small and it's transient. There's this fear about giving burn patients that you're intubating. You just pulled them out of a house fire and you need to intubate them, and like there's this fear about giving sucks to a burn patient, and that really doesn't, that's not true. You should avoid depolarizing NMBAs in burn patients like they've been in the hospital for several hours, certainly like a day or two, and then you're transferring them and you need to intubate them for whatever reason. Yes, then you probably want to choose a non-depolarizing, but acutely it should be fine to give it.
Can you just put a line through that, because it's been debunked. When
Yeah.
these slides were made a few years ago, it was a big deal, but now it's basically debunked.
Yeah.
It's already got to be hyperkalemic.
Yes.
So why don't we put a line through that, guys? It's not really important anymore. It's pretty safe to give succinylcholine as long as you're starting off with a normal K. You're
Yep.
not going to cause hyperkalemia just because you gave sucks. So that's been debunked.
I would totally agree with that. Another little known fact is that metabolic acidosis can cause an intracellular potassium shift into the blood from cells as well. And you can be a little hyperkalemic from metabolic acidosis also. Because when you have an increase in hydrogen ions in the blood because of acidosis, as a buffering mechanism, sometimes the hydrogen will be shifted into the cells, but then this causes the potassium to be expelled into the bloodstream as well. Now, the other theory is that at a significant enough acidosis, what's going to happen to the cell itself? It can lyse the cell, the acidosis can destroy the cell explodes, and where does the potassium go? In the bloodstream. So it's a double whammy. So acidosis, hyperkalemia, that kind of can go hand in hand, so just know that. Unlike sodium, where there are no EKG changes with hypernatremia, with potassium, there is a change in the EKG tracing, or they can be. It's not always diagnostic for hyper K, but when it's present, then you want to be aggressively and early on treating that with EKG changes. And that number one thing is going to be calcium, either calcium chloride or calcium gluconate, one of those. Here are some of the changes, and I will say this, that the EKG changes are also very often related to the speed at which the abnormality occurs. So just know that if someone suddenly goes from a normal potassium or for whatever reason, you can see some of these changes. But I've seen nursing home patients come in with a K of 8, but it probably took weeks to get there for whatever reason. And they had a relatively normal looking tracing, surprisingly enough. And that's because it just took a long time. But later on in the, at the end of the semester, if you choose to participate in the live tissue lab, you'll see during the terminal phase, the EKG changing right before your eyes, just widening out, then they go into asystole with potassium. And so it's much more, just like acute hyponatremia is far more dangerous than the slow hyponatremia is, acute hyperkalemia is far more dangerous than a slow, indolent kind of hyperkalemia development. Just know that the higher you go, the more wide the complex becomes. What's a sine wave? Yes, right. When you talk about math and physics and that's how about the sine wave, a sine wave is more like just an undulating line that's smooth like that. You begin to lose the characteristic markers of the QRS complex the higher you go. Basically, this is a pre-terminal event. So when you see this, they are fixing the code. You need to fix that right now or you'll have nothing to fix. So this is where you get calcium in as soon as you can, lots of it, until you see the QRS complex narrow up. And I've seen the QRS complex like narrow up in front of my eyes as you're pushing the calcium. That's exactly what you want. Keep going till you see it actually narrowing up. And then you're going to try to get rid of it as well. So that's cardiac membrane stabilization. That's the number one goal of hyperkalemia treatment, especially if there are EKG changes, is cardiac membrane stabilization. The second thing you want to do is shift the potassium out of the blood back into the cells where it belongs. And the third is removing the excess potassium completely from the body. Those are the three-pronged approach to hyperkalemia management. So as we mentioned, calcium stabilization, cardiac stabilization with calcium, really, if they don't have very many EKG changes, if at all, and they're just hyper-K, I won't necessarily give calcium, but I'll do the other two things, shifting it back in the cells and getting rid of it out of the body. But definitely, if there is any EKG change whatsoever, I'll give calcium. Remember, there's a 3-to-1 relationship between calcium gluconate and chloride, meaning which has more elemental calcium in it, gluconate or chloride? Chloride does. It takes 3 grams of gluconate to give as much elemental calcium as the chloride. So you just have to remember that. Now, why do a lot of protocols favor gluconate over chloride, though, in the EMS setting especially? No, you're close, though. It's not about, you do wonder about crystallization when you're giving calcium and bicarb together, yes. But they both crystallize. What is, it's because in the EMS setting, we rarely have central line access, but we do have peripheral IVs. And calcium gluconate is much more forgiving. It's not nearly as caustic as calcium chloride. If you mess up with calcium chloride and it extravasates into your tissues, that can cause significant tissue necrosis and problems. This is not to say that you can't give calcium chloride through an antecubital. Just make sure that it's a good patent vein and it's flushing well, and hopefully a large bore IV and vein. You just have to be careful. So in the EMS setting, if you can give calcium gluconate, we'd rather that than calcium chloride just because it's more forgiving than calcium chloride. Okay? So on USAR, we're trying to stock calcium gluconate because we'd give lots of it for crush syndrome, for example. The potassium shifting medications are things like insulin, which will drive potassium back into the cells. It takes the extra, it does not lower the total amount of body potassium, it just takes it out of the extracellular space where it's most dangerous. Now, we always talk about giving glucose with it. That's because, obviously, unless you're starting hyperglycemic, you're going to make them hypoglycemic. So we always give the glucose with it and check their blood sugar. 10 units of insulin will decrease the potassium by up to about 1 milliequivalent per liter. So you would expect to give quite a bit if you had a long ways to go, but giving insulin on top of cardiac membrane stabilization, et cetera, should in tandem work together. Then the potassium shifting medications, this is where we're trying to, we're still trying to shift K in the cells along with insulin. Albuterol does the same thing. This is precisely why kids who have been in status asthmaticus, they've been getting NEB treatments all night long. You really do have to pay attention to their K because they can get significantly hypokalemic accidentally. Okay, so Lasix also helps through renal excretion, although also with IV fluids to help dilute potassium in the bloodstream, increase renal flow to pee out the potassium more, and sodium bicarb and K-oxalate. Also, K-oxalate is a binder that helps to get rid of it through the digestive tract, although it actually doesn't work as well as people thought it did. The new binder, however, that excretes it in the third method of getting rid of potassium is called Lokelma. Get it, low K, get it? So Lokelma is sodium zirconium cyclosilicate. It's an oral suspension that works in the digestive tract as well. Doesn't go through the bloodstream, but it binds whatever in the GI tract and gets rid of it that way as well. Supposedly works better than K-oxalate. And honestly, remember, the reason why EMS dwells on calcium, insulin, albuterol, and binders like Lokelma is because that's all we can do in the field. But remember, this is just buying time. If someone truly has a life-threatening hyperkalemia with EKG changes, they need dialysis. So the hemodialysis is the definitive management for hyper-K. It's rapid. You can get a significant amount of potassium out of the serum very quickly, and it works. Everything else is just a temporary fix. Okay. Something that Josh just mentioned that I forgot is calcium, bicarb, they are incompatible IV-wise. Just remember that. So the USAR medics know this very well. If you're going to give calcium and bicarb, which they often do, then you either want to make sure, if you only have one line, that you're flushing a lot in between doses, or ideally you just have 2 separate lines. Don't even give calcium and bicarb in the same line because it'll make yogurt, which is bad. So don't do that. Okay, hypokalemia, not nearly as immediately life-threatening as hyperkalemia. Hypokalemia can cause a metabolic alkalosis, ironically, by shifting too much potassium into the cell, which will shift hydrogen ions into the bloodstream. Hypokalemia is relatively common among hospitalized patients, but excessive diuretics, GI losses, laxative uses, that's actually the more common causes of hypokalemia. And there are actually EKG changes with hypo as well. Instead of peaked T waves, what you're getting is U waves that you can see. Sometimes you get a prolonged QTC and ST depression, but really it's the classic little U waves that you see here. T, U, P, there's the P wave there. I cannot say, I think maybe one time have I ever seen U waves from hypokalemia, but maybe once. I mean, I can't really ever recall seeing it very commonly, if at all. So the treatment of hypokalemia is replace the hypokalemia. So you can give oral potassium supplements, or if it's severe, like less than 2.4, they'll often get a K-run, what's called a K-run, or an IV infusion of potassium chloride. So about 5 to 10 milliequivalents per hour, very slowly. It can take hours to complete. Usually if someone is that hypokalemic and they need an infusion, I'll just admit them to the hospital because it takes so long. And they need repeat checks. And of course, IV potassium is a little dangerous, and so we just monitor them really closely while they're getting their potassium supplementation. Doing okay? We're at the top of the hour. Should we keep going? All right, let's keep going. They're not all this long. So chloride, one of the major extracellular anions in the body, responsible for maintaining electrical neutrality by offsetting the positive charges of sodium and potassium. Remember, we talked about sodium and potassium as cations. So chloride is your major extracellular anion to kind of balance this out. Chloride is also an important means by which the kidney concentrates urine. Hyperchloremia is defined as a CL level more than 105 milliequivalents per liter. It's usually as a result of a chloride overload, like too much sodium chloride IV, like when you're treating DKA. Remember, when someone clinically presents in DKA, how many liters fluid are they typically behind already? 1 or 2 liters, 5 or 6, 7, 8, 9, 10? It's way more than you think. By the time someone clinically presents in DKA, they are about 7 to 9 liters behind. I mean, they're like raisins inside. They really are. Because they're just peeing, they've lost so much fluid. So you can get a little hyperchloremia from that. So you can also get from a loss of bicarb from GI and urine losses. You can get a hyperchloremic metabolic acidosis, someone who's really having a really bad stomach virus or something, and they're losing lots of GI and urine losses of fluid. On the other side of the coin, hypochloremia is less than 95 milligrams per liter. Seen in patients with impending renal dysfunction. Just remember that chloride and bicarb are inversely related. And speaking about bicarb, when we look at the BMP and we're measuring CO2, that is the reason why bicarb is kind of in parentheses is because it's a surrogate marker, knowing that CO2 and HCO3 are in equilibrium in a venous blood sample, but you're not actually measuring your bicarb. What you're measuring is your CO2, but because they're basically in equilibrium and equivalent, If you can measure one, you know what the other is. So just don't be confused. You're not measuring like actual CO2 at all. CO2 is a gas measured in your ABG, VBG. It's just that because in a venous sample they're in equilibrium, you use one as a surrogate for the other. Make sense? This is the chemistry equation for that equilibrium. CO2 and water, bicarb, which almost immediately gets dissociated into HCO3 and hydrogen again. And they're constantly kind of in equilibrium. This is why giving bicarb in patients who are acidotic is not routinely in protocols, because it's not going to stay, it just rapidly dissociates once it gets into the bloodstream. So if you give someone an amp of sodium bicarb, you'll see their end tidal go way up for about a minute and a half. And then it'll come down again because it just dissociates the CO2 and water again. Okay. So what then is the usefulness of this lab value? Well, it can kind of help you decide whether they have an acidosis or an alkalosis without actually getting an ABG. It gives you some idea of that. The BUN, or the blood urea nitrogen, together with creatinine, is clinically useful because it kind of tells you renal function. The BUN normally is 8 to 22 milligrams per deciliter. Urea, or NH3, and water, which is formed in the liver and reabsorbed or excreted by the kidneys, which is why BUN is one of the markers of kidney function, is the biggest clinical utility to measuring BUN. BUN is more a measure of protein metabolism and excretion of that waste. With creatinine, BUN can be a marker of kidney function or lack thereof, because that is the organ that excretes BUN. BUN levels naturally increase as we age, just because clearance is affected as you get older and GFR decreases with age. Decreased levels of BUN can indicate malnutrition or overhydration. Increasing levels can also conversely mean dehydration, renal disease, or burns because of increased protein breakdown. Remember, we said BUN is a marker of protein catabolism or breakdown. When you combine that with creatinine, take note, is not the same thing as creatine. I actually see this relatively commonly in medical notes. It might be a typo, I don't know, but creatine and creatinine are not the same thing. What we're talking about on a BMP is creatinine. Okay? Creatine is a nitrogenous organic compound made of 3 different amino acids. It plays a role in energy production in muscle, but creatinine is a waste product of creatine breakdown. Follow? So creatine is the stuff that bodybuilders take to help with muscle building because it gives energy production for muscles. But creatinine is a waste product of creatine breakdown filtered out by the kidneys. Now here's the interesting thing. I can always tell, one of my jobs is to review the post-offer employment physical exams of our police officers in the county, and I can almost always tell who the ones are that are taking creatine supplements, because they always have a touch of renal failure. Like for a normal, healthy 25-year-old dude, you should not have, your estimated GFR should be well over 90. They should be chugging along and filtering great because they're young and healthy people. And their creatinine should be like 0.8. But I've seen guys coming in with like creatinine at 1.4, 1.5, which is awfully high for a young person who's entering the police force. And I'll contact them and I say, let me guess, you're on creatine supplements. Yeah, how'd you know? Well, because your kidneys are being boxed by this. It's a huge load. I said, there's nothing wrong with taking creatine supplements. You just have to make sure that you're drinking enough fluid to keep your kidneys flush. So if any of you are weightlifters taking creatine, that's fine. You just have to drink a lot more water to make sure that it's being flushed. It's not a bad idea to get your levels checked as well with your doctor if you're going to be taking lots of creatine. So because creatine is filtered by the kidneys and is a direct marker of kidney function, creatinine is often called the troponin of the kidneys, because if it's elevated, just like if troponin is elevated, something's wrong with the heart. If the creatinine is elevated, something wrong with the kidneys. So It's very sensitive to kidney function, and if you know that BUN is measuring protein breakdown, which is then filtered by the kidneys, and that creatinine is looking at muscle breakdown, which is also filtered by the kidneys, then abnormal readings will indicate kidney dysfunction. So BUN and creatinine, therefore, are often looked at in tandem as markers of how well are your kidneys working. The ideal BUN to creatinine ratio is about 15 to 1. If it's less than 15 to 1, like if it's 9 to 1, that's a low ratio. If it's high, like 50 to 1, that's a high BUN to creatinine ratio. And that ratio, clinically, you're asking, well, what does that have to do with me as a critical care paramedic? I'll tell you, it can help you understand what the underlying pathophysiology is. So let me ask you this. If the BUN is 18 and the creatinine is 1.1, what is the BUN to creatinine ratio? Well, if 18 to 1, you know it's 18. So 18 to 1.1 is probably less than 18, which is good. It's actually 16.36. So then, how do you use that number clinically? Well, if you know that the BUN creatinine ratio is between 10 to 20 to 1, which this is, that's normal, right? What if I told you that that ratio was not normal, that in fact, well, the overall BUN is elevated, the creatinine is elevated, but the ratio therefore is neutral, it's fine. What if I said that the BUN is 40 and the creatinine is 2? Is 2 a normal creatinine? No, that's high. That's technically in renal failure, right? But what's the ratio of 40 to 2? 21. Is that within the normal range? Yeah, actually, because that's 10 to 20. Ideal is 15, but up to 20 is normal, okay? But both BUN and creatinine are elevated, but with a normal ratio, that suggests a post-renal failure. What does post-renal failure mean versus pre-renal? No. Post-renal means, post meaning after. So that means that the problem is not the kidney, the problem is after the kidneys. So if you have post-renal failure, that means the kidneys are fine, but something after the kidney is causing a dysfunction. Think about the kidneys as an engine, and that engine needs oil. In this case, what is the oil for kidneys? Blood. Blood and water. It's flow, perfusion. Right? That means something after the kidney is making it not work very well. You ever see that movie where Eddie Murphy sticks a banana in the tailpipe, and the bad guys try to follow him, and the engine, they don't know he stuck a banana in the tailpipe. And the car, he runs, he says, bye, and he runs off, and they try to go chasing after him, and the car goes, and it sputters and dies. Was there anything wrong with the engine? The engine was fine. What was wrong? The tailpipe was blocked, the exhaust couldn't come out, it backed up and made the engine sputter and die. Same with the kidneys. So the kidneys are fine in post-renal failure, but what is something after the kidneys that can block up urine into the kidneys and back it up and make it sputter and die? Like an obstructive stone. How about in dudes? Prostate enlargement, right? They can't pee, they got urinary retention. So the kidneys are fine, it's making pee, and then all of a sudden it gets stopped up, right? So that's what's causing an obstructive uropathy and the kidneys to sputter and die, just like the banana in the tailpipe, right? What if the BUN is elevated, but the creatinine is normal? They're hypovolemic maybe. What might that be from? I could even tell you, I can even give you this. I can give you that the creatinine is elevated a little bit, but the BUN is elevated even more maybe. So the ratio is like 50 to 1 instead of 15 to 1. That's usually, an elevated BUN to creatinine ratio usually suggests a pre-renal failure. What does that mean? If post means nothing's wrong with the kidney, it's just something after the kidney is making it fail, pre-renal means what? Nothing's wrong with the kidney, but something before the kidney is making it fail. So in this case, it would be like the engine is fine, but you just drained all the oil out of the oil pan. Now it seizes up, right? Your kidneys are fine, but you drained all the oil or blood out of the oil pan. In other words, kidneys are fine, but the blood's not flowing to it. What could be that from? You get renal artery, severe renal artery stenosis, can cause that. Pre-renal failure, what else? Yes, really, really bad heart failure can sometimes, there's just not enough flow to the kidneys get ischemic. What's the most common cause of pre-renal failure? Not quite. That would actually be an intrinsic problem, is chronic hypertension. How about trauma? You roll up on a roller MVC, and their pressure is 60/30, and who knows how long they've been hypotensive. You come screeching to the rescue, you give them blood, they wake up, their pressure is now 90, and they're much better, and you get to the hospital, and they live, yay, yay, and then 2 days later, they're on dialysis. But there's nothing wrong with their kidneys. Kidneys weren't injured in the rollover MVC. That's a pre-renal failure because they were hypotensive for so long. They hypoperfused. The kidneys just did not get any blood, and they went into renal failure. The good thing about that kind of pre-renal failure is just by giving them blood and keeping the blood flowing to the kidneys, hopefully it can come back, and they can be off dialysis. Sometimes, though, it's permanent. So now, if the BUN creatinine ratio is low, the BUN is normal, but the creatinine is high, it cannot filter out all that muscle breakdown from rhabdo. That's like an intrinsic renal failure. That means the kidney itself is damaged. The kidney itself is diseased. It's all the nephrons are plugged up with protein molecules, globulins, and it can't function. Okay? Or chronic hypertension has caused a hypertensive nephropathy, and all the nephrons have sclerosed because of the constant 200 systolic blood pressure. And now the engine is damaged, the kidney is damaged. Okay? If the BUN is low, but the creatinine is normal, and your ratio is also decreased, maybe that's low dietary protein. There's no protein to break down. Maybe it's liver disease. So this is kind of how you can use the BUN creatinine ratio clinically to understand, does my patient need fluids or blood, or is this something wrong with the kidney itself, or do I need to put a Foley in and relieve this urinary retention, this basketball-sized bladder, and let them pee so their kidneys can function more properly again? That's what's going to help you. Okay. Finally, glucose. Glucose is the primary energy source for all cells, combines with oxygen to complete a process called oxidative phosphorylation for ATP production. We're going to spend a lot of time on this in just a few minutes. Normal value, 70 to 110. I don't think we have to go through glucose very much longer. Y'all are experts at that, okay? Calcium. Total body calcium is roughly split 50-50 into bound and unbound calcium. Now, this is something that's pretty important for you to understand, because bound is usually bound to what? When we say about 50-50, 50% of your calcium is bound, 50% is free or unbound, which one of those types of calciums do you care about? Which is physiologically active? Unbound or bound? Free or tied up? Free. We care about free calcium, ionized calcium. That's the calcium that's doing the work in your body. The rest of the calcium is bound up to proteins. What protein is it usually bound up to? Albumin. Now, it can also be bound to other things like some phosphates and other organic groups, but it's mostly albumin, okay? So unbound, free ionized calcium is the active form of calcium. I guarantee that's a test question. So you should know that the business end of calcium, the 50% that you care about, is the ionized free calcium, because that is what is responsible for cardiac contractility, neurotransmitter release, action potentials, in other words, smooth muscle contraction, vasoconstriction. Free calcium is what helps the pancreatic islet cells trigger insulin release. So ionized calcium is what you really care about. Okay. So if I get, what is the calcium that's measured in your BMP? This is a good question as well. When you get a calcium level on your basic metabolic profile, is that total calcium or free calcium or bound calcium? It's total. So if I really want to know what the important calcium is available to my patient, I'm going to order an ionized calcium, which is your free, unbound calcium. The parathyroid controls calcium levels, so abnormalities may be related to parathyroid dysfunction. In a few weeks, when we do endocrine emergencies, we'll talk all about the parathyroid function, okay? But right now, just remember parathyroid, calcium kind of go together. We talked about the 3 categories of, well, 2 categories, free and bound. The bound can be bound to protein or bound to other compounds. I guess you could say a third would be chelated forms, 10%, just means bound to other compounds, okay? But really it's free and bound. Normal values of calcium on your BMP is going to be 9 to 11 milligrams per deciliter. What I care about is that the ionized calcium is about 4 to 5-ish milligrams per deciliter. That's what I want to see in an ionized calcium lab, okay? You should know that if you want to know total calcium, you can get that on your CMP. But if you want to know ionized calcium, that's shown on the ABG typically. All right, live quiz for calcium. Ionized calcium measures A, B, C, or D? Yes, your free and unbound calcium. Ionized calcium is the calcium level that you really care about. Hypercalcemia is defined as more than 11 milligrams per deciliter. Mostly see, it's relatively rare, so hypercalcemia you shouldn't see that often, but if you do, it's almost always going to be some disorder of the parathyroid gland or in cancers, okay? Why cancers? Because cancers often metastasize to bone and eats the bone, and where does all that calcium from the bone goes when it's eaten? Blood. Just goes in the bloodstream, okay? So hypercalcemia. Treatment, IV fluid boluses and calcitonin, which augments getting rid of calcium through the urine, okay? Hypocalcemia is the one that clinically you'll probably see more often as a problem. Calcium less than 9 milligrams per deciliter might be because patients who got a massive transfusion protocol because of the massive blood transfusion, the citrate that's in the blood as a preservative, the calcium binds to that preservative. So not only do we often give calcium to patients who are getting blood because of that, but also because calcium itself is can be a vasoconstrictor, right? It helps with smooth muscle contraction, et cetera, helps with vessel tone that you want to help if someone's bleeding to death, okay? Dysfunction of the parathyroid, pancreatitis, these can also cause hypocalcemia. The problem is this can cause paresthesias, muscle tetany, and even seizures at times. And so what's the treatment for low calcium? Calcium. So calcium gluconate, calcium chloride. Schwaztek's sign is a classic test question that is contraction of the facial muscle when you tap the facial nerve just anterior to the ear. So if you tap the facial nerve just anterior to the ear where you're seeing there, you notice how the corner of his lip just kind of twitches up all the time when he gets tapped? That is Schwaztek's sign, which is classic for hypocalcemia.
Stupid question, but do they have to be conscious for that to display?
I don't think so. It's just a reflex, yeah, so they can be unconscious, I guess, yeah. Yeah, because they're not consciously twitching, it's a reflex. So the other one is Trousseau's sign. If you squeeze the BP cuff all the way and occlude the brachial artery, you notice how the hand is like going into tetany and contracting like that. They're not doing that voluntarily, that's involuntary contraction of the forearm muscles. That's Trousseau's sign, which is also characteristic of hypocalcemia. Hypocalcemia is associated with an EKG change, and that is a prolonged QT. Our USAR medics know this because crushed muscle absorbs not only a lot of fluid, but it also absorbs a lot of calcium. And crush syndrome patients can be victims of hypocalcemia as well, but also hyperkalemia, right? So one of the classic EKG findings that our medical specialists are trained to look for is the tent on a desert. So the tent is the peak T wave from the hyper-K, and the desert is the prolonged QT. So you get this QRS complex, and there's this long QT, there's your desert, then there's this tent out there in the desert. So that's from advanced crush syndrome. They've got hypocalcemia and hyperkalemia. Mag is another very important electrolyte to know. Mag levels are usually in tandem with potassium levels. Magnesium, however, is not part of a standard basic metabolic profile. So if I have someone with hypokalemia very often I'll also add on a magnesium or phosphorus level to see if that's also needs supplementation. Mag is a CNS depressant and a vasodilator, so one of the treatments for preeclampsia, of course, is mag sulfate, and if you get too much, they can lose their vascular tone and muscle tone, and so if they get hyper mag and you're not paying attention, they can also go into respiratory arrest. So they should be closely monitored if they're on a mag sulfate drip. Okay? Mag can also be used as a bronchodilator for refractory reactive airway disease, also for polymorphic VTAC, better known as torsades. Just remember that because it's a CNS depression, it can also cause altered mental status, hypotension. What is the reversal agent for mag overdose? Calcium and dialysis. Phosphorus is not the same thing as phosphate. Okay, we are measuring phosphate in the blood. That's an anion composed of phosphorus and oxygen. Phosphorus is composed of only phosphorus without the oxygen. So just remember that we're not measuring phosphorus, we're measuring phosphate. Phosphate is located primarily in the bones and the cells, involved in the metabolism of carbs, proteins, and fats, and essential in the storage and utilization of energy, calcium regulation, and RBC function. The last lab value we're going to look at is lactate. Lactate, as it relates to lactic acidosis. Now we've been here for an hour and a half. Want to take 5? This next block is a big block. So go pee. Make sure you don't get post-renal failure. Come back in 5 minutes, please. We only have 90 minutes left. Just over an hour, a little over an hour to get through the home stretch. You doing okay? I know these are long days, my friends. I know. And just a lot of material to cram in. Stay with me. All right. This last bit, the last lab we're looking at, lactate, as it relates to lactic acidosis. Let's talk about this a bit. Lactate is considered one of the best and most readily available lab markers to assess a patient's oxygenation. Let me emphasize that. It is not as accurate to say it is a measure of perfusion. It is a measure of oxygenation. I make this point because a lot of textbooks and a lot of people will talk about how lactate is a measure of perfusion. It kind of is, kind of like CO2 and bicarb are surrogate markers of each other because they go hand in hand. This is why a lot of people say lactate is a measure of perfusion. But I'm going to try to convince you that lactate is a better measure of oxygenation, more than they're related, okay, but they're not the same thing. Hold on to this thought because we're going to go through the chemical nature of it and you'll see why in a minute. Normal values of lactate are not 0. It's 0.5 to 2 millimoles per liter. So why is it not 0? There's always lactate is a measure of cellular respiration. I hope it's not 0. If your lactate is 0, you're dead. Okay, so you have to have some level of anaerobic metabolism and just cellular respiration. So it's never 0. Very good. So if you understand this diagram, it will be much easier to understand everything else we're about to talk about. And later on this semester, when we talk even more detail about oxidative phosphorylation and ATP production and everything else, we're going to visit this again, okay? But understanding this diagram is essential to everything else we're about to talk about in the next hour. So let's spend a little time here, okay? Without the cell, there is no life, right? The functional unit of all life is the cell. The cell is made up of a phospholipid bilayer membrane that contains all the stuff inside of a cell. There's lots of stuff in the cell, but what we're going to spend time on today is this funny looking squiggly bean, which is what? The mitochondria. And of course, you remember from high school biology, mitochondria is the warms my heart. Warms my heart. Yes, the mitochondria is the powerhouse of the cell. It was almost like in unison, Chief. Now, let's see if I can get you here. What's unique about the mitochondria that's unlike anything else in your cell, in your body? Interesting trivia question.
I was going to say something, but it's something about the nucleus or something?
No, it's an organelle, so it is not part of the nucleus, correct, but so is the Golgi apparatus and everything else, right? So the unique thing about the mitochondria is that unlike everything else in your body, which is half from dad, half from mom, the mitochondria only comes from you got a 50-50 chance here. Mom, mom, okay? So you have your mama to thank for the powerhouse of the cell, which is the mitochondria, because 100% maternal. So when you talk about energy production, this is also a favorite test question. You got to know this factoid, okay? The whole process of glycolysis in normal aerobic metabolism with oxygen present, glycolysis, Krebs cycle, electron transport chain yields how many ATP? 38, okay? 36 ATP comes from oxidative phosphorylation in Krebs cycle, but 2 already come itself from glycolysis, which makes 2 ATP all by itself, okay? Which doesn't seem like much, but it's essential. It is a significant source of energy still. 2 ATP may not seem like a lot until you multiply that by billions and billions of cells, right? So it does produce energy, not the 36 that oxygen does, but still it's something, okay? So remember 38, remember 36, remember 2. Guarantee you'll see it again here and on your IBS-C test probably, okay? In some way, shape, or form. Notice the glycolysis starts in the cytosol. What's the cytosol? Yeah, the cytosol is just, you know what I'm going to do for next year is have a picture of just the cell itself and show the pieces, the nucleus, the Golgi complex, the mitochondria, all these other organelles, the cytosol, which is just a jelly inside of the cell, okay? We have the phospholipid bilayer, which is the membrane, the cell membrane itself, right? And then we've got the nucleus in the middle of the cell. We've got all these little dots of stuff in the cell like the mitochondria and the Golgi complex. Well, that's all floating around in cytosol, okay? So the cytosol is the fluid environment inside of the cell. Once glycolysis happens and pyruvate is made, you got your 2 ATP. In the presence of oxygen, that process then goes into the powerhouse of the cell. It's the powerhouse of the cell because that's where your 36 out of 38 ATP gets made. So acetyl coenzyme A or acetyl-CoA enters Krebs cycle, makes 2 ATP. The electron transport chain makes 34. And together, plus the 2, you've got 38 ATP. So that's a lot, okay? Without ATP, you're also dead. You have to have energy to run everything in your cells and your body, okay? So now you kind of understand the basic schematic of how we make energy, how we live, essentially, how cells make energy and where it happens. Lactate, we're going to discover why lactate is a measure of oxygenation, not just perfusion, in a moment. But speaking about a lack of perfusion, what is the definition of shock? What is the best definition of shock? Inadequate respiration. What do you say? Low perfusion. Low oxygen perfusion. None of these are wrong. Anyone else have definitions of shock? Give a stab at it. Solomon, you want to give a stab at it? You're going to say, they took yours, didn't they? Man. Yeah. Oh, geez, you gave it away.
Nobody answered.
That is true. Okay, yeah, you could have read it, I guess. So here's what I was hoping somebody would say is low blood pressure, a pressure less than 80. I hear that a lot, actually. Like, what's the best? Oh, it's got to be a pressure less than 80. And the reason why none of those are completely wrong, but they're not the best definition, is because can you give me an example of someone in shock whose blood pressure is 120? Like, they're well perfused, but they're in shock. Give me an example of that. Heart rate of 140. I'm not talking about shock index. I'm talking about shock. Respiratory failure. Well, maybe. No, that is a type of distributive shock, but firemen should know this one. An example where someone's blood pressure is okay, but they're in shock.
They're compensating with SDR, so the smaller the arteries are, they're trying to use it.
You gave the answer away again.
This is the genuine problem solving.
Okay, Captain Law, you can't answer anymore. Okay, CO poisoning, right? Carbon monoxide poisoning. They're pink and warm and well perfused, but you just pulled them out of a house fire, and they've got significant carboxyhemoglobin. They've got CO poisoning. Their O2, their pulse ox says 100%, right, which you know is completely unreliable in CO poisoning. But you're like, a lot of people can miss that because they're pink and warm, and the pulse ox is great, but they're like shocky, and they don't understand why. Well, why are they in shock? Because CO is attached. It's basically is carbon monoxide a simple asphyxiant or a chemical asphyxiant? It's a chemical asphyxiant because it's altering the body's ability to use oxygen. It has nothing to do with the presence or absence of oxygen. It's the body can't use what oxygen it has. Okay, a simple asphyxiant is what? It's like carbon dioxide or halon. Right, that's how the halon gas extinguishers work in buildings. Like you can't put water in a computer room. It would ruin the computers, but you can put halon gas in there to put out a fire because it just displaces all the oxygen. Right, so that's a simple asphyxiant, something that displaces the oxygen. Carbon dioxide is a simple asphyxiant, right? But CO, carbon monoxide, is a chemical asphyxiant because it physically makes it impossible for plenty of oxygen in the air to bind to the hemoglobin, and it suffocates you that way. That's why the best definition of shock is hypoxia at the cellular level. Because no matter if you're looking at anaphylactic shock or cardiogenic shock, neurogenic shock, hemorrhagic shock, it doesn't matter. The final common pathway is the cell is not getting oxygen. So hypoxia at the cellular level is truly the best singular definition of shock. Okay, all the common pathways run through there. Now, with that whole setup, this should make more sense then, okay? Now, this is in your notes. I know it looks incredibly intimidating, but you will be able to completely understand this by the time we're done, okay? Let's start here at the top. Glycolysis. You already know from our little diagram at first, right over here, right, that we're in the cytosol. We're making a little 2-ATP, and in the presence of oxygen starts this whole mitochondrial chain, okay? This is simply the really detailed version of that, okay? Glycolysis at the top, actually, to be technical, makes 4-ATP. That's the payoff phase, is 4-ATP. The investment phase, however, spent 2-ATP. Over here, you see that 2-ATP makes ADP, helps glycolysis, but in the end, you go back up, you can see the 2-NAD and 4-ADP makes 4-ATP. But 4 minus 2 is 2. So the sum totality of energy in glycolysis is 2. You make 4-ATP, but you only get 2 out of the deal. You invested 2-ATP to make 4-ATP, so you end up with 2. Okay? Usually, in the presence of oxygen, that pyruvate enters the aerobic pathway. This circle here is called Krebs cycle. Krebs cycle is also known as the citric acid cycle, which generates, its primary purpose is to generate NADH and other cofactors to run the electron transport chain, which is where you get most of your energy from. That's why it's so important, okay? So Krebs cycle, making more cofactors and energy to enter into this thing, the electron transport chain, or oxidative phosphorylation, which is where most of your energy comes from. You follow so far? You don't need to know all these other little cofactors. When I took biochemistry, I had to actually reproduce this whole thing from memory. You don't have to do that. That's the good news. You just have to understand the basic premise, which will simplify even more there, okay? But I just wanted you to see the whole thing from a 30,000-foot perspective. You follow so far? Okay. If you also notice on your page, you'll notice that carbon dioxide is a byproduct of Krebs cycle. We know that CO2 is a cellular byproduct of metabolism, which is part of the waste that's generated, right, in cellular metabolism, which is why part of the CO2 that your body is breathing off and getting rid of as you breathe as well. But the primary goal is to make more energy and cofactors to run through the electron transport chain, or oxidative phosphorylation. Oxidative meaning it's using oxygen. Look at all this ATP. You get ATP, you get it. Everybody gets ATP, right, in this whole chain, and that is cellular respiration. Okay? So when you talk about cell physiology, breathing is not the same thing as respiration. Breathing is just breathing. Respiration, cell physiologists describe as cellular respiration. It's the process of making energy and the byproducts of carbon dioxide. That's cellular respiration. You follow so far? Okay, good. Now, in the absence of oxygen, it never enters the mitochondria because there is no oxygen to make the electron transport chain. It stays out in the cytosol, and it's going through the anaerobic pathways. Now, this particular diagram is showing two ways to get energy, or ATP, in the absence of oxygen. This column over here, lactic acid fermentation. This column over here, alcohol fermentation. This only exists to show you that there is such a thing, making two molecules of ethanol in the process. But if it is easier for you, you can draw a circle around the alcohol fermentation pathway here and just put a little X through it, because that's not in humans. That's in things like yeast. When you're making bread and beer, that's important, right? But humans are not going down the alcohol fermentation route. You are going through this route though, okay? The lactic acid fermentation. Remember the pyruvate we talked about in glycolysis, which is where everything starts, okay? Right here, the pyruvate. Well, in the absence of oxygen, it still plays a role in that it enters the lactic acid fermentation phase and you end up with two lactates. But you also produce NAD, which then goes back to help make your 4-ATP net 2-ATP in glycolysis. You follow? And that just keeps going in a big circle. Okay, so in like, say, your muscles, where there may not, you're on mile 25 of a marathon, right? And man, you are just depleted. And your muscles are relatively hypoxic, and so, but it's still making energy. It's cycling through much of the anaerobic pathway in this case. Okay? So if I now simplify it even more into this diagram, it's basically the same thing, highly simplified. Let's just go over the exact same thing one more time. Glucose, your primary energy source. Glycolysis happens. Whether you have oxygen or not, glycolysis is step one. There's no oxygen needed. You get 2-ATP out of it. Glycolysis makes pyruvate, which is needed for both oxygen and anaerobic, as you saw from the first diagram. Okay? In the absence of oxygen, it just keeps making pyruvate and lactic acid with your 2-ATP net. You following so far? This doesn't even exist because there's no oxygen. Okay? But this just keeps going. No O2 needed, glycolysis, you get 2-ATP, but you get lactic acid. And the longer you're in anaerobic metabolism, what does your lactic acid level do? It keeps going up, keeps going up, keeps going up, okay? So eventually, you'll get a little bit of lactic acidosis. And as you keep going up, and keep going up, and keep going up, eventually you're gonna be having a high anion gap metabolic acidosis, where it just gets more severe. Okay? The wider the gap, the more severe the acidosis is. Okay? Now, you arrive on the scene, and you realize this person is hypoxic. They're not oxygenating. We're going to fix that problem. You intubate them. You give them high-flow oxygen. You start circulating the blood. You give them fluids. You increase their blood pressure. Perfusion is better, but more importantly, you're introducing oxygen. Now what's the body going to want to do? Use a much more efficient way to make ATP and shift to aerobic metabolism, not anaerobic, because it's so inefficient. Now, when you have come to save the day, and now you're giving them oxygen and improving their status, O2 is present. Cellular metabolism is going to want to shift away from this to this. Now, enter oxygen. Glycolysis is still happening. Pyruvate is still being made, but now far less of that pyruvate is going here, making lactic acid. Instead, that pyruvate is jumping over here through acetyl coenzyme A. Now where are we? Inside the mitochondria or outside? We're in the mitochondria now. We're not in cytosol anymore. We're in the mitochondria, powerhouse of the cell, because that's where all the ATP is made. So now, Krebs cycle, which also needs O2, generates a couple of ATP, which helps. Krebs cycle is now introducing more NAD and NADH and cofactors essential to give chemical energy to drive what? The electron transport chain. The electron transport chain, which also is needing oxygen, that's why it's oxidative phosphorylation, makes 34 ATP right here. So there's the NADH, 3 NADHs made by the Krebs cycle entering into the electron transport chain, along with FAD and all these other cofactors also from the Krebs cycle, with CO2 as a waste product of that energy, chemical energy. That chemical energy gets translated into the electron transport chain called oxidative phosphorylation. Everybody be getting ATPs, and 34 ATPs result from that. So the 34 ATPs plus the 2 from Krebs cycle plus the 2 from glycolysis, and where does this happen? In the mitochondria or the cytosol? Outside in the cytosol, but still it's 2 ATP is 38 ATP total. Make sense? See, now was that so intimidating? No, not at all. Okay, so now you understand the simplified version of how to examine lactic acidosis. So this is why I think lactate is not a great differentiator of where a problem is. You just know that there is a problem if the lactate level is high. Why is that? Well, because unlike troponin, which is only a problem reflected in the heart, and creatinine, which is only a reflection of a problem where? In the kidneys. Lactate is a reflection of a problem, shoot, could be anywhere. I mean, lactate is made in the muscles, it's made in the red blood cells, it's made in the liver as a byproduct of gluconeogenesis. What does gluconeogenesis mean? It's gluconeogenesis is literally making glucose. Genesis, making neogenesis, new creation of glucose is basically what it is. Okay? One of the reasons why alcoholics can be hypoglycemic even if they're not diabetic, because they drink preferentially to eating, right? And alcohol is just empty calories. There's no nutritional value whatsoever. But their liver detects that their blood sugar is dropping. It wants to make some sugar for them because we just found out sugar is the primary fuel source. But it can't because it's cirrhotic. It can't undergo gluconeogenesis. So their blood sugar drops to 30. Okay? That's why they can be at risk for hypoglycemia without diabetes. Right? But anyway, that produces lactic acid. And so the process of inefficient energy production produces lactic acid as its byproduct because anaerobic metabolism is inefficient. It only makes 2 ATP total. Okay? And that's measured as lactate, which can come from skeletal muscle, about 25% from the skeletal muscle. Your skin, technically the largest organ of the body is your skin. 25% comes from your skin, 20% from the red blood cells, 20% your brain. Your brain alone makes 20% of lactate. I mean, the brain is incredibly metabolically active, right? It doesn't rest, it's constantly going, just like your heart. Your brain needs a ton of energy to work. 20% alone comes from the brain. Your GI system, about 10% of your lactic acid. So it's not super helpful of where the problem is, you just know that there's a problem. Okay? So there are 2 different types of lactic acidosis, type A, type B. Type A is from inadequate oxygenation, whereas type B, lactic acidosis, is not necessarily related to oxygenation, but more underlying disease, maybe drugs, inborn errors of metabolism, some toxins. That's type B. And everything on the type B list you should be familiar with, but especially one as a critical care medic, propofol. Why? Because as a critical care medic, you'll be using propofol a lot, right? Propofol is a great anesthetic. Wrap it on, wrap it off. There's some quirks about it though, but one of them is propofol infusion-related syndrome. If your patient is getting more than 60 mics per kilo per minute for a couple of days, about 48 hours, they're at risk for developing propofol infusion-related syndrome, where they can get rhabdo, hyperkalemia, renal failure, high anion gap metabolic acidosis, dysrhythmias. Shoot, they can even have cardiovascular collapse and death from it. So propofol is not an innocuous drug. And ICUs use it all the time, sometimes relatively long term. They just have to be sure that they watch the rate at which they're getting. So they shouldn't be getting anywhere near 60. Most protocols will stop around 30 or 40 at the most, and then add something else, a benzo, opiates, something else if they need more stuff, or just change anesthetics entirely. So just be aware that turning up the propofol isn't always the best thing to do. Just keep that in mind. Okay? As a critical care medic, be aware of type B lactic acidosis from propofol. Okay? But the ones that we probably deal with the most are due to inadequate oxygenation. So things like CO poisoning, cardiogenic shock, boy, you're going to see a lot of that as a critical care medic. Hemorrhagic shock, sepsis, you're going to see tons of septic shock as a critical care medic. So type A lactic acidosis is something that you're probably going to see more of. Okay? And then management. Management of lactic acidosis, when we talk about the fact that it can be from anywhere, you want to try and figure out where that is coming from. Now, if it is systemic, meaning they are hypoperfused, okay, so this is kind of where perfusion is related to lactic acidosis. I get it, because without perfusion, there's no oxygenation. But as you can see from our waltz through cellular metabolism in the mitochondria, can I convince you now that lactic acidosis is a better marker of oxygenation, not necessarily perfusion? Does that make sense? Having said that, I completely admit that a lack of perfusion absolutely can lead to a lack of oxygenation, and a lack of oxygenation leads to hypoxia at the cellular level. So yes, in that regard, perfusion lack of perfusion can contribute to lactic acidosis. I totally get it. But I just want all of you as critical care medics to understand the real root cause of that, which is a lack of oxygen, is hypoxia. Okay? So having said that, though, I get it that if say they're in septic shock and their blood pressure's in the tank and they're hypoperfusing, well, obviously their lactic acid buildup will be substantial because their skeletal muscle isn't getting perfused, brain's not perfused, gut's not, and nothing's perfused. Then yes, all those things are going to contribute to lactic acidosis. I get it. So then what is your mainstay of therapy going to be? What is really the mainstay of therapy for high lactic acid levels? Oxygenation, yes. So typically we'll have them on supplemental oxygen, yes. Not necessarily high flow, but we'll have them on supplemental oxygen. But to get that oxygenation circulating, what are we trying to do? Improve their perfusion, right? And that's okay. But just know that ultimately it's not the perfusion that's saving them, it's oxygenated perfusion that's saving them. Okay? Because I can perfuse carbon monoxide poisoned blood with a blood pressure 200, they're still going to die. Okay? So when we say improve perfusion, we are assuming we're oxygenating them at the same time. I just want you to understand the difference, okay? Because you're going to be critical care medics, so you need to know why. Okay? So now, the mainstay of therapy, therefore, is crystalloid boluses optimizing oxygenation to then shunt the process away from this and shunt it that side to the mitochondria. Okay, make sense? So when we shunt away from anaerobic metabolism and reduce demand, just increasing FiO2 alone won't solve it if we're not getting the oxygen to the cells. Remember, we said it's hypoxia at the cellular level. So yes, increase FiO2, yes, but we got to get it to the cells. And now if we improve flow to the cells without oxygen, like it's still, like I said, carbon monoxide or deoxygenated blood, they'll still die. So yes, it is oxygenation, but perfusing it to the rest of the tissue. And then a very common question, well, what about bicarb? If they're acidotic, we can just reverse the acidosis with bicarb. Well, what did we already see in the chemical equation of bicarb? It almost immediately gets metabolized to what in the bloodstream? Water and CO2, which is why your end tidal goes spiking up as soon as you give bicarb, right? The medical specialists in USAR have also learned this, in that theoretically alkalinizing the urine helps to clear all those globules of myoglobin and creatinine out of the kidneys so that we can flush it out and return kidneys to normal function, yes? So if bicarb can help alkalinize urine and get rid of it, but it immediately gets metabolized, what's the most effective way to keep the urine alkaline then? What do you have to do to keep the steady state up? Start a what? A bicarb drip. So unless you've got a bicarb drip going, it's just not it's pretty worthless. Okay? And that's just to alkalinize the urine. But trying to alkalinize out the acid, lactic acid, with bicarb without addressing the root problem is also pretty futile, right? You can easily reverse the lactic acidosis by improving oxygenation to the cells and shunting away from anaerobic metabolism, back down the oxidative phosphorylation line in the mitochondria. Does that make sense? All right. So 2 decades of studies looking at lactic acidosis and the role of sodium bicarb. In fact, this is relatively recent. This is in the journal Shock back in 2020, so not that old. But they took 2 decades of studies. This was essentially a meta-analysis of bicarb for lactic acidosis. And basically, zero evidence, for any degree of acidemia using bicarb. In fact, they found some evidence of patient harm because of its hypertonicity. Basically, the take-home message from Rudnick et al. Was, don't do it. This is why it's not in any of my protocols ever. It's not in my protocols for cardiac arrest, even though I still see crews giving bicarb during cardiac arrest. I'm like, well, if you think it's from tricyclic overdose or hyperkalemia, fine. But otherwise, it's not doing anything for acidosis. Okay, so day 1, how was it? I know, it was a lot, right? Well, good. I'm glad you think it's good. I personally think it's a lot of fun. I mean, you're beginning to really understand the whys behind why we do things. I think you're beginning to understand what we're trying to do, what all 3 of us as instructors are trying to do this whole semester, is take what you already know as paramedics, but now give you the ability to know the whys behind it. Like, well, why do we do that? Or why don't we do this? What's the physiology, the anatomy? What's the biochemical nature of why we do things? That's what's going to differentiate you between other usual and customary paramedics. And I really hope that you give serious consideration someday to 9664. Okay. Constantly need new people, good people. All right. And at SCAD, if you're a SCAD employee, you should know that even if you don't want to quite go all the way up to single resource, that's fine. We do credential like at a CCL2 level, where you can do a lot of the stuff and fill in a lot of necessary gaps on the road and be a resource on the road. We're really trying to capitalize on the 80+ critical care medics that we have in our stable. And we've always felt like that's such a waste not using them. So I appreciate all the effort that Chief Stewart has put into a lot to writing up, quantifying all the stuff, and him and Nate, helping to run the program. And it's been really, really cool to see. So thanks for that.